Good morning, everybody. My name is Olivier Bertrand. I'm very proud, honored to have you here for the 5th AIM-RADIAL in the beautiful city of Budapest, Hungary. My co-host is Dr. Zoltán Ruza, who is in the cath lab, so I think I will make his welcome address from the cath lab, and I will be very short, but I just want to make very few comments to start. So we have been, as you know, this meeting has been an initiative from my chair, which is located at the University of Quebec, and we have been very privileged this year to work with the Hungarian Society of Cardiology, so it's a partnership, and I want to thank the local organizer, Barbara, and her team, Miss and Boss. So please do not hesitate to ask specific questions. I also brought some members of my research team that probably many of you know for the previous years. I just also want to emphasize some key principles of this meeting. I mean, we have been trying since the beginning to emphasize the evidence-based medicine. If you remember, a few years ago when we started, we were all convinced, at least many of us, about the benefit of a radial approach for coronary intervention. And so we thought at the time that it was a nice concept to have a congress focusing on discussing evidence-based medicine, reviewing the recent evidence. And the program, if you may know, is very simple to build. I mean, I'm reviewing all the papers which have been published in the previous 12 months, and then I'm contacting all authors. Of course, many of you are personal friends, and I have a specific area of interest like hemostasis or radial occlusion, so it's also easy to update the recent findings every year. So that was one of the key aspects. We wanted to have a congress discussing evidence-based medicine. We put more emphasis at the very beginning on this because that was the key issue. But we have learned, and I think you will agree that in 2016 the evidence promoting radial or demonstrating the clinical benefits has become overwhelming. So try to include more maybe technical aspects and discussing a little bit more tips and tricks for very complex situations like bifurcation or CCO, which remains one of the challenges for most of us. But I've also decided that there will be a new crusade that may not be impacting all of your life at this time, which is using a radial approach for peripheral intervention. I think it's a big topic. There are potentially many challenges as well. But there will be emphasis. So that's why there is this main room for coronary, and there is a separate room when all the technical aspects and peripheral discussion will occur. And I will encourage you just by curiosity to pay attention. When I say technical challenges, it means that there will be also very specific technical tips and tricks discussed. And I will just give you one example. We are very pleased that Dr. Roberts, who presented last year the use of ultrasound for radial puncture, will have a dedicated session using video, and he told me that he will succeed to have a phantom and sonocyte to help you learning the technique. I'm not advocating that we should move to use ultrasound for every case, but I personally believe, like cardiogenic shock, and when there is no pulse, that is probably a very fruitful and insightful technique to learn. So, because tips and tricks are best shown using live cases, there will be, of course, live cases for coronary in this room, but I will also emphasize that we will have this afternoon a combination of a cardiologist working with an interventional radiologist doing a carotid stenting. Tomorrow there will be a case of left gastric artery embolization, which I believe will be a breakthrough technique for treatment of obesity. And there will be also a case that is coming from the ingenuity of radialists performed by TAC1 with a Polish doctor when they're going to use retrograde approach from the tibial artery to perform below the knee intervention. So these peripheral cases will be broadcasted from the second room. As you know, I mean, this initiative came from my chair. We have an academic board. We have been decided the topics. We continue to expand the group, obviously, over the years. As you may know, we had yesterday a very fruitful FFR session. I'm also very much, and I'm biased, and I do acknowledge that fact that I'm very interest about biodesign and device innovation. So I think in the future, if we want to renew ourselves and explore new areas, that we will probably expand the biodesign and devices innovation within AIM-RADIAL. So there will be a session about biodesigns, I believe, this afternoon. We are very privileged to have Dr. Fumi Ikeno, who is working part in Stanford, US, and Japan to bring innovations, ideas to concept and product, and some of our colleagues, and I'm thinking about Dr. Vidovic and Dr. Pancholi and Dr. Danguas, will discuss some of their own ideas for which they develop concept and devices. Of course, a meeting like this would be impossible without the support of all the sponsors. Some of the sponsors have been with us since the beginning. I want again to express in the name of all my colleagues, staff, and faculty, our deepest gratitude, and I will encourage you to spend some time. They have booth outside in a different room, and please pay some attention. They may discuss with you product or their future and their view about and their vision about radial, and I think it's a tribute we have to also provide to them. And finally, I will just tell you that the gala dinner tonight will be also a nice cruise on the Danube River. There will be some discussion about this beautiful city. And please don't miss the meeting point and the timing at 7 p.m. in the lobby, because they need bus to get us on board. So at this time, I think that maybe they are ready to start the broadcast, and I will ask the faculty member, please take their seat. Dr. Ikari and Dr. Jim Nolan will chair, and we have Dr. Benamer. And please make also this session as enjoyable as you want, and don't hesitate to ask questions. Thank you. Enjoy the meeting.
Okay. Yes. Jó, megyünk. Igen. Igen? Itt van, megyünk.
Zoltan?
Yes, I hear you, Olivier.
Good morning. So I just I just made a brief introduction, and now you have to make the welcome at Budapest and discuss the beautiful girls.
Welcome from the Cath Lab from the Semmelweis University Cardiovascular Center. Let me introduce the live case team. Hilda Gál, our assistant nurse, Levente Molnár, my co-operator, and István Édesmáj, another co-operator, and he will help me today in IVUS imaging. We have a very tough bifurcation of left main case. I think István will help me to present the case.
Yes. Can we have the next slide, please?
Yes.
So our case today is a 74-year-old gentleman with average height, average weight for a typical Hungarian male. Also a typical medical history, what you see right here. Nothing special in terms of our cases. And his present complaints for dyspnea on effort, and his family doctor, seeing this, opted for a stress test, which was markedly positive, and because of this, coronary angio was performed. But before that, of course, non-invasive imaging and non-invasive other cardiological examinations were carried out. We have the next slide, please. Vital parameters are here, as you can see. Echocardiography was performed, which showed a preserved left ventricular ejection fraction, diffuse hypokinesis, especially in the regions of the LAD and the left circumflex artery, no relevant valvular dysfunction, and the angiography that was performed, which is previous to this one that we are doing today, showed a Medina 111 left main LAD LCX stenosis with no significant lesions on the right coronary artery. Thank you very much.
So now we can show the angio.
And angio.
We are changing for angio. This is the right coronary artery, which is not significantly diseased. And I show you the left main, which is critically stenosed in both directions. This is an AP view, and here we can see the left main. Just a moment. Okay, so here we can see this huge calcification in the left main, which involves both the LAD, both the circumflex, and from epicranial view, I here stop it. You can see there is a very short but very severe calcification on the left main coronary artery. So what was done? So now we have a sheetless guiding, 7.5 French Judkins left sheetless guiding from Asahi, and I've advanced the weak plexus support guide wire in the circumflex, and we have done an IVUS imaging, which will show István. István?
And can we get this into the main monitor, please? The radial monitor on. 1 second, so you will see our image as it's supposed to be shown. And there you go. You can see it right, correct?
It's not.
Okay, sure. Now this is the left main, which we try to find a relatively undiseased segment of the left main. You can see that it's enormous. It's about 5.1 times 5.6 millimeters, so we'll have a difficult time choosing an optimal stent. But also the technique is a question, because we also made a reference of the more or less non-diseased left circumflex artery, which is about 4.5, 4.7. So we've noted the severe calcification. You can see the pullback right now. I'll speed it up a bit, so it's a little bit more interesting. And right here, this is where you can see the crescent calcification beginning at the proximal left circumflex artery. It isn't typical ring calcification extending 360 degrees, nonetheless it's there, and it's really troubling. And this is going to be the part that's most exciting, which is right now, right here. This is definitely ring calcification with a critical stenosis that we see on the ostium of the left coronary artery. The left circumflex artery, sorry, they're extending into the left main.
Okay, do you hear us?
Hello?
Hello, do you hear us? Hello?
Hello?
Do you see the case? Did you see the case?
Good morning, it's Jim Nolan from the UK. So we can hear you, we've seen the details of the case. It's obviously a challenging left main angioplasty. I guess in the UK that would have been run through a kind of MDT. The surgeons would have wanted to take the case on. I would see your difficulties as being getting the stents fully expanded in that very heavily calcified lesion, but also getting stents up to 5.5, 6 millimeters in the main stem will be, I guess, a challenge.
Yes, I fully agree with you. It's a challenging case. We have discussed with the surgeons, and they told us to do the angioplasty because distal runoff of the LAD was calcified also, so they were not sure that they can do a good bypass there, and that's why they suggested to do an angioplasty. So after IVUS imaging, I'm very convinced that we need to do a rotational atherectomy of the left main. I'm not sure in both directions, but in the left main circumflex direction also. So we have advanced the rotavire extra support in the circumflex artery, and we have chosen the 1.5 millimeter bore to start the atherectomy. So we are using the old rotablator system, which we are using for more than 50 years, I think. So now we have a rotavire extra support in the left main, The wire position is not perfect, but I think we can go. We will check now the atherectomy system. How is the speed? I like to use higher speed. I like to use higher speed for atherectomy of these very tight lesions, not 120 RPM. Now we are going up on the dynaglide. Okay, I didn't feel that it's sliding the system. It's very important to be more the system. Now we are going up. We are using the sheetless guiding because it's very big. So here we are parking. And now I'm changing the dynaglide for the atherectomy.
The sound.
Zoltan, I have a question for the support. Why don't you use a EBU more than Jetkins to improve the support? Because for this bird, it's very difficult.
Yes, the Boer extra backup guiding is very good, very useful guiding, but due to the distal involvement of the left main, we need to we need bigger guide, and in this sheetless guiding we have only another type which is like the Voda, and I think it's not perfect the angulation, so we don't have ABU in this size, in this 7.5 French size. Now I am advancing back the Whisper extra support, but otherwise I like ABU the best, of course. But in left mains, where the left main is so diseased, we need bigger guiding, because sometimes we need bigger bores, like 2 mm, and the 6 French ABU is it doesn't allow us to use bigger bores. So now I've advanced the extra support Whisper in the circumflex again, and parallelly we are advancing the rotowire extra support. So we are going ahead. I'm always using the parallel guide wire technique because it gives a lot of support, and we know that the atherectomy wire is very Only one problem with this sheetless guiding is that it slides out sometimes. So for this reason, I'm not sure that this is the best solution. But due to the size we need, you can see that the size of the left main is 5 mm, so it's huge. So we are going back with the atherectomy wire.
Yes, I agree with you. I don't use EBU because EBU sometimes go to the deeply and not good for circumflex this lesion. But we have question. Did you place wire to the LAD or you place just CX?
No, I will use it, of course, but for rotational atherectomy we can't use 2 wires because the second wire will be cut by the rotoblator. So we can use only one. And rotational atherectomy doesn't make huge dissection, only in very limited cases. So it's very safe to do atherectomy in one direction and sometimes in the other direction without causing dissection. For the angioplasty, we will use, of course, a 2-wire technique for the LAD and circumflex also. So that's why we are using now only the atherectomy wire. Now now we are going.
I'll just ask the other panel members about the guide catheter choice there. So we probably would have used not a sheathless guide. We'd have used a standard 7. We'd have put it in sheath with balloon-assisted tracking. So we'd have had any, choice of configurations. And one of the problems there is that the guide catheter is not supportive, and also the coating makes it very easy to displace from the coronary. So you avoid that with balloon tracking the conventional guidance. Any comments on?
Yeah, I would say it's a tough turn for a burr to make, to the ostial left main and then into this angulated circ. So I actually might have burred into the LAD first and then addressed the circ at a later stage of the PCI.
Yeah, the circ has more disease than the LAD, actually.
It sure does.
Yeah.
Do you have comments?
Yes, I'd like to propose a step down in the dorsal sultan.
So the problem is that the guide is always coming back. So we are going back.
Did you hear that? Audience suggested you to size down to 1.25 or something.
At the moment, because we have here some problems, because I stabilize. Okay, so it went out. It's very tough case. Sorry about that, but we didn't see from angio that is so severe calcified. So now we have passed with the bore. We are doing again the atherectomy. I think it will be much more easier. Okay, so I think now we have removed the calcium from the surface. We are going out, and then we will change for conventional PCI technique. Yes.
This is 1.5 burr, right? 1.5?
1.5
Okay, 1.5.
One important point for using the burr is the sound of the music. So it's very important to hear if the speed of the burr is going very constant or not. Here it's a little bit fast.
Yeah, most UK operators use much lower RPMs now. Most of our operators are running about 140 rather than 180, 190, 200. So low speed rotational atherectomy is more in favour in the UK. I suppose the other thing to think of here is the precise technique to use now. And I know it might be a bit heretical, but a simultaneous kissing stent would sort that out pretty quickly, and you wouldn't have so much trouble getting the stents up in the main stem. Any thoughts from anybody else about what they do? Would you do a culotte
Or maybe in this case T stenting, provisional T stenting.
I would do T and protrude tap. I think that would be the best. Probably.
T or tap.
Yeah, T or
Yeah, T or tap as well.
Okay.
These neocarina techniques I'm very fond of.
How about you, Dr. Kari, for the...
I want to do the T stent in this case.
It's just me that likes the simultaneous kissing stents, then, is it? Oh, Dr. Luvar doesn't look very happy on the front row.
Yes, KS, you are creating a new carina. And the occurrence of restenosis is not so rare. So in case of restenosis, what are you doing? Sending the patient to surgery. Second, this is the perfect situation to have stent thrombosis. And when you have to go back to this vessel, you even don't know how to go in the distal beds. Because we all think that, like on the drawing we do for a paper, that the two channels are like this. Not at all. They are like this. You know? So they are around each other. So it's very difficult to go back. I remember the first time we presented the technique in Bifurcation Club was by Victor Legrand, a Belgium colleague. And he showed the case that the patient was living on a bifurcated saphenous graft. It was the only vessel he had, and he has a bifurcation lesion. So he did this technique brilliantly, very quick, in a patient with chest pain, and everything goes perfectly. But the week later, the patient died with stent thrombosis. Yeah.
So if you're going to do a bifurcation left main PCI, you've got to replicate the results of the surgeons, haven't you? You've got to be as good as they are.
So with this case, if you have a restenosis, you have to send the patient to surgery, because whatever you will do, of course we can convert to crush, but this is theory, because you don't know where you are entering. Maybe you go through the neocarina, and really. The result, the data we have from this series is follow-up. The only one we have is from single center. We have no multi-center trial, no randomized trial compared with other technique. I don't think this is reasonable to propose that.
I mean,
I can accept that in patients suffering cardiogenic shock and so on, but something like this, no.
Well, I agree with all that, even. You know, an SKS is a very quick way to get out of trouble, isn't it, for a patient with a bifurcation main stent? But the difficulty here will be getting the stents fully expanded, won't it, in a very large vessel. So you have to do as well as the surgeons can do. Our surgeons would be fighting with us to do that patient. So excellent distal vessels, we can get a fantastic result. Patient will be home in 5 days. Okay, I mean, you have to cut them up. They forget half their previous life. I accept all that. But you've got to do a really good angioplasty.
We have now stents, at least one that can go up to 6 millimeters, so can manage this case with this kind of stent. Personally, I've not seen everything, but I will probably implant a stent from left main to circ and kiss. And I won't be surprised if the result is good, with only one stent.
Right, I mean, I'd probably be looking at a Q-lock as a technique of choice there, but as you say, you might get away with a single one.
There it has to be a mini Q-lock, because what we try to do is to minimize the overlapping. As you know, overlapping, the desert trial by Waxman, overlapping is a predictor of stent thrombosis.
We will have the trial be approved in the U.S. probably in the next few months. What is your experience? That's a lot stent for this. Has anybody have experience with this?
I never used the treatment. It's just another way of doing a Q-lock. And when they did a randomized trial, it was found to be inferior to other techniques, so I wouldn't use the Triton.
I think about we have a small experience in MACI, but not in left main. And as it was said, the randomized trial versus provisional strategy was the treatment was inferior. But the patient included, as usually, the patient included in the study were not the patient that were planned, because the mean diameter of the side branch was 225. It was scheduled planned to have a side branch at least 2.5. But this is true for all the studies. So I won't be surprised if in big bifurcation with big side branch, maybe probably working better. And they prolonged the trial in a non-randomized way, yeah. And they showed that now for patients with the side branch more than 225, they are non-inferior to the provisional. But yeah. Non-inferior with two stent doesn't mean that this is better. Huh?
Yeah, we were in the Triton trials, but again, it was not done for left main. But I think one of its use might really be this.
So, can I ask you to give us an update on where you're up to there in the case?
Do you hear us?
Yes, we can hear you.
Yeah, so now what was done, we have advanced the Visprexa support. We have advanced the Visprexa support guide wire in the circumflex. We left in place the rotowire extra support in the circumflex of the body wire, and maybe we need another atherectomy, we'll see. And I advanced the BMW guide wire in the LAD. So now we have 3 wires, 2 in the circumflex and 1 in the LAD. I dilated the left main circumflex at high pressure with a non-compliant 3.25 drag balloon, and now after this I've dilated the LAD. So now we have done in both directions balloon dilatation, and we can see that after atherectomy the balloon is dilated well. So now we are making an angio. Here we can see the angio after ballooning. Now just a moment. This is the problem with the sheetless guiding, that it slides out. So we need to be very careful about it, because it slides in but out also.
So,
okay.
So you plan to stent first the circumflex and then open the strut?
Yes, yes, I fully agree with you. We are planning to stent the left main circumflex with a big stent, 5mm big stent, and then dragating stent, and then we'll do a T-stenting, provisional T-stenting. So we'll see the LAD after ballooning, how it looks like. We can check it with IVUS also, because we have IVUS on the table. We are always using in this complex left main cases IVUS, because without imaging we can have a stent thrombosis. You get a stent? Okay, now we can see that the calcium is there also in the circ, and we have a dissection also, but not so severe. It's very hardly so severe the calcification that we can see too much from the angio, but we'll see finally from IVUS everything. Okay, is it okay? So now we are doing left main circumflex stenting. Okay, so we are implanting a 5.0 12mm long onyx stent in the left main. Yeah. Another option would be to implant self-expandable stent in this left main, but it's so severe calcified that now I'm not sure that that would be the good idea. I like very much because it fits in all big left mains and.
Can you repeat, please, the diameter of the stent you choose for this angioplasty? The diameter of the stent?
The stent is 5mm big and 12mm long.
It's too big. It seems to be big for the circumflex. It's okay for the left main, but we have to choose the stent with the diameter of the circumflex, I think. Maybe 5.0, it's too big.
Yeah, we choose the shorter one, so we will put an additional stent if it is necessary.
So we've discussed this briefly in our native language. We do not really think it's too big for the proximal circumflex. The mid portion of the circumflex until the IVUS was initially brought down to almost had a diameter of 4.9, 4.8. So this is a 5.0 stent, which will expand with a nominal pressure and then take a look what happens. So we're not too much impacted by the fact that the left circumflex may be a bit smaller than the actual stent, which is about, I say again, 0.1 or 0.2 millimeters.
Okay, so the stent was implanted. Okay. Now we are moving the balloon, and the rotavirus extra support is out. Nézzük meg, nézzük meg angióval, meg nem biztos, hogy a diszekció, hát most nézzük meg a lagot. Okay, so now let's see the angio. Okay, so I think we have a nice result in the left main circumflex. Yes, we can see that the stent is a little bit upsized in the proximal circumflex. So now we can implant another stent, or we can do an IVUS. I think it's better to implant now a stent. Egy 4-es stentet kérek szépen. Egy 4-es 12-es jól szint. Vagy mennyit Okay, so we are implanting a 4.0 millimeter big stent in the circumflex. And then we need to treat the LED also. Why this case was chosen? That Robert Gill wanted to select a conical stent, bias conical stent, which is bigger in the proximal part than in the distal part, and these stents fits very well in these lesions. It's a bias stent. They have 5 millimeter and 4.5, or 5 millimeter, 4.0 millimeter big stent. But I don't have too much experience with that stent. That's why I choose the Onyx stent, which is now one of the best on the market, I think. Okay, so we can see the LED must be treated after the second stent implantation. Here is system. Okay, so we are implanting another Onyx stent in there.
So the operators have gone for 2 stents, haven't they? So one large one, main stem into the very proximal circle, and they're going to put a smaller one distal. I mean, I guess I would have used a longer stent of smaller diameter, and then an optimization with a big balloon in the left main. What do the rest of you think? Or?
That's what we do in our practice. We use the diameter of the distal part of the bifurcation and then open with the proximal optimization technique the proximal part of the bifurcation and then cross the strut and so on.
Especially calcified lesion, the dilatation part is not calcified area, so too much dilatation makes sometimes cause rupture. So in the calcified lesion, I want to choose a smaller size. So probably more smaller one.
Yeah, the 4.5 actually is the same platform as the 5, so it's a bit safer, and you can go up to 6 millimeters in left main. That's what I would have done.
I think a bit longer stent probably would have been my first choice, but I mean, this sometimes happens as well, you know, and it's. My general concern would be sometimes it's tough to recross with the second stent through this angulated. So you may end up regretting the fact of stenting proximal to distal. You get burned a few times.
I absolutely agree with that. But you had a jail wire because there was a buddy wire at the beginning. We cannot see clearly, but maybe you had a jail wire which improved the support to cross with the other one.
It's a nice anchoring.
Yes, very nice.
Poor man's anchoring, right? Yeah.
Yes, we are doing now anchoring to improve the support. So we have implanted a 4.0 80 millimeter long stent to fix the distal lesion. I fully agree with the panel that we are using a little bit smaller stents in very calcified lesions, but if we are doing atherectomy, and if the balloon is dilated after atherectomy, we don't need to undersize the stent, because the stent will implant, because the main principle of the atherectomy is to remove the superficial calcium, and then we can implant the second stent safely. So now this is the angio after dual stent implantation. I think it's nice, but now we need to do the LED to kick mesh the shield. So now we need to recross the stent into the LED. and then we decide what kind of stenting to do. We can do a culotte stenting, or we can do T stenting or TAP. So now the first is to recross the stent through the LAD.
One other point which is very important for the left main maybe is the coverage of the ostium. When we do, especially for a small length of left main, we try to cover the ostium completely with the stent. So in this case, maybe it's not completely covered. I cannot see it clearly, but
yes,
probably still a case for doing some proximal optimization there, because you know the next hazard is crossing into the LAD, isn't it, and going outside the stent with the wires. And is that a fresh wire to cross into the LAD?
Yes, this is so to answer your first question, the proximal optimization has been performed. Okay. So Dr. Rujo works very fast, so his hands are like lightning, so that's already happened. And this is an Asahi Scion wire, a fresh wire, which looks like it's definitely inside the lumen of the stent, and now it's in the distal part. Right now it's in the outflow tract of the LAD, so just went into a small branch, but it's promising, and then we'll carry on with the bifurcation technique.
So I guess, Dr. Ikari, I would have used the circumflex wire to cross into the LAD there to try and minimize the risk of getting outside that stent. What would you do? Would you take a fresh wire, as the operators have done?
Yeah, I want to use fresh wire because, circumflex wire should be inside the stent and to the end of the procedure, because sometimes something may happen. It's a security or something.
How about you guys?
Yeah.
Circumflex wire or a new one?
When we do a left main, usually we use a third wire to recross. It's very important to be sure that we are in the good lumen.
In other bifurcations, I swap the wires, but in left main I use a third one.
Fresh one. Sometimes what happens is the circ wire gets banged up. It's not as nice.
Steve, have you got any thoughts on that one? Which wire to use there for the LAD?
I use the circ because it is stented, and also this wire coming from the circ will come back to the LAD. We are not going forward to the LAD. I have not seen a real pot, so my concern now is, as it cross inside the stent or outside the stent. So if you use the wire coming from the circ with a proper shape, then you will re-enter from inside the stent, not outside.
Yes, it's a very important point to get the distal strut.
Yes,
this situation, the distal is close to the carena, the closest to the carena. So if you do that, you will project some metal of the main vessel stent towards the side branch.
But one important point, Yves, is that when we use the third wire, we get in the circumflex and then come back to the LAD.
Why not remove the circumflex? Circumflex is stented. You have not seen. It's important to look if you have no dissection, of course.
We are not in
But, okay, you can pull this wire. It makes one wire less. So.
Hi, do you hear us?
Okay, so Zoltan?
Okay, so now we have one geode in the LED. I think I will leave there because it gives a lot of support. And now we dilated the stent strut with a 3.0 balloon. And we are doing an IRUS through from the left main to the circumflex. I think it's very, very important to check the left main now with IRUS, because parallel wire can go beside the stent, especially in these big left mains. So we need to prevent the stent crashing. My technical, not to crash the stent in the left main, that I made a small loop on the wire, I went to the circumflex, I think it was too fast, you didn't see. And then I put back the wire in the left main. I went to the LAD. Mostly, of course, we are using the main branch guide wire as a guide wire to go in the side branch. But here I didn't want it to lose the circumference guide wire. That's why I didn't remove it. So I used the third wire because the lesion is a little bit. So it's a left main, and you don't want to lose the left main. So now we are going an IVUS with a Boston IVUS, which is 5 French compatible, but we have 5.5 French guide. So it allows to use nearly all devices. That's why we are using the sheetless system for these big left mains, because we can do culotte stenting, we can do TAC, we can do all kind of stenting which we want. So we can see that the IVUS passed the lesion, and now we are doing an IVUS in the left main circumflex. So this one will show the IVUS, the left main LAD, sorry.
And the pullback.
And now I'm waiting for the panel after this, what to do, what kind of stenting to do a culotte or to do additional stenting of the ostium. This is the LAD, which is a pretty big vessel also. It's 4.0. Here is the lesion, which is a little bit calcified also. It's very severely diseased.
And this is the left main.
Yes, and this is the left main. We can see that we are in the stent, which is very important, and we can have a huge malposition of the stent in the left main, so we need to post-dilate after the intervention, and here is under expansion of the stent. Okay, I think the ostium of the left main is not properly covered. That's why I will be careful to dilate very hard in the ostium. So, what do you suggest, to do a culotte or to do an additional T-stenting?
Maybe additional T-stenting or
Yeah.
LAD.
This is. Yes,
I would say
yes.
you have a favorable angle for TAP. I think it's going to look good, you know. Yeah.
Because T would be very difficult
Yeah,
because of the angulation.
Yeah, okay, we can do a top if you want. So now we will do another pot in the left main then.
Do you have stent enhancement in your cath lab?
Please?
Stent V's or stent boost or stent enhancement?
Yes, we can do. Okay, so I will do on top, and then we will use the stent V's program. Okay.
To see the distal struts, sometimes it's very useful.
I would probably do the culotte there, because I think it's quite difficult to place the stent across the. You've got to, you know, the disease extends right back to the stent. So for me, your best chance of covering it and getting it optimized is with a culotte.
Ez is halad, és ez a cít.
Okay, so now we are doing.
What do you think, Dr. O'Connor? Culotte or?
Yeah, I do culotte in this situation.
Should we do a raise of hands in the audience to see what the audience? So who would do culotte? All right, and good. So that's and TAP. It's 50-50, right? Roughly, right? Yeah. Actually, culotte wins though, right?
75-25.
And kissing balloon?
Tegnap jól engem kérdeztem, hogy milyen négyes feles
You get away with kissing balloon there because it's very calcified, it's very severe.
Yeah, but to judge the result, now before putting your second stent, you need a kissing balloon.
Yeah.
You do a kissing balloon, after the kissing balloon, take the stent.
I mean, I'm not advocating two-stent procedures, don't get me wrong.
Because he pre-dilated the LAD with a small balloon, so now, of course, he has a bad result. So, and now he will implant in a stent in a vessel which is not fully open. It's calcified, not fully open. So doing a kiss with a 4-0 in the circ, or 3.5 in the circ, and 3.5 in the LAD, will prepare the second stenting, if necessary. You don't know.
This is a left main,
It's a 5.0, 8 millimeter long balloon. We are doing proximal optimization. Not easy because we can't see anything because it's very calcified. So now 2 balloon dilatations, and then we'll do the stent viz, right? Okay, so now we are doing the stent viz.
So we'll just let you know that we have to cut the broadcast in 5 minutes, but we will come back to you to see the end result later, because I think it will take longer than that to finish the case.
Okay, thank you very much.
Okay, thank you very much. We hope you can have us again when we are ready with the case. Thank you.
So we have another 5 minutes to stay with you, so...
Oh, okay, great.
Yeah, going back to the guiding talk, he chose today the shiftless system, but we have 2 choices right now to go slender. One is a shiftless, and the other is using the glide sheath slender. Shiftless can downsize 2 French, glide sheath can downsize 1 French, but we don't know which is better. It's a big discussion in Slender Cloud Japan. Which is better? We don't know. But which one do you like?
Maybe for the support I prefer slender, because we all know with the sheetless guiding catheter the support is weaker than usual catheter.
Yeah, so we would use a conventional guide with balloon tracking and no sheath. And you don't have
From the sandwich, and you can see the stent is dilated.
I think 7 slender.
That's it to the bed.
So the CTOs in our institution, we routinely put an 8 French guide up the right radial with balloon tracking and no sheath. We use a 6 in the left radial then for the contralateral user.
Yeah, sheathless is good, but you cannot change the guiding catheter. It's a problem. And tomorrow, Dr. Yoshimachi will talk about the virtual 3 French, sheathless 5 French technique. It's very nice. Very nice. No radial occlusion because it is 3 French. But some bleeding complication happen, especially you change the guiding catheter.
Yeah.
Yeah, it's a problem.
Jó, próbáljuk meg.
No real problem.
So now we are implanting the first
So
stent.
I've been doing I've done about 150 of these cases over the last 6 months, and that's not a problem that I see using conventional catheters, both diagnostics and
So I'm not sure where the operators are up to there. Are they doing an IVUS or? Okay. Okay. Well, thank you to the operators there. It's a fantastic case, and we'll be really interested to see the end result. We'll come back to you later. Thank you.
Thank you very much.
Okay, thank you very much. We look forward to it.
Hi everybody, it's a pleasure for me to introduce this first section in which we will face with some important topics about radial preparation and selection. And I will move to the first presenter, that is Dr. Gilles Christ, that will speak about the need or not for an Allen test before radial use.
Thank you very much. So the topic I got charged with today was, do we still need Allen or oximetry prior to radial approach? And let's see what we can do with this. Perfect. First off, from the very beginning, there was what I would call a myth out there. Many of us learned this in medical school or nursing school, and that is that the hand is simply a two-vessel piece of anatomy where you had a radial artery and an ulnar artery, and that sort of fed the whole shebang, and that you had to have intact arches, else if you cut one artery, you would lose half the hand. And that came out with interesting pictures. This one from Circumflex. Supposedly this is a surgical resident whose hand turns red and white depending on which artery you compress. This type of folklore has been in the medical literature for quite some time, and makes great demonstrations. What's happened to that myth is that it's turned into a ritual, and here's that's the patient down there, pleading with its two wrists up in the air to the budding radialist there, who's really a femoralist, who's now got to go through the ritual of checking the Allen's test. And if for those of you who may not be a connoisseur of the English language, if you look up what a ritual actually is, it's a detailed act or series of acts carried out by an individual, in this case the doctor, to relieve anxiety or to forestall development of anxiety in the doctor. So this is actually a picture from a Mayan temple, and that guy's about ready to be sacrificed on the bottom. All right, and the reality is the hand is much more than just two arteries stuck into it, and there's a whole series of arteries in there, and they all interconnect, and there's more than two, there's more than three, there's lots of arteries in the hand. And the worst case scenario is that you measure an Allen's test and end up with something like this, which is a retroperitoneal hemorrhage. This happened to be a case in our institution where the doctor, another operator, decided that because the Allen's test was abnormal, that he would go do a femoral case. This is the only known serious complication to an abnormal Allen's test. That is a retroperitoneal hemorrhage because you decided to switch over to the groin. Do infarctions of the hands occur? Yes, this is a recent case in JACC intervention, but these are thrombotic complications. Embolism coming off the catheter. None of these that are in the literature have been associated with an abnormal Allen's test. These are thrombotic occlusions from lack of heparin or something that went wrong during the case, and nothing to do with the Allen's test. When I also am a critical care doctor, and the critical care literature years ago had sort of thrown the Allen's test out the window. There's no class 1 evidence that it works. There's no randomized data for good meta-analysis back then. There was no standard definition of what was abnormal. Significance of abnormal was unclear, no predictive value, and the conclusion back in 2006 was the performance of an Allen's test before radial artery cannulation in the ICU should not be considered standard of care. This didn't catch on with the radialists for another decade. The Transradial Allen's test is built on an assumption of predictability, which was never there. We've tried to refine it with oximetry, and one of Dr. Bertrand's colleagues touted that. It's been mentioned as a ritual at many transradial courses in the United States, at least, labeled as a standard of care without data, and on the other hand, many long-standing operators don't do it or never have done it, and ischemic complications are essentially unheard of and certainly not related to the status of the Allen's test. What I think sort of put the nail in the coffin was Marco's radar study from Italy, where they basically took the Allen's test on a group of patients, 203 patients, of which 80 some were normal, 80 some were intermediate, and 60 were abnormal, and then did a series of testing, including lactates and frame counts and discomfort ratings, and looked at that at baseline 1 day after the cath, 1 month after the cath, and 1 year after the cath. And basically, they didn't see any differences to suggest that there was a risk with an abnormal Allen's test. To put it more graphically, here are the, this is the hand grip over the 1 year follow-through period, and there's no difference between the 3 groups, whether they had a normal, intermediate, or abnormal Allen's test. You can look at the discomfort ratings, and again, there's no difference in here. And you can look at the lactate produced during the procedures in that, and there's no difference whether there's an abnormal, intermediate, or normal Allen's test. Bringing up the Barbeau, the oximetry test, if you can look at the Allen's test in the far off column when it's normal, most of those are Barbeau A's. A couple of them are Barbeau B's. In the center column is the intermediate Allen's test, and you can see that's dominated by Barbeau B and some C with a few A's. And then the abnormal shows even more Barbeau D's, which in many labs would have excluded a radial. That's at baseline. In the normal Allen's test group, they stay fairly constant through the next follow-through. In the intermediate group, you start to see how unstable these tests are. You see drift over the year, and certainly they didn't grow arteries over the year. And then in the really abnormal Allen's test, you see that there is a marked difference in the distribution of Barbeau findings over time. So in other words, it's not a stable test. These tests are very variable and probably depend on a lot of collateral flow differences and autoregulation that we don't understand. It's just not as simple as 2 arteries plugged into the hand. Is there a role for collateral testing? Should we throw it out the window? You know, is this all junk? Should you not even bother? I think for triage, whether to use the wrist or not, this is not a role for there's no testing role here. You know, if you have a hand, I use it personally. I've done that for 20 years, and I haven't lost a hand yet, despite my femoral colleague who claims he counts them in the parking lot. On the other hand, there is some use for it, I think, if you're interested in some of the patent hemostasis or trying to understand what's going on with the pulses in the hands. If you know that you can easily bring out a collateral circulation and how those 2 arteries feel, you know, that's fine. You can record that before the test, but don't cancel your radial procedure and go down under just because the Allen's test was abnormal. So, you know, when you're talking about the risks and benefits, I think if you spend a lot of time playing with the Allen's test, the patient starts to wonder what's wrong with them, and really it moves their concentration away from their heart. Also makes you look like you maybe don't know what you're doing because you're sitting there staring at the wrist. I think this is what we really want to see now. Maybe we don't want to see a hemoband like that, but you want to see a nice clean wrist at the end of the procedure, and you want to see a patient with a nice smile on. You don't want to see that because the Allen's test was abnormal, because that then turns into something even uglier. And I think before you just dive down to the groin, you need to make sure that the patient understands that you're going to the groin because you're afraid there might be a complication because they have an abnormal Allen's test. Although that complication's never been recorded in the literature, but this complication does occur, and you can tell them with a straight face that there is a risk of this if we go down to the groin. And so for my practice recommendations at this point, there's no evidence to support the utility of testing for dual circulation for pre-procedural triage for transradial catheterization to prevent ischemic complications. There's nothing in the literature that says that a normal Allen's test will prevent complications in the hand. And we need to refocus our attention on using oximetry and plethysmography and other techniques to guide patent hemostasis once the transradial procedure is completed to minimize radial occlusion. That's what we should be worried about, not whether their hand's going to be ischemic from the procedure. So with that, I'd like to thank you. Hershey's the home of the Hershey Kiss. My kids thought I was kind of crazy about radial, so they got me a radial license plate for my car. With that, I'd like to
I would ask to the audience, how many of you use routinely Allen test before a radial approach? Can you stand up your hand, please?
Preaching to the choir?
You convince them.
No, but
Perfect.
there is...
That's it?
Thank you. Allora, the next presenter is Jim Nolan, that spoke about there is a relationship between volume and the access site complication and operator experience.
Nice old Mazda there, Ian. Where are you? Is that an RX-7? Yeah. Okay. So, thank you to Olivia and the organisers for asking me to come and speak about access site-related outcomes and their relationship with operator and centre volume. I think it's important just to start off by asking ourselves why we use radial access, and we use it to reduce vascular complications, bleeding and transfusion rates, major adverse complications and death. And the data that supports these statements is never going to get any better than it is now. It's supported by large, multi-centre, international randomized trials and huge observational databases. And the data's not going to get any better because it doesn't need to get any better. So people who persist with femoral access are in the grip of some kind of psychiatric condition, which a psychologist would call situational blindness or cognitive dissonance. It doesn't matter what data you present to those people, they will ignore it and they will find a reason to carry on doing what they want to do. We do have to ask ourselves, are all operators and all units and centres exactly the same? And the answer, of course, is no. So I'm a big believer in the whole mantra of 10,000 hours of practice. The more you do, the better you get. And you see that in all practical procedures. People who practice playing football in the garden get to be quite good at football. People who go to the tennis court a lot get to be quite good at tennis. People who play a lot of chess get to be good at chess. People who do lots and lots of radial procedures get to be good at those radial procedures. So the first data that emerged was from the RIVAL trial published in the Lancet in 2011, 7,000 patients randomized into radial or femoral access. And in the landmark paper, and this shows the effect of radial centre volume on the composite primary endpoint, which was only favourably influenced in the units which were in the highest tertile. Those were the centres doing more than about 150 radial cases a year, which many of us would consider to be quite low volume centres in a European context. So there's clear evidence from RIVAL that centre volume has an effect on outcome. In the intermediate and the lowest tertile centres, the composite primary endpoint was the same in the rate, was unaffected, so that it wasn't favourably influenced over femoral access. The RIVAL investigators then went on to do a complex multivariate analysis, which they published in JACC in 2014, looking to see whether the primary outcome was independently affected by radial PCI centre volume. And you can see here, if you look towards the top, where the primary outcome is listed, that radial PCI centre volume was an independent variable that affected the composite primary endpoint. And they also looked at radial operator volume, and once again, radial PCI operator volume was independently associated with outcome for every additional 50 cases that were performed radially. So RIVAL seems to show an effect for operator and centre volume on the outcome of radial procedures. What about the most recent data? This is from Matrix, published in Lancet in 2015, 8,500 patients. And this is the effect of radial centre proportion on the composite primary endpoint of matrix. So in the low volume centres or the low proportion centres, the composite primary endpoint was unaffected in the intermediate centres, but in the high proportion centres doing more than 80% of their cases radially, there was a significant beneficial effect on the composite primary endpoint. So that's fairly clear. So it seems from RIVAL and from Matrix that there is a volume effect in the highly selected populations who are enrolled in randomized trials. Of course, randomized trials have their disadvantages. The populations are highly selected, it takes a long time to do them, etc., etc. They don't really reflect real-world effects and real-world patients. In the UK, the Interventional Society, BSIS, which was established in 1998, collects data on all the PCIs performed in the country. So we collect 130 PCI-related variables about patient characteristics, procedural characteristics, and outcome data. And we have very robust mortality data, which we track using a personalised NHS number, while the NHS still exists in the UK. And that's linked to a central register. And it's a legal requirement for every death in the UK to be notified and recorded on that central register. So we can track angioplastic procedures, their performance and their outcomes quite carefully. This is what's happened to access site practice in the UK. It's quite amazing, really, especially for me when I started off trying to promote radial procedures in the UK. Nobody wanted to do them. I was all on my own for a long time. But in the 10-year period from 2004 to 2014, there's a 5 to 10% increase in the proportion of procedures performed radially every year, so that we're now, at the end of 2014, at 76%, and I fully expect the 2015 data to be up above 80%. So there's probably some lessons there for North American and international people where radial access is low. How did this happen? You know, we could talk about that endlessly. If you look at the pattern of radial access in UK centres, if you look here, the yearly centre volume is on the horizontal axis and the proportion of radial procedures is on the vertical axis. And what you see is that all the high volume centres in the UK are now predominantly radial. And the centres where femoral access predominates are pretty much low volume centres. There's a similar pattern here for the operators. Most of the high volume operators in the UK are doing 75% of their cases or more radially. And the femoral operators, the people who persist with femoral access, are usually low volume operators. There's one guy there, if you look along the bottom, that black dot, who does more than 600 cases per annum femorally. I know his name. I might be tempted to send some of my friends from Liverpool around to see him one dark night. Protect the patients from this recalcitrant individual. But that's an example of, no matter what data you produce, what it shows, some people will ignore it if they don't want to listen. There's no way to persuade them. So we've looked at the effect of operator radial practice on outcomes in the UK, using that tight database that we have, tracked mortality. We published the data in Circ Intervention in 2016. We looked at 2 years, 165,000 angioplastic procedures. The next two slides follow the same pattern. The radial proportion is on the horizontal axis, and the risk ratio for 30-day mortality for radial versus femoral axis on the vertical axis there. And the line describes that, the solid line describes that relationship with the confidence intervals being the grey zone. So here you can see that operator radial proportion is an important mediator of outcomes, and that there's a linear relationship from 0 to near 50% reduction in mortality compared to femoral procedures when you get to be a high proportion radial operator. You have to do at least a third of your cases radially to start seeing some benefit, but that benefit continues to accrue as you move up through 50, 60, 70, 80, 90%. Every operator in the UK has their individual angioplastic performance and outcome data published on a publicly accessible website. You can look me up, you can see how many procedures I did, you can see what my case mix was, and you can see whether I used radial access or femoral access for those cases. I do over 95%. There are many other operators. One operator in the UK does more than 200 procedures angioplasty and has a 99% radial rate. Yeah. I know who he is as well. So you can see that there's a clear relationship between what proportion of cases you perform and what the outcomes are. And interestingly, when we looked at centre radial proportion, it wasn't such a strong predictor. We couldn't find a relationship. So you can be a high volume radial operator in a low radial volume centre and still get good results. It's down to the individual operator and how he leads his team and how he manages things. So even if you're in with a bunch of old dinosaurs, you can still do a high volume radial practice, get great results. So in multiple randomized trials and large observational studies, radial outcomes are linked to institutional and individual practice patterns. The best outcomes are achieved by the high volume radial operators and institutions. You need to do more than 30% of your cases via radial access to favourably impact on the adverse outcomes of the femoral practitioners. And high proportion radial operators can achieve a 50% mortality reduction in a real world population of 165,000 patients if they achieve a high radial proportion. We should briefly consider what the mechanisms for this effect are. There is a learning curve, we all know that. This is some data that was presented at TCT in 2003. Thierry Lefebvre's learning curve was very long. In those days, 1,000 patients, 1,000 cases, 1,500 cases. This would be daunting, I think, if you were starting off as a femoral operator now to look at this and think it's going to take me 1,500 cases before I'm any good. There is increasingly data that contemporary learning curves are much shorter. This is some of Rao's data published in Circulation in 2014. It looks at fluoroscopy time here and shows that fluoroscopy time declines steeply for the first 50 cases and then starts to level out. Similarly with contrast volume use, I think this is a little bit optimistic. There's a steep learning curve from those first 50, but I don't think a learning curve for radial operators is really 50 cases. This is more like the real world. It shows failure rates over and operate on the vertical axis and operator volume on the horizontal axis. You need to do a few hundred cases before you get there, or spend about a year getting on top of the thing. This is the decline in fluoroscopy time for trainees and experts. You can see at the end of a year it's pretty much equivalent. So I think in reality the learning curve in contemporary radial practice is a few hundred cases long or up to a year. And if you're a low volume radial operator or a low volume radial institution, you will have lots of operators who are early on in this learning curve, and they will have some difficulties that they can't overcome. They will encounter situations that are new to them, and so the low volume institutions and centres are carrying learning curve operators. There are also case selection effects. So you see in this paper from Rajani and colleagues published in 2015, they looked at over 10,000 sequential radial cases in their institution. And so if you look at 2008 compared to 2012, multi-vessel PCI was not done radially, CTO PCI was not done radially, bypass graft PCI was not done radially, mainstem PCI was not done radially. But over the period of observation, there was a big shift in practice so that these more complex patients were taken on by the radial operators. This is some data that Mamas and I published in JAC 2014. We looked at 350,000 cases, and outcome for radial cases in blue, outcome for femoral patients is in red. And you can see here that as we rise up the bleeding risk category, as we move across the graphs and we get into the more risky patients, the beneficial effect of radial access over femoral access is magnified. So if you are only doing low-risk patients, you will not gain a lot of benefit from being a radial practitioner. But in the more complex and, of course, more difficult patients, the beneficial effect of radial access is magnified. So, what can we say in conclusion? We all know that radial access is better for patients, but only if you switch to a high volume radial practice. There's no point in doing type A lesions radially, doing all the bypass grafts femorally, doing all the main stems femorally, doing all the primaries. You know, that's not going to lead to better outcomes. The sicker and the more complicated the patient, the bigger the benefit of being a radial practitioner.
Okay.
That's probably mediated by learning curve and case selection effects, that the effects are magnified for the high volume or high proportion users. And it's a powerful reason to move your interventional practice to mostly radial access, as you can see pretty much everyone in the UK has done. Should the radial approach only be used in high volume radial centres? I think the answer to that is no. Every operator and every centre, however, should be a high-volume radial centre. Thank you.
I have a provocative question. So during the training for a new operator, there is a space for femoral approach or not? Or which is it, the space?
Yeah, I mean, I think I will do some femoral procedures if I think it's in the patient's interest to do it that way. So I think we have to, the trainees who come through in the UK are all trained from day one as radial operators, and their exposure to femoral procedures is limited. So we have to do something to maintain their expertise. And I hear this trotted out endlessly by femoral operators. Well, you know, this is terrible, they're not learning anymore. Now, you know, if you can puncture a 2 to 3 millimetre artery and navigate through loops and tortuosities and use your guide catheters through tortuous subclavians, hitting a 7 or 8 millimetre femoral artery and putting a guide catheter up is not difficult. It's really not, is it? It's easy. So you have to teach the trainees and other operators how to do femoral procedures well. Not the way I was taught to do it, which is feel about in the groin, find a pulsation and stick a needle in, and press on it for a while afterwards. You have to use ultrasound. You have to really care for those patients. You have to keep them in your cath lab or in your recovery area for 4 hours after. Don't send them to the ward and find out their blood pressure is 70 when you go up there 4 hours later. So there are ways to manage the potential risk of so-called de-skilling in femoral procedures.
Okay.
Does that answer the question?
No. The problem is now that operator that is beginning this work should be able to manage both the artery, no? So in your fantastic presentation, you explain us that there is no reason to do not radial. No. So, but when we have to face very complex case or CTO,
well, I would say if you face a very complex case, use sheathless guides if you want, or balloon track a large caliber guide up the radial artery. It doesn't make any difference. You don't need to do those cases femorally. So in the UK, to my surprise, I've stopped running exclusively radial meetings, and now in our meetings we run we have a section on how to do a good femoral puncture and how to manage that patient, which is not what everyone used to do, stick a needle in somewhere randomly. You know, identify the right point of the femoral artery to puncture and really look after that patient afterwards. Press on it, don't stick a piece of collagen in it and send them off to the ward.
Okay. There is any question from the panel? No, okay. We are now the possibility, thank you. We are now the possibility to see the end of the live case. So we will move in the cath lab. Hi, can you hear me?
Okay, so this was the last image you've seen. There was a significant gel in the LAD, and then we have implanted, this is from another angulation, we can see the lesion. So we implanted a 4.5 millimeter long onyx stent in the ostium, and then we have done kissing in the LAD and the circumflex and left main, of course. After kissing looks nice, and then this is from epicranial view, the left main LAD circumflex, and I show this is the one, and the next, the last angio. So this is the last angio. I think the stents are looking to be very well expanded, and we have done an IVUS to the LAD and to the circumflex. In both directions we have a good apposition. I will show now the circumflex. This is the second IVUS. We can see that the distal stent is properly expanded, and this is the left main, which is properly side is a 4.4 6 millimeter big the stent, so it's a properly expanded and properly sized the stent. The ostium is not dissected, and this we can see in the LAD also. There is no geometrical miss in the LAD ostium, so I think from angiographic point of view and from IVUS point of view, we can finish the intervention. And now Levente will show how we remove the sheetless guiding, and we will close the system with the Perros compression. Yes, Perros system. And now we show Levente how removes the sheetless guiding.
This is a C1 closure device, and we position the center of the closure above the point where we inserted into the vessel the needle, and then as we pull out the sheet, there is actually like a clock. You can see there is no bleeding. And this closure device will stay on for 3 hours, reduce the pressure by time. After 3 hours, we can take off the closure device and the radial will be patent. The benefit of this device is that it does not occlude the venous system. There's plenty of space, so the hand will not swallow. It will be not swollen, and as you can see, it's not livid. The ulnar artery is free, so there is good circulation for the hand.
Thank you very much.
Okay, fantastic case. Do you plan any angio follow-up for this patient?
Yes, yes, we will plan CT angio after 2 months, and we will do control coronary angiography at 12 months.
Okay. Thank you. Excellent case. Good presentation.
Yeah.
So, thank you, Olivier, for inviting me to this great meeting. I think it really is a highlight in the radial calendar. And it's a great opportunity to meet colleagues and discuss interesting data, and also the radial individuals are fun group of people to meet anyway. So my name's Mamas Mamas. I'm based at QLand. I'm the Professor of Cardiology at Keele University. And what I want to show is data from the United Kingdom, from the BSIS registry that Professor Nolan before me talked about, showing that changing to radial practice does not necessarily impact on femoral outcomes from a national perspective. So in the UK, there's been a huge change in access site practice. So this is a map from a paper that we published earlier this year, showing that in 2005, very few centres were doing radials. The darker equates to more radial procedures. And as you can see, over time, radial utilisation has increased quite significantly. So by 2012, there's large parts of the country, like the North East, the Midlands, parts of Wales, that were doing over 90% of their procedures radially. Nevertheless, there's still quite a lot of areas like the South East Coast, London particularly, where utilisation of the radial approach is only 20 to 30%. So there's great heterogeneity, even in contemporary practice, of what people do from an access site choice. We showed in our paper that in the United Kingdom, this change in access site practice has been associated with around 450 lives saved. But heterogeneity in practice means that some additional 260 lives could have additionally been saved had everybody switched to a predominantly radial practice. However, even in high-volume radial centres, there are situations where PCI needs to be undertaken in the femoral approach in around 5% of cases. So, for example, in cases of cardiogenic shock, where you can't feel the radial artery, in the very elderly, when again, radial artery diameter is very small and you have difficulty even passing 5 French catheters, and so forth. And there's been a lot of data and a lot of discussion currently amongst the femoral community to say that, okay, there's a strong argument for switching to radial, but this switch to radial may compromise the outcomes of femoral cases. And And this is some data that was published by Mark Scholikler's group a few months ago. And what they looked at was access site complications from their single centre in around 12,000 femoral cases. And they looked at 2 time periods, 1996 to 98, where mainly a femoral approach was undertaken in their centre, and 2006 and 2008, where there was a transition to radial in about 50% of cases at an institutional level. And what they showed that both for diagnostic and PCI cases, even when you adjust for confounders, there is a significant increase in femoral access site complications. So their argument was, well, this shows that switching to radial means that you have worse femoral outcomes and therefore you shouldn't do radial. And that doesn't really follow that argument. And also, when you actually look at the paper, there's some quite unusual statistical methodology employed. They didn't adjust for a number of confounders, such as balloon pump utilisation. So, for example, in the contemporary cohort, 4 times as many balloon pumps were used than in the historical cohort. They had no data about drug use in the historical cohort, no data about French size used. They didn't adjust for a number of covariates. All they adjusted for was age, sex, and whether the patient had a STEMI. And so this data really is quite flawed. And so I don't think it gives us a huge amount of insight of femoral outcomes in a transition to radial. So what we've done is to look at the BSIS dataset to see whether this national change in access site practice that we have reported in numerous publications at a centre level has led to worse femoral outcomes. So these are the methods that we employed. So what we did was, in 2006, all centres mainly did femoral. We then tracked at the centre level these cases, and we split them up into 3 cohorts. So there were centres that mainly stayed femoral, there were centres that partly switched to radial, and there were centres that switched mainly to radial. And what we did was look at the femoral outcomes over time in each of these 3 groups. Because if there really is an influence of changing to radial on your femoral outcomes, then one might expect that the femoral outcomes of these predominantly radial centres will be much worse than the centres that have stayed femoral. So it was a retrospective study from the BSIS dataset over a 7-year period, including every PCI undertaken femorally in the United Kingdom. We looked at 30-day mortality and vascular complications, and we looked at femoral experience, and we categorised this as the proportion of femoral procedures undertaken by the centre in 2013 to split it up into 3 categories. The high femoral proportion centres, i.e. the ones that have stayed femoral, the intermediate ones, the ones that have switched to about 50-50, and the low femoral proportion centres, i.e. the ones that have switched to radial. So this is data from an individual centre level. So these are the 92 centres in the United Kingdom. And what these dots show are the proportion of cases undertaken femorally at each centre. The darkness of the dots represents the volume of that centre. So to give you an example, this centre, centre number 43, you can see it's a high volume centre. In 2005, the cases were mainly undertaken femorally, but there's been a big switch to radial. In contrast, in these low-volume centres, you can see that they've mainly stayed as femoral centres. And so we split these different centres into 3 groups. The low femoral proportion centres, so that means that less than a third of their cases were femorally, i.e. the majority radial, and that's the majority of the centres in the UK. The intermediate level centres, and the high femoral proportion centres. So these are the centres that have stayed radial, these are the ones that have stayed femoral, and these are the centres that have done a bit of everything, so do a bit femoral, do a bit of radial. And we included close to 250,000 patients in this analysis. These are the demographics, categorised according to centre proportion. So remember, low femoral proportion equates to predominantly radial centres, and high femoral proportion equates to predominantly femoral centres. And what you can see immediately from this data is that, particularly in the latter years, so in 2013, in the predominantly radial centres, patients are much sicker if they have femoral approach. They're much more likely to have a balloon pump, cardiogenic shock, be ventilated, have inotropic support, much more likely to be STEMI cases. Whereas in the femoral centres that undertake mainly femoral procedures, the patients are much lower risk. So this is the unadjusted 30-day mortality over time according to the femoral proportion. So you can see that in high femoral proportion centres, i.e. centres that do mainly femoral cases, you can see that there's been a slight increase in 30-day mortality, but not much. In the centres that have switched to a predominantly radial practice, you can see that the mortality in the femoral cases has increased massively. So you might say, just looking at this slide, yes, this proves it. This shows that switching to a radial practice impacts on your femoral outcomes. But you've got to remember that these are much, much higher risk cases, and so you have to adjust. And so we adjusted through all these indications, not like the other paper from a single centre where they just adjusted for age, sex and indication. We've adjusted for all different covariates. And when you adjust for these covariates, what you see is that there is no difference in femoral outcomes between centres that have switched to a predominantly radial approach and those that have stayed femoral. We've also modelled the data slightly differently. So what we've done is, rather than split them up into three categories, is at each centre level, we've taken each procedure and then looked at the year's data in that centre and worked out a femoral proportion and done this as a rolling average. And again, you can see in the unadjusted data, as your femoral proportion increases, i.e. as your centre is more likely to be femoral, your mortality reduces. But once you adjust for differences in case mix, there's no difference. And so what this slide again shows is that in centres that have switched mainly to radial, there is no different outcomes in terms of their femoral procedures. And again, this shows that there's no statistical relationship between your femoral experience and your mortality outcomes. So switching to a radial practice does not compromise your femoral outcomes. And we've looked at this in different groups. So we've said, okay, why don't we look at the top 10 radial centres versus the bottom 10 radial centres? So in the top 10 radial centres in 2013, the radial proportion was between 87 and 95%. And in the top 10 femoral centres in 2013, the femoral proportion was between 80 and close to 100%. And you can see in unadjusted figures over time, femoral cases done in radial centres appear to do worse, but that's because of their case mix. When you adjust for differences in covariates, there's no difference in the femoral outcomes in the high proportion radial centres versus the predominant femoral centres. We can also remove all the complex procedures and say, well, okay, let's look at all the procedures excluding circulatory support, ventilation, cardiogenic shock and so forth. Again, the same message. Over time, the centres that have stayed femorally do not have better outcomes in femoral procedures than the centres that have switched to radial. We can look at vascular complications. Again, the centres that have stayed femoral do not have better femoral outcomes than radial centres. So, in conclusion, this is national data. This is data from the UK at a time when there has been a complete change in radial practice, in access site practice towards radial. And what we show is that there is no difference in outcomes from a femoral perspective in cases undertaken in radial centres compared to femoral centres. So whilst there may be a signal at a single centre level in North America, in the whole of the United Kingdom, there is no signal. Once differences in case mixes are adjusted for, femoral outcomes are similar in high and low radial proportion centres. There's no such thing as a Campo paradox in a country that has transitioned to predominantly a radial approach, where 75% of all PCI has been undertaken radially. And in my view, this argument that if you switch to radial, it compromises your femoral outcomes is invalid. This is not supported by data from the United Kingdom, and the radial approach should be maintained as the default access site to practice as per current evidence based on international guidelines. Thank you.
Yes, thank you. I'm Surya from Indonesia. Did you do any sub-analysis in cardiogenic shock patients, and you find still that radialists may perform better?
We did a subgroup analysis in the patients that were not shocked. The numbers in cardiogenic shock are too small to take this approach. I mean, the confidence intervals are absolutely huge. We did publish a paper a few years ago exclusively in the cardiogenic shock cohort, I think in about 5,000 or 6,000 patients, comparing radial and femoral and showing a better mortality outcome in the radial cohort, even after adjustment for hemodynamic indices, inotropic support and other markers. But for this type of analysis, the numbers are just too small to try to do any meaningful analysis across 92 centres. Although cardiogenic shock was included in the models, which wasn't the case in the other publication that has gained so much interest from one centre. I think, Jim, you want to say something?
Yeah. So, you might wonder why this hasn't been published yet. Why it's taken us some time when we first presented it.
And the answer to that is that the vagaries of the peer review process are obstructing the publication of this paper. And so
So I've got my three best statisticians. So at the moment we're in a battle with circulation interventions. I'm hoping that we will win that battle.
Yeah. So you've seen the original paper that generated the so-called Campo paradox terminology, and that was waved through with laughably inept statistical analysis. And our paper has met enormous attempts to obstruct its publication. So it's taken us some time for Mammoth to refine the analysis, to get it into that tip-top shape. You can see what it shows, but there are definitely people who don't want it to be published.
So what we are planning to do with this lazy guy that continue to use a femoral approach?
Sorry?
What are you planning to do with...
I'm going to speak to my friends in Liverpool, and they're going to be sleeping with the fishes.
Well, I mean, I think the problem is that nowadays in the UK, there's a move towards quality. So there's various quality improvement initiatives, and one of the markers of quality currently that's published by the British Interventional Society is the proportion of cases that you undertake through the radial approach. You can see a future not too far in the past, in the future, where perhaps the commissioners will pay less for cases undertaken through the femoral approach because they're deemed to be of lower quality.
And already in the UK, in the private practice sector, if you do a radial PCI, you are paid more than if you do a femoral PCI.
Yeah.
So there's already a costing differential in there.
So hit them where it hurts the most, in the pockets.
And I presume that with the radial you are more prone to do outpatient, so are you paid less with outpatient or more with outpatient PCI?
It's more. I mean, you can turn around. The turnaround is much quicker. The data is slightly difficult to analyse because a lot of the femoral centres are low volume centres that do most of their PCI as elective cases, whereas the radial centres are much higher volume centres which do a bigger case mix of primary and acute cases. But in the UK...
No, I'm speaking about the payment, what you receive when you do outpatient or not. Is it paid better with outpatient or better with inpatient?
I'm not sure. I don't know.
In the USA, the remuneration is being loaded into day cases and radial procedures by the insurance companies already, so that will be a driver in North America.
I don't think it, I think
So
in the UK
I think in France we are very early doing Transradial, but still today we are not paid for outpatient PCI. Nothing. We are not paid.
Also in Italy. So.
I think that the payment's the same in the UK. So,
did you find the same kind of result for elderly patients?
So I haven't done subgroup analyses, but we have adjusted for age, but I would imagine that there is no difference. So we published a paper about 2 years ago looking at elderly cohorts, and the elderly benefit much more from radial access, but they are much less likely to receive it. But in this paper, I've kept the message simple and not looked at different subgroups. As I said, there's been a huge difficulty in trying to get this out from all sorts of ridiculous, review comments from femoral people. So I think one of the review comments was, you need to tone the manuscript down. The evidence for radial is not very strong. These sorts of idiotic.
In 2002 for MI, it is unethical.
Yes.
Unethical. 2002.
Yeah.
Jack.
Yeah. But anyway, we'll get there.
Okay. Thank you for your presentation. The next presenter is Dr. Kumowski. It will show us, explain us if femoral proficiency is lost when we use a radial access.
The Chairman, ladies and gentlemen, thank you very much. My name is András Komocsi from the University of Pécs, Hungary, and my task is to substitute our friend Stanislav Bartos from Krakow, and I would like to present a presentation about just a similar question that has been discussed in details already. And having been received these slides yesterday evening, I had a very long night to run through it, and I also couldn't resist the temptation to give some notes and also add some Hungarian data in order to widen the international perspective of the presentation. But anyways, the general rule applies, so please read the message, but do not kill the messenger. So, what we do know that radial access, the use of radial access is increasing, and if you look at the data of the Polish National Registry of Interventional Procedures, we can see that all Polish friends have a continuous yearly increase in the use of radial access that ends up in some 1 quarter of the patient where this kind of situational blindness, as Dr. Nolan has called it, somewhere in 25% of cases. So it's not just a yearly leap. We see a continuous increase in the figures, and it's not just a Polish phenomenon. We see the same or similar data from the UK as well. But even if I'm really convinced about the benefits of the radial intervention, there are some situations and there are some cases where I feel a bit itchy when I start my radial procedure. I think everyone has his own personal list. I don't really want to run through it, but we can agree on the fact that there are some situations where the procedural success and the applicabilities of the radial access can be limited. I put learning curve at the end of this list because my personal experience is that right now all trainees are trained for transradial access, and lately I receive more frequently call for helps from trainees and colleagues at the cases of transradial crossover, where the operator do not feel enough proficiency to perform the femoral access site. And well, we have already seen this interesting manuscript that had put the question mark about the presence of the Campo, the so-called Campo phenomenon, by comparing some 10,000 of procedures of a historical cohort to a contemporary cohort with a 50-50 distribution of femoral and radial access, and what they found in analyzing the vascular exercise complications, that transradial patients had fewer complication rates when compared to the contemporary femoral cohort, but when compared it to the historical femoral cohort, they have seen a much worse outcome nowadays. If we want to analyze these data, then we have to make some consideration. Where are the benefits of transradial approach? And we all know that exercise complication, I have to admit, if we do not count the radial occlusion, but exercise complication and for sure bleeding is equivocally reduced in cases of radial access. But how this translates to the benefits regarding mortality and major adverse events, it's much more dependent on the clinical scenario where the intervention is done, and the highest the benefit of a radial approach is at the high-risk patients. So having said this, higher the risk, higher the benefit of the radial access, we have to have a short look at the cohort of the patients with the highest risk, patients with cardiogenic shock. And at the first sight, if you examine these Kaplan-Meier curves, you can say, okay, what I see is a very beautiful benefit of the transradial access and compared to femoral, but I'm afraid that devil lurks behind the small details. And if we look at a bit more carefully the first few days, there is a huge separation of the curves, and the later outcomes do not really show any further benefit. And this is a sign of a potential treatment selection bias. So we can say that these curves are different because, well, transfemoral access was tried at some dying patients who died thereafter, and maybe transradial access was performed in patients with a better outcome. So if there's a hint for a selection bias, we have to look at the data from randomized trials, and plenty of meta-analyses are available on this project, including that of Dr. Mamas, that showed that in randomized trials, the benefit regarding mortality of the transradial approach is coherent, and also observational studies showed the same relation between transradial and transfemoral. Let me show you one of our publications where we have performed a cumulative meta-analysis of cases with of studies with randomized trials and observational trials. And if we look at these charts, we can read that as data were accumulating, and with the gray boxes, I've marked the data when more than 1,500 patients were in the data set. The significant mortality benefit appears as in the randomized trials, so in the observational trials, and the treatment effect in both analyses was 0.6 of hazard ratio, so the same 40% mortality reduction. And finally, let me just show you some data from the Hungarian myocardial infarction registry, where through this night I performed the analysis of 10,000 cases. What I would like to draw your attention is the percentage of the transfemoral in Hungary that is under 10%. So in myocardial infarction patients in Hungary, transfemoral access is performed, but in a very selective way. So that's why it's not surprising if we compare the patients with transradial or transfemoral, that there are plenty of significant differences. These people are not the same group of patients. What I did, I put all these parameters within the registry into a propensity score matching, and with logistic regression analysis, I counted a probability of being treated transradially for each patient, and using this probability, I composed a propensity matched cohort where all these parameters were balanced with this aspect. And using this propensity score matched cohort, I analyzed the 1-year mortality data from the Hungarian Statistical Office and the Hungarian Transfusion Service. And what I've seen that the benefit regarding mortality is significant among STEMI patients, not that much great difference among NSTEMI patients, but it's still very significant. And the benefit regarding the avoidance of transfusion is significant only among STEMI patients, and among NSTEMI patients only an important trend persists. And finally, I've performed a multiple regression analysis to find out what is the key player in defining the patient's outcome. And I took first the transradial access, second the transfusion, and fourth the propensity score that accumulates all the clinical parameters that's included in the decision if the patient is treated on either way. And what I've seen that all of these three has independent and significant impact on the survival. But if we look at the hazard ratio number, what we see is that there is the well-known 40% reduction of mortality, what we have seen in the randomized trials and in the observational trials. With the transfusion, there is some 70% increase in the mortality, but the hazard ratio numbers are the highest at the propensity score, meaning that all beside these parameters, access and transfusion, the patient characteristics are the main driving force behind the patient outcome. So, dear Chairman, ladies and gentlemen, let me conclude that there is a very solid data of randomized and observational studies confirming the benefit of a transradial approach. However, the actual complication rate are influenced and related to the patients and the procedure characteristics. In the current era in Hungary, with less than 10% use of transradial access, and where the high transradial and selective transfemoral access is used, the patient characteristics has more important impact on the survival than the exercise selection itself or that of the transfusion. So if this paradox exists, well, maybe, and I do not believe that this is the problem of the exercise selection. This is the problem of the patient selection among very ill patients. And of course, such a phenomenon may exist, so I agree with Jim Nolan that we have to keep the gunpowder dry, and we have to have this very short but effective training on transfemoral access and have it in the pocket. Thank you very much for your attention.
Thank you. We have shown the data from Hungary that transradial PCI has increased. In STEM patient, it was 8% increase, I think. Can you share to us about the reason why the uptake of radial approach is still low in transradial primary PCI cases?
I'm not really sure that I understood correctly your
yes.
question.
The question is that the problem that you and the previous presenter show us that the excellent result with radial access in high-risk patient But when we face a daily practice, acute, especially unstable patient, make me be afraid of treat with radial approach this patient. So do you have some practical suggestion to?
Well, I was really. I found the part of Dr. Mama's presentation about the different experience center very intriguing, and there are some very important differences when one compares UK to Hungary. One is very important that in Hungary there's no low volume centers. So we have for 10 million inhabitants we have 19 cath labs, 5 here in the capital, and the other ones are scattered in the country. And all these centers are high volume center. And this also, the uptake is very high of the transradial approach. My impression is that we are using transfemoral only in patients where we cannot do a transradial, and this is the reason of this kind of situation of blindness. It's a kind of lack of palpation, but because when I do not feel a radial, I cannot puncture it. It's my fault, I think.
Okay. This is a crucial point.
Yeah.
Selection bias.
Yeah.
Okay.
I'm from Uruguay. In our center, I believe really the proficiency of the radial approach or the proficiency of the femoral approach is lost with the radial approach grow, because in our center, it's a high volume center. We perform more than 250 procedures and more than 100 angioplasty. We are increase the complications in the femoral approach, and we increase the training, the fellows in training, they're not seeing a femoral approach, because our center is 96% radial approach, and I think this is the reason. But you would.
Thank you very much. I think this is a very important topic, and Dr. Luvard has mentioned that in 2002, transradial approach was considered as unethical. I have a bit fear right now that there is a kind of fear from transfemoral. But if we look at the data, transfemoral training in patients with low risk, I do not really feel that it's really an unethical thing to do. And where an important difference is that transradial and transfemoral catheterization, the learning subjects, the things what one have to learn is very different. For a transradial operation, again, the data that's already been presented, one needs a year to learn. For transfemoral, a few cases is enough, and but there must be a very solid theoretical knowledge behind it, and not just do the puncture and do the procedure, but the peri-procedural care of the patients is something really important, and it's not just a question of the education of the operator, but the whole staff should be prepared for these very few cases of transfemoral access.
There is a question from the panel, so can you? No. Can you give me the microphone?
I mean, I think I appreciate that may be your experience, but from a national UK experience, centres that have changed to over 90% radial utilisation, if you track their femoral outcomes over time, once you adjust for differences in case mix, there is no difference compared to centres that have stayed femoral. So I've shown that data. So I don't think that switching to a radial practice, once you've adjusted for differences in baseline characteristics of patients and procedural characteristics, results in worse femoral outcomes at the centre level. We've not been able to assess it at the individual operator level because we only have operator level data in the UK for the past 2 years, whereas centre level data we have it over the last decade. So at the centre level there is no deterioration in femoral outcomes, even in centres that are over 90% radial. And the data from the Azzolini group is very, very flawed. When you actually look at the methodology, you look at what they've adjusted for, it's a flawed analysis. The way they select cases in cases where they've undertaken multiple catheterizations, the cases included in the analysis are the cases that have actually had a complication. And so, you know, the whole methodology is not very robust.
Okay, thank you.
I just couldn't agree more with this methodological consideration. I think the main merit of this paper is that we can talk about these topics.
Okay. Thank you.
Thank you very much.
Okay, now move to more technical presentation, and I invite to the Dr. Sindbag that will show us about coated slender technique and undercoated traditional sheets. Thank you.
Thank you very much. Mr. Chairman and the panel, I'm very pleased to be here at the AIM-RADIAL Congress in Budapest. On behalf of the Axis 1 study group, I'm looking forward to present randomized comparison of coated slender versus uncoated standard sheet during radial procedure, during radial angiography and angioplasty. And my name is Birte Sindberg. I'm a nurse at the cath lab at Skyby Hospital in Aarhus, Denmark. And my disclosure. Terumo has provided an unrestricted grant for the Axis 1 study. Due to the increasing use of the radial approach in UK and also in Denmark, and I'm very glad to say that in this company, the aim of and the background of this study was to examine whether the standard sheet with a smaller external diameter and hydrophilic coating had any impact on spasm tendency, pain, success rate, and post-procedural radial patency compared to a standard sheet. That was the background. And we are a high-volume center in the Western Denmark with 5,500 procedures per year. And from December 2015 and until July 2016, we included 1,000 patients in this study. It was an all-comer study, and we included consecutively included patients for elective CID or PCI, as well as non-STEMI and STEMI patients. And randomization was stratified according to friend size, 5, 6, 7 friends, and gender. If the patients were included in the cath lab, where the nurse made a pulse oximetry test, the Barbeau test, and if that test was positive, the patient were asked by the contact nurse or by the doctor if they would participate in this study. And the exclusions criteria are, of course, a negative pulse oximetry test and planned CID PCI procedure with 8 friends equipment. And here you can see the patient's characteristics, the baseline data. And as you can see, there's no difference between the two groups due to a successful randomization. The endpoint of this study is pain during sheath insertion, pain during procedure, successful radial procedure, analgesics and sedatives during the procedure, and radial patency evaluated by the reverse Barbeau test after the procedure. And as you can see here on the right side of the slide, you can see the Barbeau test, where A is an open vessel, and D is a closed vessel, and B and C is in between. The methods we used: the patients were asked for the worst episode of pain during sheath insertion and during the procedure, and after the sheath was removed. As illustrated here, we use the visual analog scale. 0 is no pain, and 10 is worst possible pain. And now we're moving on to the descriptions and results. As you can see here, 95.3% of the patient had a radialis sheath inserted. 4.7% didn't. Successful radialis procedure was happening in 88.6%, and 11.5% they were not. They could be converted to femoral access, and that was due to spasm tendency or too short vessels. The reverse Barbeau test were done at the ward, and that was when the TR band was removed and the patient had to be discharged. The nurses at the ward made the reverse Barbeau test. And in that case we found 80.72 with the open vessel, and if I may let your attention to D, 1.51 with closed vessel. That is 13 patients. These patients were asked to come back 1 month after discharge, where a new evaluation were done, where we made an ultrasound they had an ultrasound performed and another Barbeau test. And that showed that 9 patients had an open vessel and 2 still had a closed vessel, and these two patients had no clinical symptoms. And here we have the results of the pain during the sheath insertion. And here we see a significant difference between the two groups. If we take the slender group, 72% of the patients stated a VAS score from 2 till 0, whereas in the standard group, 65% stated a VAS score below 2. And this is a significant difference with a p-value below 0.05. And that brings me to the results. Use of a slender sheath was associated with less pain during sheath insertion, whereas no difference was observed in any of the remaining endpoints. There were no difference in pain during the procedure. There were no difference in use of sedatives and analgesics during the procedure. No difference in proportion with successful radial procedure, and no difference in radial artery patency evaluated by the reverse Barbeau test. So the conclusion is that the use of a slender sheath was associated with less pain during sheath insertion, whereas no difference was observed in pain during the procedure, use of sedatives and analgesics, procedural success or patency following the procedure. Thank you very much.
Okay, there is any question from the panel? Okay, when you evaluated the pain, at the end of the procedure or when you remove the compression?
That was that was at the end of the procedure, after the sheet has been removed.
Oh.
We did it 2 times. We did it when the sheet was inserted, and then again
So
when
immediately after the
immediately
insertion.
after the sheet were inserted, and before heparin and nitroglycerin was given.
So according to these results in your cath lab now, you use only slender sheet, coated sheet.
No, not particularly. No.
Why?
That's an economy question.
Okay.
Yeah.
So now do you select some particular patient for this sheet, or you're planning to not use anymore?
We don't plan anything with
Okay.
the slender sheet. No.
Okay. This is important. Okay. Thank you for your presentation. The next speaker is Dr. Vorpali, that will speak about retrospective analysis of conventional radial Tiger catheter use.
Dear Chairman, dear gentlemen, ladies, it's a great privilege to present our data from our study group here in this very nice meeting. We became big fans of radial catheter 6 years ago. We had the privilege to meet Professor Ikari and Dr. Yoshimachi last year at Tokai University, and this is actually a picture of Enoshima in Japan, very close by. So the data is very convincing. The Wuppertal Heart Center, we have 6 cath labs. We are doing about 8,000 diagnostics per year. And we did last year we crossed the 50% quote of radial catheters. So we became big fans now. Oh, I have nothing to disclose. So for diagnostic, what are the options? We have the conventional catheters. I personally prefer the AR1 for the RCA, and most of you may also use the JR 3.5 or 4 or FL or JL 3.5, depending on the company catheters, to do the diagnostic. So on the other side, we have these very specific catheters with a fancy concept of one catheter fits both sides. For example, the Tiger catheter, which we are using, we're not using Kimney or other catheters, we're using the Tiger catheter. And it promises that it's specifically designed to support and alignment during cath, and that it's available in different sizes and it fits for various anatomies. There's a previous study from Kim from Korea published in 2006 in about 160 patients, prospective randomized, and they showed very good success rates with their Tiger 2 catheter. It's greater than 90% for left and 100% performance for the right coronary artery. So we were asking what's in all comers in our centers. This may not happen during radial catheter. It happens during femoral catheter with an 18 French sheet, which broke during structural heart. And I just came from Rome, and we have a lot of imaging guys showing excellent CT angiograms. And the question is, can we allow to have a poor diagnostic even when we doing a radial catheter? And sometimes these kind of things happens with your Tiger catheter. It takes some time to move into the ostium. here of the left side. And then the moment you inject, the catheter jumps out. A lot of the colleagues may have experienced this. And then you move on, go back, put the catheter again into the left ostium, and again it jumps out as in the second you're pushing in, give too much push with the contrast. And then you start and having a poor angiographic images, and at this moment you can or you should change your catheter system, and we have switched in this case to an FL catheter, and it suits perfectly. It's due to the angle it stays much better inside the ostium, and you get excellent images, so you can have the best quality of images for your patient. So what we did is we were very interested how it looks like in our cath lab. We have people using the conventional catheters. We have people using the specific radial catheters, and we have these people using various catheters. So what we did is we looked for our patients where we did a transradial coronary angiography from the right radial in the time course of 2 years. We had to exclude a lot of patients to have comparable results. We excluded all the CABG patients, the left patients where we did a left ventriculography, where we did a left radial approach or a conversion to femoral access, or where we did a PCI. So overall we had 273 patients. This is how the baseline characteristics look like. They're pretty much well distributed. We have some kind of local bias because we are offering these radial technique specifically to obese patients to avoid the problems with compression or bleedings after the procedure from the femoral. So this reflects also in our baseline characteristics, where we have a BMI from about 28 to 29, almost 30, which is quite impressive. It's not US American impressive, but for Europe I think it's pretty impressive. So what happens? We had a crossover rate. That means a crossover from the standard catheter to a Tiger catheter, or from a Tiger catheter to standard catheters in 15% of our patients in the Tiger group, and about 5% in the conventional group. This is way higher than reported in the previous study from the Korean group, but this reflects somehow the all-comer, all-day work in our cath lab, where when you feel uncomfortable, then you change your catheters. This was significantly higher in the group of the Tiger catheter. Then we look for the fluoroscopy time. The mean is about 2 minutes for the standard catheters, as well as for the for the Tiger catheter. And we have also we have observed some cases where it was almost less than 20 seconds. So you can be very quick, and this is what it's usually how it works. But in the case you have to change your catheter, of course your fluoroscopy time increases significantly, and it doubles, almost triples in both sides, as well as in the conventional catheters or in the Tiger catheter arm. The same with the radiation dosage. You need more time, you need more angles or projections. So of course the radiation dosage is rising as well when you are in the trouble or in need to switch your catheter. On the other side, if everything works well, your radiation dosage is almost the same in the conventional arm as compared to the Tiger. Contrast agent, another I think important issue, is about 50 cc for our diagnostic in our cath lab, which is a little high, or higher in other than in other centers, but overall lower than for a CT. And we have the same trends here, that if you are in the need for a conversion to different catheters, of course your contrast agent consumption increases. So in the summary, what we observed in our all-comer center is that we have seen way higher rates of conversion rates in the Tiger catheter, and this leads to more radiation and contrast conjunctions in both groups. But what we believe is that the conventional catheters may be the primary choice for diagnostic coronary angiography from the right radial approach. Thank you.
Nice presentation. But you have shown that the crossover rate is very high with the Tiger catheter. It was 15%. And that makes the contrast volume becomes larger and the fluoroscopy time is longer. I'm not sure. I think this is a retrospective analysis, right? And there is no balance between sample size in patients with conventional catheter and the Tiger catheter. It's not well balanced. So I think from my experience, we have started Transradial approach in 2010 at that time, and we used the Tiger catheter in almost all of the diagnostic procedures, and the crossover rate is very, very low. For example, in a patient with aneurysm with a large aortic, then we have to use the unplugged catheter or even an extra backup catheter to engage the left ostium. I don't know whether
I think what
can we ask the audience how many of you are still using Tiger catheter for diagnostic procedures in the cath lab? And how many of you are still using the conventional catheters for a diagnostic? It's almost well balanced.
Now, what I want to point out, sometimes with the Tiger catheter, we are maybe satisfied with an imaging quality which is not 100%. So you have an indirect display of your coronaries, or like in the live case before, you're not really in the right ostia. So it's not the perfect quality which you may have with the other catheters or with a different catheter. It may be sufficient, but it's not perfect. No. Hand injection.
Hand injection is something very important when you use Tiger, because you have more feeling and better just the longer contrast. I've seen many people, especially in our radial course, that we often say with an automatic injection system, they keep not using.
Okay. In your experience, there is a learning curve for this catheter. So you
Definitely.
So probably the 15% is related to is higher in the first part of the study.
Yeah, we started our radial program 6 years ago, and this is from the starting 3 or 4 years ago. So we had the learning curve of 2 years already. So we are 8 attendings who are doing these radial catheters, and these were all attendings performing these procedures in a high volume center. So with greater than 200 cases per year.
Okay.
So we try to avoid this bias by selecting this year, this time frame. But of course, there may be some selection. What we see from the raw data is we have performance of 20 seconds up to 4 minutes. But the question is overall, is time a marker of quality for a diagnostic? I'm not sure about this.
Okay. Thank you for the presentation. And now move to the last speaker that will show us the benefits of the possibility to use the ulnar approach. Dr. Gokro, I hope that my spelling is right. Is there Dr. Gokro here? No? Ah, okay. Yes. And the last presenter is Dr. Gokro, please. Thank you.
Good afternoon. Greetings from India. Yeah. First of all, I will extend my heartfelt thanks to Dr. Tran and the organizing committee who has invited me amongst this august audience. I'll be presenting my experience of ulnar artery intervention in an era of among the all radialists. When I started my career, I was femoralist for a year only and then switched on to radial. I worked on radial for 3 years, performed almost 6,000 cases, and for last 4 years I am switching to ulnar. And as a default ulnarist, my lab has 40% cases every day. At my center, the annual turnover is 2,500 cases, and in last 1 year, we had only one femoral case, and 40% or more default primarily as a radial. So, do we really switching over to ulnar in time to come? So, nothing to disclose. So, in the background, when all of we are switching from femoral to radialist, where do we stand? As we know, the radial cannulations have been accepted as a default technique in most of the part of the world because of the advantage of the femoral. And these are the well-known, discussed and known factors why do we are going towards the radial. So can ulnar artery be a viable alternative to radial artery for coronary access? Yes. But we had a very important study in 2013 where they were concluded that trans-ulnar access is inferior to transradial, and the reasons were very limited. Reasons were the operators were inexperienced to the tune that there are less than 20 to 50 cases of ulnar access approach, and even they have attempted those ulnar arteries who are low in volume or not palpable even as a part of protocol randomization. So, high crossover rate in transulnar group made it inferior to radial in that particular study. So, does experience matter? Yes. This was our data which presented to ACC 2015, where if you see in the initial 50 cases, if you see the spasm, hematoma and crossovers are more with an odd ratio of 3.16. But as the experience increases from about 50 to 100, the odd ratio is significantly reducing, and after 100, it's almost same. So as the operator's experience increases, the chances of spasm and crossovers is reduced significantly. Therefore, the experience does matter. So, does ulnar artery cannulation still remains inferior even if performed by experienced operator? And therefore, the study was conducted. The prerequisites were default radialist with a minimum experience of 50 transulnar cannulation. Cannulation attempted only if ulnar artery easily palpable and anatomy is favorable. This was the biggest limitation or reason for success. Trying to use an ulnar artery which is a low volume or not palpable as a protocol of a study will give you biased results and may show inferiority. This trial was designed as a randomized, single-center, non-inferiority trial where 1:1 randomization was done and 1,270 and 1,262 cases of transulnar and transradial access were used. The primary endpoints were composite of major adverse cardiac events, major vascular events which included large hematoma and vessel occlusion during hospital stay and the crossover. Secondary endpoints were individual component of these primary endpoints, the vessel spar, if you have had more than 3 attempts, or total procedure time, fluoroscopy time, and the amount of contrast used during the procedure were also considered. The exclusion criteria was the same standard where if you are not able to palpate either radial or ulnar artery, if you are going for a high risk primary angioplasty, patient in cardiogenic shock, or patient already on chronic hemodialysis, or various peripheral vascular disease, Raynaud's, or skeletal abnormality of the forearm where you cannot access the vessels easily. And on those cases of post-CBG where you want to do the graft angios were excluded. So out of these 2,700 patients, the 2,556 patients were enrolled, and the data was not complete for 24 patients. So trans-ulnar were 1,270 versus 1,262 transradial access we used for ITT analysis, and for per protocol analysis 1,176 for ulnar and 1,140 patients for transradial were considered. Primary endpoints, if you see, there was no significant difference in these two groups of trans-ulnar versus transradial. If you see the major adverse cardiac event, they were similar almost, 2.9 versus 3.2% without any significant p-value. Large hematomas, there was no significant difference in the trans-ulnar versus transradial in this group of 1,200 patients. Crossover was not significant, whether you use the trans-ulnar or the trans-radial access. Spasm was relatively less in trans-ulnar group as compared to trans-radial. So when the analysis was done as per ITT, intention to treat analysis, all these outcome parameters were present in the zone of non-inferiority, except the large hematoma, though it was in the zone of inferiority, but the confidence interval was, upper bound was beyond the non-inferiority margin 1.93. In per protocol analysis, the data was same, other than large hematoma. Every event was in the zone of non-inferiority. Among these two group of patients, when we saw that out of 48 patients where transradial crossover was done, if you see the out of 48, crossover to another radial was 10 patients. So 38 patients went femoral. But if you are expert, you have proficiency in ulnar, then you have a chance to go to the ulnar. So out of 48, we had 10 radial and 36 ulnar. So out of this group, you are going for 2 femoral only. And if you are only proficient in radial, you are going to for 75% femoral. So if you are experienced, proficient in ulnar cannulation as well, after an initial experience of 50 cases, you are through with the upper arm access. So if you are proficient in ulnar, you have 2 radial, 2 ulnar, 4 access as compared to femoral. So all major adverse problems of femoral access are taken care of. Therefore, with this proficiency in ulnar, here we have shown that 75% patients were not shifted to femoral. So experience at our centers right now, we have more than 2,065 till I arrived here, and we have done more than 243 angioplasties as a default. So trans-ulnar cannulation is also an easy, safe and comfortable procedure without any fear. The concept of that is a deeply seated, more hematomas and difficult to cannulate. After 50 procedures, every operator is through. So if used as a default strategy, it is non-inferior to transradial approach. When performed by an experienced operator, it's a reality and not myth. Thank you.
Excellent study. I just want to ask whether did you evaluate the diameter of the radial and the ulnar artery in the trial?
Timings of?
The radial or the ulnar artery.
Puncture time or total procedure time?
No, I mean the diameter. Did you
Diameter, okay. We have not done the ultrasound study. all clinically palpable ulnar arteries are included. As such, any vessel which is palpable clinically, it is 2 millimeters plus, so it can accommodate easily 5-6 French catheters.
I think the others want to ask something, please. George.
Congratulations, Dr. Gokro. I enjoyed your talk, enjoyed your papers, and I must say with pleasure, because you open a new route and you suggest a new route. As we started 3 years ago, because we published the Hour of Artemis. I'm the first author. My name is Hahalis from Greece. So it's advancement what you showed to us. I think, however, that the two trials are not comparable.
Yes.
They are not comparable because we selected the ulnar artery and randomized it to the radial artery as a default strategy. Not just when we found that the ulnar artery was palpable, and was not palpable in significant minority of the patients. When you have a palpable artery, I agree totally with you, you can have very good coronary procedure. If not, then the problems begin. And the problem is that the crossover rate was exactly the difference between your study and our study. We were experienced in transradial approach. We had a crossover rate of 5.9%. You are a center of excellence. You have a crossover rate in your paper 3.8%. But it is amazing to see that you have only 1.5% of patients not having palpated the ulnar artery. It's too low. This is the first remark, or one of the remarks. And the second is, you had a mixed population of PCI and coronary angiography patients, but the duration of the procedure was only 7 minutes. So I don't know how it comes when you have a mixed population to have only 7 minutes procedure. It's what I would say. And the other one is, you have, it's very interesting when we make studies and include the occlusion in the primary endpoint, not to have examined the radial artery by ultrasonography and having examined it by palpation and clinically. So I think we must all know, in my experience, that it is a good alternative route. If you take patients who have occluded radial artery, like Dr. Kedev's results, then you have almost in every patient good ulnar artery, because it's a compensatory mechanism. You fail almost never. Now, concerning the learning curve, we were experienced. We had no learning curve with regard to crossovers. We had a learning curve with regard to fluoroscopy time and contrast volume use. So again, I congratulate you because it's a very big advancement, these papers on this field. Thank you.
So I will give the mic to Dr. Roberts. I just want to make a comment first. Who is doing ulnar when the radial fail? So I guess, I mean, you know, many radialists have already learned the ulnar. And if I may just have a second question, who think that the ulnar should remain like an alternative site? And who think that the ulnar could become the default artery access? Okay, so one guy is but I think that's overall that everybody agree that you have to learn the ulnar. Yeah. I think one point I will make about your study, which is very nice, large population, is that when you design a study, of course you select the endpoints. Yeah. And when you design when you take as endpoints MACE or overall vascular complications, both are very peripheral arteries, so you don't expect to have much difference. Yeah. what I have, my feeling, and I may be wrong, but when I use the ulnar, I mean, it's a little bit more tricky. I mean, and first of all, the only thing that for me changes is that sometimes you will stick the nerves and the patient will feel something. And that usually you don't get that with the radial because there is no nerve. And it's still interesting also that it's a little bit more complicated to compress. That's why you had also some larger variation from hematoma.
I would like to put a comment. The chances of ulnar paresthesias we have not observed in these cases. Secondly, the hematomas which were observed, they were only lower 1/4 of the forearm only. There is no major hematoma at all. And thirdly, the problem of not palpating pulses. The problem is if you extend the hand and with abduction, the ulnar artery is palpable here in most of the cases. Only few those cases where there is a Montgomery degeneration or calcification, you may not be. We have also observed tortuosity of ulnar artery as well here in the flexor retinaculum. We have seen 2 cases of ulnar loop as well. So the question is, if it is palpable, you can do at par with radial. And the question which was very much raised by sir, that fluoroscopy time it was a mixed population, you are absolutely right. So initial data was of 1200 cases, it was only ulnar angiography. Right? In the now our experience with 2000 cases with the ulnar angioplasty, time is the same radial angioplasty versus ulnar angioplasty. So this was the data with the only diagnostic.
A comment about ultrasound. I published last year, December 2015, 565 consecutive patients where I ultrasounded radial and ulnar. And there's clearly a role for both radial and ulnar. If we use a cutoff point of 20% or larger as the cutoff, the ulnar artery was larger than the radial and 6.5%, and the radial was larger than the ulnar and 37%, and the other is about equal. You can't tell that by palpation, and so in my practice now, approximately 5% are ulnar, because I do 100% ultrasound guided, and 95% radial, and you can't tell again by palpation. If the radial is 1.5 centimeters and you put a 6-French sheath in it, you will not complete the procedure because of spasm. And the ulnar may have been 2.6 millimeters, not centimeters. So yes, we do have data. There's a role for both.
Thank you.
Hi, nice speech. Holtz is my name, from the Netherlands. As a hand surgeon, I want to ask you, you has had 2% hematoma. Did you actually research the paralysis of the hand for it? I mean, the ulnar nerve, as you know, is direct next to the artery. Instead, where the radial artery is, there is no nerve, motor nerve.
There was no gangrene, though no VIC, and these were the patients. As soon as the next 24 hours the edema subsided, there was nothing, no change of color of hand or gangrene. So we have not observed in 2000 cases. And moreover, if you are a hand surgeon, you are considering the circulation. We have the radial, we have the ulnar, we have the median artery and so many collaterals which Dr. Nohan has shown. So there are so many collaterals are there. With a myth that these patients will develop gangrene is very... Only one case, which was probably because of peripheral embolism, which was shown here in the finger in the last lecture. And so I don't think that there is chances of, because of ulnar occlusion.
It's not the occlusion, it is the hematoma. When you have a mechanical pressure neuropathy.
Yes, if there is a hematoma, first there will be VIC, pressure compression symptoms, right?
Yeah.
And in all diagnostic or even in the plasty, the hematoma was never beyond the lower 1/4 or lower half of the arm. And this is so many spaces, interstitial space and everything to accommodate these small hematomas. Nothing to produce such a tense hematoma to press the nerve, to produce the symptoms, or press enough to compress the radial artery as well or other vessels. Because the pressure is 100, 120 millimeters mercury.
It's not the vessel, it's the nerve which is important. Because it's 60% motoric, 40% sensible, and when it's very long compression, you have paralysis.
In the lower forearm, below the flexor retinoculum, there is a lot of space between these tendons.
Yeah.
So I don't think there will be direct pressure over the ulnar nerve. It's already 2 to 3
It's next to it. Tenths of millimeter next to it.
But that's why I think it's a very valid point. 2 points.
Yeah.
First of all, because of the nerve, it's next, but sometimes the nerve can be just above. So usually in my experience, I'm going to tell the patient, if you feel anything like funny when I'm trying to find the artery, just tell me, because otherwise you will have some patient jumping just because it's painful. So that happens sometime with the ulnar. That's the first point. And I think that then the question about what could be the consequence of hematoma on pressuring the nerve, it's a very valid point. I don't know if anybody in the room has had long-term or mid-term consequence about some hematoma on the ulnar nerve. I mean, personally, I've never had like a mid or long-term consequence. I don't know if anybody can say, George.
I agree with Dr. Kagro. There may be some lightening pain in 10% of the patients, but no nerve damage has happened except for one case, which has been published an abstract in AIM-RADIAL 2014 from a Spanish group in 1,400 ulnar interventions. And there was one paresis which resolved after some weeks. So trauma is transient. There is no permanent damage. Even if you have hematoma, you may have more hematomas than the radial puncture because it's more cumbersome in our experience. But no problem with nerve damage, ulnar nerve damage.
George, can I ask you, what is the dosing of heparin you give for the procedures, 5,000?
We are randomizing now, as I was saying in my next talk, 50 units per kilo versus 100 units per kilo, and I will discuss about it in my talk.
2,500 units for all diagnostics, and for angioplasty 7,500, as 70 to 100 units per. Just to answer your query, the most important point when there will be ulnar injury, you have to put the local anesthesia lateral to the ulnar artery. Yeah. The ulnar nerve is medial. So if inadvertently this local anesthesia goes directly into the ulnar nerve, at the time of that when the needle touches the nerve, patient will have paresthesia and he may snatch the hand.
Yeah.
So you will have to keep a watch that your local anesthesia, which is we give 1 to 2 ml, it is lateral to the ulnar artery. So in the beginning, learning curve, because of any reason, he puts medial to that, and that needle touches the nerve. It gives us immediate tingling and paresthesias. So it should be lateral.
Okay.
So we have not observed at all.
Okay, although a small question, the spasm of the artery, how did you define that?
If honestly you ask me, out of 2,000 procedures which is done by me personally, I have observed hardly 2 cases of ulnar spasm.
Okay.
Honestly. The other data, which was because of my co-operators, the fellow trainers, when they rotate the catheter 360 degrees, 3, 4, 5, 6, 7 times, just to hook, at that particular time, the whole circumference of the artery is stimulated, and then the spasm comes. So the experienced operators, he does in a very short time, 1 or 2 rotations, he hooks the right coronary, left coronary, he doesn't have spasm at all. Though I have observed the spasm in the forearm, in the arm, in the subclavian as well. Last week there was a serious spasm in the brachial artery. 5 to 7 kg weight was to be taken to bring the catheter out. So rather than giving general anesthesia, give local intravascular dilators with the nitroglycerin, wait for as the anxiety goes, your catheter is free. Yeah.
Professor Oliver, regarding using the heparin in diagnostic angiogram by transradial approach, I usually like to give 5,000 unit of heparin, and I have found that the radial arterial occlusion rate is very low. If I use a bit higher amount of heparin, it does not create any problem. And regarding the switch over of from radial to ulnar, why we are radialist? We are radialist to avoid a big road. We have come to a smaller road, number 1. Number 2, there is another big road, that is brachial artery. We have avoided that because of hand ischemia. And if I do once injury to the radial artery, then I switch over to the ulnar artery, meaning that I am injuring the brachial artery equivalent. As because I am injuring radial, I am injuring ulnar. Whether it should be ideal or not, my question is to you.
Primarily, we are radialists because of it's easily palpable and superficial. We don't want to waste our time. We are in a hurry, and our learning curve is slightly more as compared to radial in ulnar, because it is the position of the hand which is very important when you are puncturing. Right now, if you see your ulnar artery is palpable, the moment you keep it, the ulnar artery is not palpable at all. So the position is to be kept during the puncture time absolutely perfectly, and it is hardly 1 or 2 millimeters below the skin. It's very easy to, but the hand should be kept in exactly extended and abducted. Same is this story in the radial. If it is extended and adducted, the ulnar puncture is in more than 90% success in a single puncture. But if you are putting it like this and trying to do it, then it's difficult. Then your puncture time will be second or third time even in radial, even if it is superficial. And as far as diameter is concerned, RT of 2.5 millimeters enough to take a 7 French, where you can have the bifurcation as well.
Yeah, I would like to have a question also. I would like to ask, you choose the contralateral radial artery if you fail with the ulnar artery, or if you fail with the radial artery, you choose the contralateral ulnar artery, and vice versa. So yes. My question, it was on your study. So my question is there any time, any moment in your personal experience you use the ipsilateral ulnar artery? For example, you tried a bit. Is there a point that you don't switch to the contralateral because it's a tedious one, it's time consuming? So is it a time or a point you say, yeah, I can go, I didn't have any damage to the radial artery, I go with the ulnar artery? Is there cases like that?
Absolutely great question. If on the same radial artery we are failing, and if there is already local hematoma, in those particular cases we switch to the other arm. Otherwise, if there is no local hematoma, we fail because of radial spasm, and the ulnar is palpable, you can go. Because once there is a radial spasm, the volume of the ulnar artery will increase, because the flow has to go to the hand. So in that case, it is easy.
Yeah, you mean that local hematoma and a spasm is an indication for the contralateral arm? It's your experience.
Certainly. What is the cause for switch over to other side? Okay. And we look for the anatomy again for the left hand. The radial is easily, if you are short of time, go radial. If you have time and good palpable ulnar, then accept the ulnar as well. Yeah, the only advantage is 4 axis you have.
Yeah, sometimes I do it myself, and so I don't know where to stop. So I don't have such much experience as you with the ulnar artery. But sometimes, if I even have a little bit local hematoma, I go with the ipsilateral, but I don't know what consequences I will encounter in the future, but so far, no problems. So
even when we have used around 10 or 12 cases so far, ipsilateral radial and ipsilateral ulnar with hematomas, things melt away within the next 24 hours, while keeping watch, of course, on the hand for the ischemia. So as default, I can't say that you should do it, but the outcome was in real world, there was nothing happened.
Okay, I think we will close the session. I don't want to be rude, but I think otherwise we're going to be very late.
Good afternoon. It's time to begin this session. Afternoon session will begin with a live transmission done from Szeged. So do we have Szeged connected?
So do we have Szeged connected?
Imre, are you there? I see you.
Dr. Hungi?
Yes.
Imre,
hello.
Are you there? I see you.
Hello, Yves. Nice to hear you. Unfortunately, I can't see you.
Nice to see you.
Nice to welcome you in Hungary again.
Nice to see you.
And we are happy to be a part of this very prestigious, very important Transradial meeting. So, can I speak on the case and the procedure? Of course, please present the case.
Of course.
Thank you.
Of course, please present the case.
Thank you. First, I would ask Dr. Taiti to present the clinical situation of this patient. Dezső, akkor most bejátszátok a Petinek a prezentációját?
Dear colleagues, dear guests, let me show our CTO live case, key eye. He's an 80-year-old male patient with a BMI of 36. His angina status is CCS3. Among the risk factors we can find hyperlipidemia and hypertension. Echocardiography showed diffuse hypokinesia with decreased left ventricular function with an ejection fraction of 23%. Among the comorbidities there is type 2 diabetes mellitus, atrial fibrillation and heart failure. A few days ago, he was hospitalized due to acute coronary syndrome with a non-ST elevation MI. The coronary angiogram revealed RCA CTO, significant RCX, and not significant LAD stenosis. An urgent RCX PCI has occurred with 2 drug-eluting stent implantation. Here we can see the right coronary angio first. And here we can see the left system. And we can see it from a different angle too. And this is the last angio after the RCX PCI. Thank you for your attention.
Imre,
At the panel, I have Sasko Kedev.
Yes.
At the panel, I have Sasko Kedev with me.
Dr. Arada,
I have
Dr.
Dr. Arada
coming from India.
and
So we are waiting for your
Dr.
analysis.
Gokro
of this,
coming from
lesion.
India.
How
We
do
are
you
waiting for your
evaluate the
analysis
CTO
of this
score?
lesion. How do you evaluate the CTO score?
Yes, thank you, Yves. Actually, first I would introduce the team of our cath lab. Actually, Magdi is the most experienced CTO scrub nurse of our team, and András Katona is an experienced CTO operator as well. Actually, he is well known for the radial community because last year in Manchester, his case won the Best Radialist of the Year prize. So András is not unknown for the radialists. Actually, something about the lesion. As you could hear, he is an acute coronary syndrome case, and the culprit lesion was done already. But we considered to do this CTO also because of the heart failure symptoms and to as complete revascularization as it possible. Your question on the JCTO score, we consider this lesion, this occlusion, longer than 20 millimeter. There is practically no stump at the rise of the acute marginal branch. There is practically no calcium in this vessel, at least no visible calcium in this vessel, and no real tortuosity. So altogether, I considered that this is a JCTO score 2. I must tell you that we were a little bit faster because this 80-year-old patient has limited tolerance. He is a frail patient actually, and we had to be fast. So we are around the end of the procedure, but I would show you the setup. As you can see, if you can focus the camera on the right hand, and then on the left hand, there is a biradial procedure. I must tell you that this is exceptional in our cath lab because the CTO is usually done with a hybrid access. So we usually use the right radial and one femoral. But just because of the age of the patient, because the fragility of this patient, we try to do it from biradial, and also because of the AIM-RADIAL. And now I would show you the angiogram, the simultaneous angiogram today. I don't know whether you can hear me well, and please interrupt me if you have, in the meantime, any question.
We hear you perfectly, and we see you also, but we don't see the angio. Ah, okay.
We hear you perfectly, and we see you also. But
Thank
we
you.
don't see the angio. Ah, okay.
Thank you, thank you. So actually this is the today angiogram. This is the simultaneous angio. We considered to start with an antegrade wire escalation strategy, and we considered as a second option, second strategy, the retrograde way through the septal collaterals. This is our normal setup. We use the 4 centimeter, 7 French guiding catheter into the contralateral side, into the left main, and 1-0, 7 French implants left into the right coronary artery. For the antegrade wire escalation strategy, we use the Fielder XT as the primary wire and the fine cross microcatheter. I don't know whether you agree with this start of the procedure, or you would have started
For the moment, we don't see you. We have,
with another strategy.
For the moment, we don't see you. We have,
Sasko, what your opinion about the strategy defined by Imre?
I will also use the same strategy, so Fielder XT, because it seems that there is a microchannel, visible microchannel, pretty long lesion, but I agree with the same strategy. Fielder XT, maybe Fielder XT and fine cross.
Hallom az ő hangjukat, mondtad, hogy nem is hallom.
I think we all agree that there's a good chance of getting through antegrade, so we all agree on your strategy, and we are really curious on the result. So we all agree on your strategy, and we are really curious on the results.
Okay, you can proceed. We see you now.
Okay.
We see the image now.
So
Is it the side hole catheter, the one you have in the
we see
right?
the image now. Is it the side hole catheter, the one you have in the right?
Actually, in the right, there is a side hole launcher, 7 French launcher. Sometimes it's a debate whether through the radial, the 6 French should be preferred or the 7 French. Of course, with a simple lesion, we use a 6 French guiding catheter, but our standard is that for CTO, we use 7 French even through the radial artery. If the radial is not compatible with 7 French, which is quite a rare situation, we switch to femoral, actually. So it's a 7 French side hole implants left 1-0 catheter.
Are you always
This
using
is
7
the
French for contralateral injections?
Anatomy of the collaterals.
Are you always using 7 French for contralateral injections?
Practically, yes. Yes, thank you, Sasko. Welcome you also in Hungary. We haven't met each other for ages. So, yes. the only exception is that we are sure that we don't do a retrograde, and the contralateral guiding is used for visualization only. But because it's usually an option to go retrograde, we use 7 French to increase the passive support and to allow us to use, let's say, trapping or anchor balloon in another branch. So that is the standard. It looks that there are some nice collaterals from the septum, but of course we started the antegrade. I must tell you that this case proved to be much easier than we anticipated. This is the Fielder XT in the fine cross. The tip of the fine cross is at the proximal cap, and with some attempt, I hope that you can see well this fluoro store image, that we could follow a small channel, and it looked that this track is following the vessel architecture and actually the lumen. Here we were not sure whether we are inside or not. This is a contralateral injection, and we followed the advancement of the guide wire. Now it seems, at least for me, that we are in. We convinced on the on the position of the guide wire with another projection with the contralateral injection, and it seemed that there is an intraluminal position of the Fielder XT. Actually, we removed the Fielder XT wire from the fine cross when we advanced the fine cross into this distal position, and this is the removal with the trapping balloon of the fine cross from stiff supportive wire, which is a balanced heavyweight wire. So with an intraluminal position of this BHW wire, we did predilation, and actually we already stented the lesion. We had to be a little bit faster than we expected, but the patient is a little bit out of the tolerance, so and which can be understood because of this poor left ventricular function and the heart failure symptoms. This is the result of the predilation. Now it's a question after wiring the CTO. It's a usual question whether to use IVUS for assessment of the possible subintimal passage of the wire. I don't know whether you have done IVUS in this situation or not.
I will personally proceed just based on this angio result from a distal.
I will personally proceed just based on this angio result from a distal
part.
So the same for me, Imre.
I practically I agree with you, Sasko.
The same for
this
me,
distal vessel is remodeled.
It has been shown that
even IVUS cannot give you.
this distal vessel is remodeled, negatively remodeled, so even IVUS cannot give you what is the true size of the vessel.
I know that many people
So you have to imagine what will be the true size of the vessel. Personally,
majority of cases.
I know that many people are using IVUS. Personally, I'm not doing majority of cases.
I agree with you, and I think that this is the real world, at least in Europe, and probably. Thank you, Zoli. And actually, I know that from Dimitri Karmpaliotis and from Manuel Brilakis that it's the same in the United States as well. So we stented. Actually, we wanted to cover all the diseased segment. So we implanted first 2.75 Science expedition into the distal part of the main branch, but just before the bifurcation. So we didn't there was no indication to do a crossover stenting.
What is the length?
It's 48. 48, and this second stent is 44.
New one.
Yes, yes, and there is already a third stent just from the osteum, because the osteum was also diseased. There is a little bit slower flow. We repeated it after some adenosine, and it seems to be that there is no significant residual lesion. There is practically a TIMI-3 flow, and also with an angio from the left, it looks that there is no retrograde filling of the right coronary anymore, which I think is important result of this procedure, because before referral to our center by transthoracic echocardiography, there was significantly increased flow velocity in the proximal LAD. Probably because there was an increased myocardial territory, and I think that one of the important indication of this procedure is to unloading the somewhat diseased LAD. I don't know what's your opinion on this situation.
I agree with what you say. Are you planning to do a FFR in the LAD?
I agree with what you say. Are you planning to do a FFR in the LAD?
Actually, it's yes, we are ready to do an FFR. We haven't done yet, but we already prepared because it's a good question and a good idea.
I think for the audience, if you do the FFR before opening the RCA,
for the audience,
the chance to have it
if you do the FFR before opening the RCA,
is great. So
the chance to have it
it's important. You
positive,
cannot
I mean less than 0.8
is
great.
if the right is not.
It's important. You cannot interpret the result of the FFR in LAD if the right is not patterned. So now it's a good time to perform the FFR to see if we have to treat also LAD or not.
Yes, yes, thank you. It's, definitely, it would be and will be higher than the before opening the right coronary. Of course, just to limit the time of the procedure, we did not measure it before because it would not have been a real value. But now we measure it. And in the meantime, may I have a question to you, Yves and Sasko?
Yes, of course. Yes, of course.
Actually, Thursday is the normal CTO day for us, and we have another patient from this morning who actually was a little bit more difficult than this patient, at least technically. So if we still have time in this session, I would be happy to introduce his case as well. Of course, it depends on you.
We still have 10 minutes, just 10 minutes. We still have 10 minutes, just 10 minutes.
Okay. We try to measure fast the FFR. Okay. Ja, befogom egy kicsit.
Imre, this is Daniel Ardi. Meanwhile, you are measuring FFR. Can you comment on the hemodynamics during the procedure?
Meanwhile, you are measuring FFR. Can you comment on the hemodynamics during the procedure? Were there a pressure drop as a reason for the slow flow in the patient?
Thank you for this really important question, because we cannot forget that there is a patient around the vessel. There was no any instability. And actually, kicsit menjünk mehet arra, mert nem tudom innen. Egy kis tesztet adhatnátok. So actually, it's a really important question if we go retrograde. Because in this patient with a very low ejection fraction, the temporary occlusion of the only somewhat good vessel, the LAD, could have resulted in severe instability of the hemodynamics. Okay. But and that was why we considered as a last resort, let's say, the retrograde, because of this hemodynamic status. But we were lucky because the antegrade was successful, and there was no necessary to occlude temporarily the LAD. So practically, he was stable during the procedure. Kis tesztet tudsz még adni?
Imre, we have a question from the room. Imre, we have a question from the room.
Yes. Jó, azt hiszem, hogy a fog kelleni.
Not working.
Guiding catheter. So maybe it's important during the measurement of FFR to disengage the guide catheter from the ostium, or to make an equilibration within the aorta. But now I think it's too late. But at least be sure that you don't have a damping of the aortic pressure, because it can result in a false negative result for the FFR.
Damping of the aortic pressure, because it can result in a false negative result for the FFR.
I agree with that, but it seems that you have some difficulty to cross with the wire, so it's trying to have a supportive. It's important to disengage when you do the equalization, and also to disengage. Of course, it's very important to disengage when you do the equalization, and also to disengage immediately after injection to make the measurement. Yes, another comment there.
Thank you, Yves. Sorry, of course, this is the way of measurement. It is,
when working through left radial, what's your practice? Do you put the arm on abdomen patient or just
lehet 20-asra kicsinyítés.
line side and lean over the patient. It's not for arm line side and lean over the patient. It's not ergonomically favorable.
Yeah, that's, Imre is still very young, so he can work over the patient. For me, it's impossible. So in my group, we have the patient has the left arm pushed on the abdomen. And so you are working like right radial on the right femur. So it's more comfortable. You can stay.
I'm sorry, Yves. I have to.
For years.
Yeah, I have also a question. I've just stick with the right coronary artery.
Yeah, I have also a question. I've just stick with the right coronary artery. This is a good example how
the procedure
to perform a biradial C2O. The procedure was actually a good one, but I'm a bit suspicious about the chronic total occlusion. Because this was a tapered one, and it was an easy one, and after the opening of the artery there was slow flow. Is there a possibility that this time of total occlusion was below the 3 months of period? Is there any possibility? Because this doesn't seem like a real CTO for me.
So for me, it's very clearly a CTO because what we saw, if we can see typically precise, we see that these are channels.
I mean before 3 months, yeah.
Channels cannot develop in maybe 3 days.
No, I mean
even
before
3 months.
3 months, yeah.
3 months, so these are typical channels. This is not the lumen of the vessel.
Yeah,
this is not tapered. This was stump, and the vessel was continuing with the marginal branch. So, and he catheterized selectively some channel. Okay. I'm sure it's a good CTO, probably on all one.
The only one reason you could see that nice image that it was a contralateral injection also. So if you remember the first angio, it was filled by the diagnostic angio. You couldn't see any channel. But IMRE performed the dual injection, and that's why you could see that channel. And now we can see the importance why we are going with the dual injection.
Very important point. This is the explanation. When you inject both, you see more frequently some channels. What I'm doing quite frequently, I prepare my CTO, I come with my fine cross and my wire, I just put the fine cross close to the occlusion, and I do a local injection there. So several advantages, no overlapping with other vessels, and also you can really inject at the place of the occlusion, and you very frequently discover some crushing channel.
So how frequently you are doing bilateral radial for complex CPO?
Okay, so just
how frequently you are doing bilateral radial for complex CPO in your practice?
And in this case, my other practice of radio in more than 95%.
And in this case, IMRADIAL did a very good job with the left amplats left in a right coronary artery. Sometimes we can use a left radial with amplats for right coronary. Maybe sometimes we have much better support. But in this case, it was perfectly done from the right side. So how frequently are you using left radial for RCA CTO?
That's curious because I find maybe because of my morphology. And for me, it's frequently difficult to go with an amplats. I'm a fan of an amplats. I had a dinner 20 years ago with amplats. I was a fan of amplats. I find that using an amplats from the left side is difficult. Amplats from the right, personally. And I frequently use side holes. I do the side holes myself because we don't have side holes in France.
I don't know whether Dr. Ikari is here, but we have found in several cases his Ikari left providing perfect support for RCA CTO. With very good contralateral wall support.
Another catheter in the catalog is the 3D. If you If you know this catheter from, I think from Cordis, not sure. The 3D, you can change the support by just rotating clockwise, more support, counterclockwise to move out. Very nice catheter for right coronary CTO. So, Imre, what's the result?
Thank you. If just one additional remark to this question, whether it's a true CTO or not. I can see that it was really easy, but I qualify a CTO as easy only after the procedure. All we know that there are a lot of surprises during CTO recanalization. That is my first remark. And the second one, that this very well-developed septal collaterals means that it definitely must be older than 3 months. So it's just an additional remark. And thank you for your feedback to this question. Actually, in the meantime, we measured the FFR. Maybe, I don't know whether it's possible to turn the FFR screen to the camera. Okay, so if you can see the FFR screen, we measured it and it's 0.77.
And can we identify
this means that it is an indication of LAD.
Can we identify a lesion in the LAD, or is it a diffuse disease?
Actually, it's a good question. I try to show you the LAD.
Because this is not because the FFR is less than 0.8 that this is a treatable lesion. Because this is not because the FFR is less than 0.8 that this is a treatable lesion. Sometimes you have lesions that are 5, 6 centimeters long. It's not realistic. This is, we see quite clearly that the first and second segment are very diseased. A bit better at the beginning of the third segment. Is not also a very long LAD. On the diagonal,
yes, thank you, Yves.
Tight lesion on the diagonal that can influence also the FFR, because this the amount of myocardium supported by the diagonal is not available for full vasodilation, full opening, so may reduce artificially the FFR. Is it your opinion?
So definitely, I also agree with your statement that I would defer actually doing anything on LAD at this stage, because it seems a very low EF and good result on RCA. Maybe just continue with following up.
077 means we have.
Other opinions about this in the room?
Do we have to treat
077 means we have to treat the LAD or not? Do we have to treat the
very long stent, proximals and mid?
Yes.
But do we have a pullback
It
here?
means that you have to put a very long stent, proximals and mid.
Do we have a pullback here or no?
Injection is a coronary.
I don't think we have.
No, it's an injection in the coronary artery, or it's a perfusion?
It's an intracoronary adenosine. Yes, you are right, Yves. So we with this approach we can.
It's an injection.
We cannot do pullback curve. Meg kellett volna állnom az alatt a lézió fölött. Látod, ami ahol benne állok éppen.
Personally, I'm not sure that pullback will change
nem érdekes, ezt most meg fogjuk magyarázni.
The two lesions I see.
Personally, I'm not sure that pullback will change anything, because the two lesions I see, at least, proximal to septal, distal to septal, are both very tight. Probably both significant. Have to be covered by stents. I see the distal LAD also very small.
Not treat this patient.
Disease also.
Maybe look for.
Personally, I will not treat this patient, at least today.
If can I
functional aspect, MRI, thallium.
If can I tell you our decision? You may also see it.
We fully agree with you, Imre. The patient has 20% ejection
so
fraction is very old.
just-
We fully agree with you, Imre. The patient has 20% ejection fraction is very old. Very nice case, excellently performed. I think everybody suggests to leave it. It's a very nice case, excellently performed.
Thank you very
nice
much, Imre,
stand.
for this
So
nice case.
everybody was lucky the patient.
Thank you.
Thank you very much, Imre, for this nice case.
Thank you, Yves.
Maybe see you if you are coming here.
Yes, hopefully by the evening I will be in Budapest together with András. András must be in a hurry because he in the afternoon has a case presentation in Budapest. We really hope that he will get. Thank you for your interest, for your attention.
For that we change
the
chairman. Thank you, Imre. So we are moving to the next session, and for that we change Bryniarski, Lavi, Siabasi, and Yoshibashi.
Now that we're finished playing musical chairs, I'd like to open this session. We have a very exciting and interesting session around radial occlusion, a very important part of any transradial procedure. If I could perhaps ask my co-chair and other panel members to introduce themselves before we go to the first speaker.
So I'm Dr. Adela Mignon. I work in Belgium, and I'm very happy to chair this session with Dr. Mamas because I'm a big fan of your work, as you know. So it's a real honor for me. So.
My name is Leszek Bryniarski. I come from Krakow, from Jagiellonian University in Poland. I am a radial operator, also the CTO operator, so many procedures of the CTO are from femorally, but we will discuss this tomorrow. I am a professor of cardiology in the Institute of Cardiology. Thank you.
Good evening, I'm Alessandro Sciabasi from Rome. I'm an interventional cardiologist. We perform more than 95% procedures through transradial access, and it's a great pleasure to me to be here. Thank you.
I'm Dr. Shimachi from Japan. I'm radialist, and I produce slender graft Japan. I always use 5 French or 4 French or slender guiding catheter. Thank you.
Shahar Levi, interventional cardiologist from London, Ontario, in Canada.
Okay, thank you very much. So without further delay, I will invite on the stage Dr. Ahalis from Greece. We will present her study and his view on a very burning issue, which is the impact of high versus low heparin dose and the impact on radial arterial occlusion. So thank you very much, Dr. Ahalis.
Thank you very much. I would like to thank Professor Bertrand and Professor Rutzev for the kind invitation in this interesting meeting. And my talk has to do with the impact of high versus low dose heparin on radial arterial occlusion. There is no conflict of interest relevant for this presentation. The background of radial arterial occlusion. It is asymptomatic, but not always. It prohibits the vessel reuse, and there are nephrological and teleological issues. And there has not much attention paid so far. The SKY guidelines state that there is a dose-dependent reduction of occlusion rate from 2,000 to 5,000 heparin units. And the European guidelines state that heparinization should be at the level of 50 units per kilo or up to 5,000 units per person. We have found in the Ore of Artemis trial that the rates of occlusion were 9 to 10% for the radial and ulnar artery, meaning that it's by no way a rare complication. And there was no difference between the two forearm arteries. Now, in preparing a meta-analysis already 1 year ago, during my speech in Liverpool, and not being able yet to publish it, my good colleagues from UK were able to catch up and publish an interesting meta-analysis this year. So we had we isolated 126 studies up to the middle of August this year. And of these studies, 82 did not report or did not find any predictors of occlusion. And these studies extend from 1989 to 2016. And the predictors, the studies reporting predictors, were usually predicting that the body size or the surrogate of body size was the most usually reported predictor of radial artery occlusion. But also other parameters like age were found in 4 to 6 of all these studies. And as you see here, anticoagulation intensity was not so frequently found as an independent predictor of anticoagulation of radial artery occlusion. Now, the history of anticoagulation started in 1989 from Dr. Campeau, who gave heparin and who wrote that when pulse failed to return, additional heparin was administered as well as a continuous drip per hour for up to 24 hours until radial artery pulse recovered satisfactorily. The history went on in 1996, and Spalding found that there was a reduction of radial artery occlusion from 71% without heparin to 24% with low-dose heparin, and even to 4.3% with standard dose of heparin. The story became confusing in 2012 from the Leipzig registry, as occlusion occurred in 15 to 30% depending on the franchise. And the author's conclusion was that this incidence was higher than expected, especially in patients who underwent the procedure with larger sheaths. We will come back at the end of this presentation on this study. The first randomized trial of low versus standard heparin dose was published by Dr. Bernard. Also, Bertrand was a co-author. There was no significant reduction of occlusion rates with the standard dose over the lower dose, but was further reduction of occlusion rates after ulnar artery occlusion, compression. Now, we found in a relatively small randomized trial, but in integrated large database, over 700 patients, that standard heparin dose reduced by 23% over low heparin dose the incidence of radial artery occlusion. The difference was not statistically significant, and patients with an occluded artery over those with patent arteries had received lower heparin, 38 units per kilo, over those with patent arteries, 46 units per kilo, but this difference were not statistically significant. And here is a a table showing the 5 randomized trial. In the meantime, we have an additional trial published this year from Iran. And as you see on the right side here, there is a reduction in the incidence of occlusions in the standard dose over the low dose. And in 2 studies, this from Turkey and this from Iran, the difference is statistically significant, but we are talking about small studies with 400 to 745 patients. And in our not yet published meta-analysis, we found that in the 4 randomized trial, the high over low dose heparin was not statistically significant in reducing the occlusion rate, from 7.3% to 4.4%. P is 0.25. But when we included all the observational trials and the number of the patients increased significantly, we found that there was a significant reduction of 29% of incident occlusion in favor of the higher dose heparin, 5.3% versus the lower dose heparin, 7.5%. And this was marginally, but yes, statistically significant. And this is in accordance with the published randomized trial from Rashid, Mamas, and other colleagues, Bernard, which showed that they found impressive relative risk reduction of higher versus lower dose for radial arterial occlusion of 64%, meaning that 2/3 of occlusions can be prevented by higher instead of lower heparin dose. There are forward and backward steps toward radial arterial occlusion prevention, and I will show you 2 very recently published studies. The one is from Levine and colleagues reporting on long-term radial artery patency following transradial procedures via 7 French sheath, a low number of patients, 43, observational study. The primary endpoint was radial artery occlusion, assessed by ultrasound. Patent hemostasis was not applied, but heparin dose was high enough with ACT over 200 seconds in most patients. Incidence of occlusion was 19%, 18 out of 43 patients, and the colleagues, the author stated, femoral vascular access should be considered when there is need for insertion of large bore sheaths in patients with low body weight. And more importantly, a Chinese study, observational but very well done, with registration number, showed that even a patent hemostasis was applied and higher heparin dose was given, the incidence of radial arterial occlusion mounted to 9.24%, 556 out of 600 patients. The heparin administered was high, 72 to 73 units per kilo, and there was no difference between those who had occluded versus those who had an open radial artery. We have found a non-statistically significant trend showing that every increase of unit per kilo heparin dose reduces by 1% the risk of occlusion. It means there is a 1% relative risk reduction of radial artery occlusion if we increase by 1 unit per kilo the heparin dose, meaning that if we increase by 50 units per kilo the dose, we may reduce rates of occlusion by 50%. And this was the guide to plan and execute the randomized control trial, which is now running in Greece. To conclude, we are gaining more confidence with the anticoagulation effect in prevention of radial artery occlusion. It's clear that low heparin leads to more occlusions, high heparin dose to less occlusions. In the Ullmann series in the Leipzig registry, the 6 French occlusion rates were 30%, but what is not reported in the paper is that 79% of the 6 French procedures were 2,500 heparin coronary angiographies, low-dose heparin for high French size. It may all be coagulation to overcome gender, BMI, French size, and occlusion technique issues, to simplify our approach to prevent occlusions, in other words. But we still need to know how high should the heparin dose should become. Higher dose heparin, 100 units per kilo, versus low dose heparin, 50 units per kilo, is being tested in a Greek multicenter randomized trials, which is running since the last year. We have already enrolled over 1,000 patients, and we anticipate that we will stop enrollment at the end of this year and have the first results at the end of the next year. Thank you very much for your attention.
So thank you, Professor Hallis. An absolutely superb presentation, superb talk. There's a lot in the literature, there's lots of comparisons between 2.5, 5 and so forth. But how important do you think the actual amount of heparin is versus the ACT that the heparin produces? So 5,000 heparin in a very fat, overweight, obese patient may produce a much lower ACT than 2,500 in a very small-bodied, frail old lady.
Well, it may be that ACT values, if we establish patency rates with ACT values, would be very important information, like we have this in the PCI, but this relationship has not been firmly established at this moment. On the other side, for me, it's better to give a dose based on body weight rather than giving a fixed dose. Because a fixed dose is very different for Japanese people and very different for Dutch people, for example. I don't know if you have any information on that, but in my search I didn't find any firm, any large study. There are some sporadic studies with ACT, some with bivalirudin, but most of them are PCI studies. And by this opportunity, I would like to comment that we didn't find any difference between PCI and coronary angiography in our meta-analysis. Although not published, I can tell you that I anticipated this result. Why? Although the procedure is longer, all patients receive high-dose heparin. And this confirms, in my opinion, the importance of heparin. We don't see high occlusion rates after PCI, although we have a longer procedure.
Yes. Good answer. Are there any other questions or comments from the panel? Or
I would like to ask something about the patient on oral anticoagulant therapy. Previous studies of Dr. Pancioli show the importance of heparin also in this subgroup of patients. What do you think about it? Is necessary heparin and high dose or no, or low dose?
Well, first, this is the only one study existing, and it's very interesting, and it shows that what for me is very important. If you have patient on anticoagulation, give heparin, yes, even if the INR is 2 to 3. And if you see the guidelines for acute coronary syndromes on patients who undergo invasive procedures and are on anticoagulation, they don't recommend not to give heparin. They recommend to give heparin, which means that we are not so certain that leaving the patient without anticoagulation just because he has he's on oral anticoagulation, that he is safe and protected. And there are good explanations in the paper of Pancioli why heparin additionally may protect. I don't know exactly, but probably intravenous bolus has an immediate effect and may be very much more protective than steady state anticoagulation level.
I have one question, one comment. My comment is that I completely agree with Chairman that until we don't have ACT trials with the ACT measurements, we cannot conclude which dose of heparin is better or worse. This is the first. And the second, what is your opinion about the same rate of occlusion during the PCI? Maybe this is a role of the antiplatelets that we give also during the PCI, but not during the routine angiography.
It's a very reasonable thought. But when we've analyzed the predictors of occlusion in our database, we didn't find independent predictors for antiplatelet agents. Those who had received versus those who did not have received antiplatelets, they have no difference. They have had no difference in occlusion rates, and there was no independent factors for prevention of occlusion. So I don't think even that with the newer antiplatelets that they play a very important role, but it's not conclusive evidence. It's suggestive evidence.
Thank you very much, Dr. Alice. For the sake of time, we will carry on. Thank you very much. And I will invite Dr. Gorgolu. We will basically discuss on the same topic, so radial catheterization on patient on low versus high heparin dose.
Yeah. At the beginning of my speech, I would like to thank the organizing committee for having me in front of such a distinguished audience and panelists. Before I begin chatting regarding the controversial issue of radial catheterization on patients on low versus high heparin dose, I'll give you a quick update of what we have done so far until our latest study, which is the current topic now. Because we know procedure failures could be due to anatomic variations of the arterial path, radial artery angiography is a routine in our daily practice. The radial artery has become our primary access route since 2010, especially for coronary angiography and all kinds of complex coronary interventions. Unfortunately, we have some trouble. Yeah, the complex coronary interventions such as left main lesions, bifurcation lesions, and chronic total occlusions. The role of radial artery approach is almost also undeniable in our daily routine practice when it comes to peripheral angiography and intervention. Carotid angiography is almost always performed by the radial route, and this approach is also routine in patients with bovine arch anatomy who undergo carotid intervention. Radial approach is sometimes very promising in subclavian, mesenteric, and iliac interventions in which you may need an upper extremity access. At the beginning of our radial artery journey, we thought vascular perforation, dissection, spasm, arteriovenous fistula as the most fierce complication. Therefore, we didn't even recognize radial artery occlusion as a vascular complication, and this was not our concern in our early studies. First, for instance, I will give you some updates of our studies. We published 2 studies in 2012. The first one was arterial anatomic variations and its influence on transradial coronary procedural outcome, and the other was a randomized study comparing the effectiveness of right and left radial approach for coronary angiography. Another was published in 2013, and the topic was incidence and predictors of radial artery spasm at the beginning of a transradial coronary procedure. This in all these three studies, vascular complications were defined as hematoma, dissection or rupture, spasm, pseudoaneurysm, arteriovenous fistula, and localized infection. Radial artery occlusion was not even our least concern. Later on, radial artery occlusion became my most frustrating complication. Many patients landed on my cath lab table with previous radial artery access and radial artery occlusion. Once the artery is occluded, it cannot be used for further catheterizations in the future. So we decided to find the predictors of radial artery occlusion, and we planned this study, the long-term incidence and predictors of radial artery occlusion following a transradial coronary procedure. This study revealed radial artery diameter, sheath artery diameter ratio, and post-procedural pain as the predictors of radial artery occlusion. What drew my attention in this study was the heparin dose effect on radial artery occlusion. There was no difference between 5,000 and 10,000 units of heparin on radial artery occlusion. The heparin usage is not questioned when it comes to radial artery catheterization. These early two studies and many more indicating the necessity of heparin in preventing radial artery occlusion after radial artery approach. In contrast to radial artery occlusion, unfortunately, heparin has no effect on preventing impaired vasodilation response in radial arteries following radial catheterization. Based on this study, artery sheath ratio is the only predictor of flow-mediated and nitroglycerin-mediated vasodilation after radial catheterization. Another indisputable issue is the high effectivity of patent hemostasis on reducing radial artery occlusion after radial artery access. I can give you two study examples from which the randomized PROPHET study seals the issue for good. Not much dispute on heparin usage and patent hemostasis. However, plenty of uncertainty on the heparin dose. No shortage of studies investigating low dose, high dose heparin, but no clear answer yet. Trying to shed some light on this matter, I am going to speak of our latest study a bit. Comparison of effects of low versus high dose heparin on excess site complications during transradial coronary angiography, a double-blind randomized study. The background of the study is that radial artery occlusion is one of the limiting complications of transradial access, and it can prevent future transradial interventions. The FEROA study indicated that with patent hemostasis, the incidence of radial artery occlusion was independent of heparin administration at the beginning of the procedure. On the contrary, what we knew from an early study was that the heparin dose effect in reducing radial artery occlusion appears to be dose dependent. This study, however, dates back before the 2000s, when radial technique was not standard practice, and both operator experience and knowledge regarding occlusion techniques were rather limited, with high radial occlusion incidence, noted especially with low dose heparin. Taking all these background issues into account, our objective in this study was to evaluate the efficacy and safety of two different heparin doses during coronary angiography. 520 patients were screened for eligibility. The presence of dual circulation was tested with the Barbeos test. After the exclusion of 30 patients due to various reasons, 490 patients were randomized to either low dose or high dose heparin. Further exclusion was performed due to ad hoc angioplasty. After the puncture, the needle was removed and 6 French short hydrophilic sheet was introduced over the guide rail. The 6 French issue is here important because the other studies investigating low dose, high dose heparin doses used 5 French sheets in their studies. So different from the other studies, 6 French sheet was a routine of this study, but I will mention it again later on the presentation. After the sheet insertion, vasodilator was given and subsequently heparin diluted in 10 mm syringe was injected into the radial artery. At the end of the coronary angiography, patent hemostasis was achieved by a radial compression device. The primary endpoint of the study was radial artery occlusion. The secondary outcome measures were bleeding during the deflation process of the TR band and the incidence of grade 3 or greater hematoma. Radial artery patency was assessed using a reverse Barbeau's test at 7 days after the procedure. Baseline clinical and procedural characteristics were similar in both groups. The compression time was statistically significantly longer in high-dose heparin patients due to bleeding during the deflation process. The higher the heparin dose, the more the bleeding during the deflation process, as well as a trend towards increased post-procedural hematoma was noted in our study. Access or non-access site bleeding is still a complication of the radial approach, and it may alter the prognosis with aggravation of morbidity and mortality. Therefore, the potential benefit of high-dose heparin should be weighed against possible hemorrhagic complications. Unfortunately, the effect of heparin dosage on hemorrhage is largely unstudied. There is one study I would like to mention before I continue. Sciano et al. Compared 5,000 units of heparin and weight-adjusted heparin. They concluded that there was no increased hemorrhagic risk involved in the group with 5,000 units of heparin. A result we contradicted. This difference with our study may be due to our 6 French sheet usage and due to our 3 times larger population size. Though we agree with Sciano and his colleagues that a heparin dose lower than 5,000 units does not increase the radial occlusion rate. According to the multivariate analysis of our study, high-dose heparin was found as the only independent predictor of bleeding. Yes, and as to my current understanding, radial artery occlusion is one of the most important complications. No doubt about that. Various studies indicating that the incidence of radial artery occlusion is markedly decreased by the administration of heparin and the use of non-occlusive techniques, hemostasis techniques. However, there is no definite suggestion about the heparin dose. There are 2 studies I would like to draw into my discussion. The first one was published in 2011 in American Journal of Cardiology. Similar to our study, in comparison of 2,000 and 5,000 units of heparin, no difference was found in terms of radial artery occlusion. The other published in 2012 and suggested provisional heparin administration. These 2 studies shows that low-dose heparin may be sufficient for the prevention of radial artery occlusion. However, these 2 studies were confined to catheterization with 5 French sheets. I never use 5 French sheets. Ad hoc angioplasty is my routine. Therefore, I use 6 French sheets routinely, sometimes change to 7 French, even 6 French sheets, but not 5 French sheets. So, as we know, the sheet artery ratio is an independent predictor for radial artery occlusion. Here comes the question, is the low-dose heparin approach also effective for radial operators like me who use 6 French sheets routinely? The reviewers of the journal wanted us to point out the 6 French sheet issue as a limitation of our paper, and we did as the reviewers wishes. On the contrary, I think that it was one of the strengths of our study. If the low dose heparin issue works with 6 French, then it is highly probable that will also work with 5 French sheets. And we concluded with this study that anticoagulation with 2,500 units of heparin decreases minor bleeding events during TR band deflation without increasing the radial artery occlusion after transradial coronary angiography compared to 5,000 units of heparin. I have so much difficulties with this loop, so I don't know what's wrong, but this isn't gonna work properly. So this is my last slide, but I want this to play. Okay. Long story short, I feel at least safer with 2,500 units of heparin after such frustrating complications and don't have to worry about radial artery occlusion. Thank you all very much for your attention.
Thank you very much. I think we have time for only one question before switching to the next presentation. Yes, Dr. Alice?
Yeah. 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 Yeah, but
who is using in the audience 5,000 units of heparin for diagnostic angiography, please? So I think this is the most commonly used regimen for the moment, and we are waiting urgently for more trials, because I think most of these trials were maybe a little bit underpowered to assess the true difference between high dosage and low dosage of heparin. And we see in the study of Dr. Bernat that it's not significant, but you have a 2%, if I remember well, or 3% difference, which didn't reach statistical significance. But maybe the problem is just that all these trials were underpowered. So we need more data on this.
Yeah, but we always know there is always a gap between the studies and what you are actually doing. This is a study I also co-authored and helped to planning, but I am not changing my strategy according to this study. So I use also 5,000, and when I begin with ATOC angioplasty, I give in 10,000 units of heparin, and I don't encounter any problems with 5-dose heparin, and as it is not my problem to pull out the sheet, so it doesn't mean anything to me that the deflation process.
So thank you, Dr. Gorgulu, for your presentation. So I think we have to move on now, because we're running behind schedule. So if I can take the opportunity now to introduce my good friend and the person that's had a huge contribution to studying radial occlusion. If I can introduce Samir Pankali.
Thank you. Good afternoon, everyone, and thanks again for the AIM-RADIAL steering committee for inviting me, and thank you all for coming. I'm in the part of the planning group. So this is music to my ears that I keep on hearing in every talk, that radial artery occlusion matters, and it's very important. I don't have any significant disclosures that would affect this talk here, but my biggest job lecturing all over the place is to convince people that radial artery occlusion is a problem. Because when I go all over the world, literally speaking, most people don't see this as a problem. And when you point out that to the community that you're lecturing to, what are the 2015 peer-reviewed publication rates of radial artery occlusion, and all of you in the audience are represented here very well. You can say that 1 out of 10 radials, even in good labs, go home closed, which is a really shame on us, basically. We need to do something better than this. And so having accepted the fact in the last 45 minutes that radial artery occlusion is a significant problem, let's talk about the best practices to lower the incidence of radial occlusion. Let's keep our best friend open for us to be welcomed again. What's the mechanism of acute radial artery occlusion? Well, it used to be debated 10 years ago whether it's severe spasm versus fibrotic obliteration because of some weird reaction there. Well, it just happens to be the balloon injury thrombosis model. And if you access the radial artery distal to the occlusion point, as Otandil will show you in the next talk in a very elegant fashion, this is what you will see, that there is a stump, and if you recanalize and extract that lumen-occupying material, this is how it is. It's a cast of the vessel formed by the thrombus, which under light microscopy appears to be a red thrombus, and very, very rapidly organizing. This is a 72-hour specimen of this thrombus under high-powered microscopy, and what you can see here is these neovascular channels that are being formed that actually are seen as the circular blue areas there. These are blood vessels already forming inside the thrombus. This is a scar that's going to organize. As you can see, the wavefront of the fibrotic element coming from the top left of the slide, attacking the red element, which then becomes a impenetrable fibrotic lumen. So what do we do? Well, we are good at shooting out thrombus. So far, we have many, many pharmacotherapeutic agents. So when we see thrombus, we attack it. And as intuitively one would think, anticoagulation has been shown, as we heard in the last 2 lectures, to have a very significant and likely a dose-dependent effect. This was the landmark description by Spalding and his group in the non-contemporary era of Transradial, where we were using non-hydrophilic introducers. And you can see that 71% of the radials were closing if you don't give anticoagulation. And there was a proportionate decrease as the dose of heparin was increased. This was bolus heparin. And this was later corroborated by Ivo's very elegant study where, as pointed out, a significant reduction was seen in those darker bars, as you see there, the 5.9 to 2.9% decrement with increasing the dose of heparin, again showing that this is a dose-dependent effect. I think this concept of discussion is very appropriate to the younger radial communities like the US, for example, where diagnostic radial procedures without heparin are still fairly commonly done as a matter of something new that the operator is trying to learn. As Dr. Hollis showed his study here, there is definitely this issue out there, how much dose of heparin is adequate and how much is not enough, and more importantly, as we heard in the last talk, how much is too much. So I'll leave that open there, and the message is that a low dose is certainly not adequate. A higher dose with the best efficacy and risk ratio has yet to be determined, and hopefully the trials in the near future will show that. But administration of heparin remains a best practice in reduction of acute radial artery occlusion. And that includes patients who are systemically anticoagulated with warfarin, where you can see here that the warfarin group had a significantly higher acute and delayed occurrence of radial occlusion compared to a group in the same time frame who was not on warfarin and received heparin. We are now using heparin 50 units per kilo on all warfarin-treated patients who are therapeutically anticoagulated. And we have a fairly large size registry now, which is hopefully soon to be published, with no increase in bleeding at the access site or outside the access site. Similar experience has already been in the registry for the novel oral anticoagulants who do not seem to protect. Mechanisms of radial artery occlusion, back again, the biggest proponent of the thrombus formation, besides injury, which is unavoidable, is stasis. Stasis, as most of you have observed doing radial angiography during these cases, occurs even with the smallest of the introducer sheaths. A 4 French introducer sheath in my lab with an average radial artery diameter of 2.1 millimeters is nearly always occlusive, mostly because of spasm. So the biggest antithrombotic in our armamentarium is flow. And in this extremely valuable and elegant observation by Marcelo San Martin, he showed that radial artery occlusion and flow cessation during hemostatic compression have a very, very tight association. Noticing this, also around the same time, our group decided to therapeutically test this in a randomized setting where we tested the conventional strategy at that time of making the radial artery completely dry and not having any bleeding no matter what the patient does, as opposed to the so-called as needed or as low as possible pressure hemostasis called patent hemostasis. And as shown in these graphs here, with maintaining patency or with paying attention to patency, you can lower your rates of radial artery occlusions very sizably. Patent hemostasis, and I'll run through these videos here, even though I'm sure all of you know, was performed with a traditional hemoband. In this video, I've shown a TR band. Any band or any method could be used. And after inflation of or tightening of this device, we basically remove the sheath. After removing the sheath, we see if we have patency, and if not, we rapidly reestablish patency by deflating or lowering the pressure at the site of puncture. And this was established this was measured by looking at a plethysmograph with the reverse Barbeau test, as we heard earlier. So anyway, patent hemostasis definitely lowers the risk of radial artery occlusion. 2 randomized studies in the literature exist testing this hypothesis head-to-head with non-patent hemostasis, so to say, and have both shown a very significant effect. So patent hemostasis, again, becomes one of the best practice as recommended in the SKY document and others to come. Let's go to the next issue, which is how long is optimal compression time? This is our data, observational, where we switched our strategy from 6 hours to 2 hours, and we found that from going from 6 to 2 hours in PCI patients, we found that the radial artery occlusion rates improved very significantly in the 2-hour group compared to the 6-hour group. Obviously, 6 hours was too much for both achieving hemostasis and keeping the radial artery patent. What is the downside of decreasing your compression times even further? There has been a lot of talk about going to 1 hour, sometimes even 45 minutes. And this is a study from Politi et al. From about 5 years ago, where they used a thrombogenic patch under the compression device and were testing 15 minutes with the patch, 15 minutes without the patch, and 2 hours with the traditional patent hemostasis. And in the yellow bars, you can see the radial artery occlusion rates, but more importantly, in the blue bars is the rebound bleeding. And so one of the downsides of reducing your compression durations is the problem with rebound bleeding. And what does rebound bleeding do? Well, rebound bleeding leads to revengeful pressure, at least in my lab, where we basically crush the artery because it acted up on us. And most of the time, this leads to radial artery occlusion. Our registry corroborates this suspicion. So when we decrease the compression durations, we have to take into account the pharmacokinetics and pharmacodynamics of our heparin bolus and adjust our compression times based on that so that we don't underdo it as opposed to what we were overdoing previously. Duration as an independent predictor is somewhat related to the patency of the vessel, which means the longer you compress, the higher the probability that you will miss the occlusion of the vessel if you're not very vigilant. And that probably is how duration increases radial artery occlusion. In our analysis, when we factored in patent hemostasis in the multivariable model, duration lost its significance. Even though the model was slightly overfitted, this kind of has panned out since then as well. Let's talk about how to compress. So there's always a suspicion. Olivier and I have had many dinner discussions about manual compression and dressings being as good as the so-called expensive bands and gadgets that we use. And this is a very elegant study, which so far the literature has missed, I think, just about 6 weeks out, which was done in China. 1,650 patients were randomized to either a dressing or a balloon band or a pad-based band. And as you can see, the duration of compression needed to get hemostasis was higher with the dressing compared to the bands. And the more important thing is the radial artery occlusion rates, at least in this cohort, which were assessed by the reverse Barbeau test, were significantly higher in the dressing as opposed to the more titrable pressure devices that we have. Again, goes to show that probably at play here is the fact that we can adjust the pressure more in a refined fashion with the devices that we are used to using now as opposed to dressings. Does that endorse the use of the devices? Absolutely not yet, but it's a signal. What about other strategies to lower the risk of acute radial artery occlusion? Well, this is a very great randomized study, again, testing the role of spasm in promoting radial artery occlusion. And Surya Dharma and Sasko and Tejas Patel et al. Basically tested the hypothesis by administering half of the population 500 micrograms of nitroglycerin right before the sheath was pulled, and the control arm was given saline. And what they found is the 24-hour occlusion rates were significantly lower in the nitroglycerin arm compared to the saline arm. Probably, obviously, because of amelioration of spasm left over from the procedure, further maximizing flow, which then would increase patency. What else? Well, what else is on the horizon? Well, the radial and the ulnar arteries, as we heard from this morning, are interdependent, both anatomically and physiologically. And when we compress one, we can direct more blood flow through the other by lowering the distal resistance. And recruitment of flow in the radial artery has been shown and published now. By compression of the ulnar artery, you can increase the peak pressure. And I mean, in this case, the peak flow velocity and the VTI. As you can see, almost a 40% increase in the velocity time integral in the radial artery by compressing the ulnar artery. This was put to test and soon to be published, hopefully in the next issue, the Prophet 2 trial, which tested this hypothesis, which was discussed at the first dinner meeting of AIM-RADIAL in Quebec City with Olivier, Ivo, and I and others sitting at the table. We said, well, you know, if Ivo was able to show recanalization, why should we not suspect efficacy if we prophylactically compress the ulnar artery when the thrombus has not even formed? So this study was determined, or actually designed at this point, with 3,000 patients randomized with follow-up in this trial for 24 hours and 30 days for radial artery occlusion. And as you can see here, in the gray bars, which were the prophylactic ulnar compression, the occlusion rates are very, very low. And the blue bars were the patent hemostasis alone. So again, in the Prophet 2 trial, we showed that the prophylactic ulnar compression further lowers radial artery occlusion. This is how the prophylactic ulnar compression was achieved. It was not through any fancy gadgetry. It was just one of our hemo bands with a pledget underneath it, with a needle cap and gauze, which showed it. A very similar observational study has been recently reported in Journal of Invasive Cardiology from Greece, where they showed that in a smaller sample, the similar effect was shown. The ulnar compression, which starts at the same time or slightly earlier than the radial artery hemostatic compression, is able to nearly eliminate radial artery occlusion in their group. You know, obviously this is a sample effect. I don't think we will ever be able to eliminate radial artery occlusion, but we clearly can lower it to a point where it becomes tolerable, better than the 10% that we have right now. So post-procedurally, paying attention to hemostasis, and especially all the way through, not just leaving the lab, but throughout the whole monitoring process, and even going home, applying very tight compressive dressings and ruining the whole work that the team did, needs to be attended on. So summarizing the best practices: heparinization in diagnostic procedures, maintaining patency of the radial artery during hemostatic compression, assisted by probably a shorter rather than a longer duration, watching out for rebound bleeds, is probably the best way to tackle radial artery occlusion. Have we made a difference? Well, these are the PubMed reported radial artery occlusion rates, historically speaking, from 1989 to 2008. And then with patent hemostasis, we have 2 trials that showed a sizable reduction. And then now with ulnar compression, with EVO's data set, where the artery was compressed after the radial artery already closed up, or prophylactically in the subsequent 2 data sets, soon to be in the literature, you can expect a further incremental improvement. Radial hemostasis has the biggest problem. It is very well tolerated and is highly effective. And because of that, we tend to overutilize it. But the risk of radial artery occlusion needs to be the goal of radial hemostasis, as the efficacy has never been an issue. And so using heparin, using patent hemostasis, maybe using an exit cocktail, and hopefully maximizing flow if flow is a problem with ulnar compression might be the way to go. Thank you.
So thank you for an absolutely superb overview, Samir. You really have contributed significantly to the field. Is there anyone with one very short and brief question, because we're 15 minutes behind schedule?
Samir, great presentation. Just a question, and this is related to all 3 presentations, including yours, with regard to heparin. Obviously, there is, with higher dose, always risk of more bleeding. And then the question is, when to give the heparin? Immediately after sheath insertion, at the end of the procedure, after the wire is advanced to the ascending aorta?
So I think, that's a very important point, and I have heard all sorts of combinations. People give it when the wire is in the aorta. My principle is that the purpose of giving heparin is to prevent, a radial occlusion, and also to not get thrombosis on the catheters. And so if you're doing the procedure through the radial, unless you have exquisitely short procedure times, like Dr. Saito or Tejas Patel does, which is 90 seconds or less, or your money back type of a deal, then I would give it at the end of the procedure. If you're spending a reasonable amount of normal time, I think heparin should be administered after your hardware is placed in the artery, because the radial artery occlusion is why we are giving, and the thrombosis on the catheters. You definitely should give it before you pull the sheath if you have not given it so far.
Okay, thank you very much. So by the next speaker, Dr. Babunashvili, which will give us a talk about the novel technique of retrograde recanalization for chronic occlusion of the right coronary artery.
Thank you very much. Good afternoon, dear colleagues, chairmen, panelists. To continue discussion about RAO, main point of my presentation is interventional management of late RAO when repeat TRI is needed. Can I change this?
We have to wait some loading. Sorry.
Okay, thank you. So this picture demonstrates the rapidly growing number in Russian Federation of TRI, and as you can see, the past 5 years, the number is increased 5 times, 6 times, and overall, country is radial because more than half cases performed radially. But in another hand, growing number of TRI, theoretically and logically, means the increased risk of an increasing number of RAO. Is the RAO problem for patients? Maybe not, because clinically asymptomatic, no change in quality of life. But for interventionalists, yes, because sometimes we need the repeat access, repeat TRI, and procedure requiring 2 access site, for example, for CTO recanalization and PCI in case of severe aortic disease. This is the data from our clinic. As you can see, per year, we need 20-25% of repeat TRI, for example, for control angio, TRI because of restenosis, or multi-stage PCI. And in those patients, 5 and 7% of patients have a RAO. This is the established technique, what we always try when RAOs occur. As you can see, distal post-occlusion segments of radial artery in almost all cases was patent, and we can puncture this post-occlusion segment because based on collateral pulse transmitted from ulnar artery. And you can see the examples for RAO, CTO, radial CTO recanalization. And when stump is enough length, has enough length, we have more space for manipulation of catheters and proper positioning at the stump, wires and catheters. And after that, we have the good condition for recanalization with coronary wires, with escalation technique and another technique what we use in coronary CTO recanalization. But in some cases, foreign part of post-occlusion segment was absent. And in that case, we can go more distally and puncture radial artery in anatomical snuff box area. In that area, radial artery lies superficially, and we can puncture this part of radial artery based on pulsatile wave transmitted from ulnar arteries, the same manner as we can puncture when distal post-occlusion segment in forearm is present. Hemostasis is easy. As you can see, only finger compression in this area is much enough for stop bleeding. And you can see the picture how we can recanalize the radial artery CTO, use the distal radial artery puncture. This is the video, radial CTO recanalization. As you can see, radial artery is occluded in whole length in forearm part, and we can puncture distally in radial artery in snuff box area after the recanalized with coronary wire, dilatation with balloons, and restoration of the flow and lumen of radial artery. We can use this radial artery repeat for transradial interventions. And as you can see, no distal embolization was occurred in control angio, and this picture demonstrated the relation of standard puncture of radial artery and puncture point in anatomical snuff box area. Area recanalization instruments, we can use the same instrument as we used in coronary CTO recanalization, the same strategy, escalation and penetration strategy, and recanalization technique, trilumen recanalization or knuckle wire on hydrodynamic recanalization. And the second, then this case demonstrated use the knuckle wire technique. As you can see, this is the coronary wire, floppy wire, filter wire. You can recanalize very tortuous radial artery, as you can see, safe manner. After that, we can insert a long terumo sheath and control angio, demonstrated a patent ulnar artery and distal microcirculation. Preliminary results we used in 22 patients, distal radial artery access with 90% success rate, with low radiation dose, comparing in total dose of TRI. But it took a lot of time, and it took 50% of time of total TRI procedure. In only one case, we occurred a perforation radial artery without clinical consequences. You can see the reperforation due to subintimal course of coronary wire. And another possibility to use foreign arteries when later aortic canalization was failed. This is the 82-year-old woman with small radial artery, as you can see, previous TRI, later aortic canalization. We tried the recanalization, but that failed. And after that, we have paid attention collateral channel connecting distal part of radial artery with interosseous artery. As you can see, this collateral channel had a straight anatomical course, no tortuosity, and much enough caliber, 1.2, 1.3 millimeters, and nearly the same as 5 French sheath. And as you can see, the 6 case of later AO, in almost all cases, we have seen that collateral with different anatomical course, with different caliber, and we can use this collateral to switch coronary wire from distal post-occlusion segment of radial artery to interosseous. And we placed the 5 French sheath in interosseous artery. As you can see, the shape is the same as anatomical course of collateral. After changing 5 French with 6 French pteroma sheet, hydrophilic sheet, we can relatively easy insert in interosseous artery placed in brachial artery. And as you can see, patent ulnar artery and perfect distal microcirculation without embolization. And preliminary results, we used novel entry point in 22 patients with late or subacute AO. In 20 patient cases, retrograde recanalization was successful. In 1 case, failure was occurred despite of correct puncture of deep pulmonary arch, and no major hematomas or ischemic complication of the wrist were detected. And my conclusion is, new distal entry point of radial artery, deep pulmonary arterial arch, provides good conditions for retrograde AO recanalization in case of total occlusion of foreign part of radial artery. And Leon curve is needed for reliable and effective use of this novel entry point. Thank you very much.
So thank you very much for a very interesting talk. What's your post-operative management of these patients? So once you've recanalized the vessel, then what do you do? Do you give them any particular regime?
Technique of recanalization is the same as coronary. First wire of choice is filler wire. And any another floppy wire with 1 gram of stiffness. After that, if penetration is failed, we use the escalation strategy, miracle wire or Gaia wire and another. And in 90% of cases, this wire escalation strategy was successful. And if not successful, we used collateral access, as you can see and demonstrated this lady, or we used high radial access using the ultrasound under the ultrasound control function.
Okay, thank you. Are there any other questions?
How much is the rate of reocclusion, further reocclusion after recanalization?
Yeah, reocclusion rate is relatively high, about 50-60%. But we have some cases for recanalization of reoccluded artery. And this is the established technique in our clinic. We always try to recanalize, not use the contralateral radial artery, because in that case, is an elevated risk of bilateral radial artery occlusion and loss radial artery access in the future if needed. And we always try to recanalize. Failed, we use the another access.
Yes.
What's your indication for doing this? Are there any indications, or are you doing this in every case, with every large occlusion cases?
Routinely. If we feel the collateral pulse of on distal post-occlusion segment, we always try to puncture and cannulation and recanalization of later AO, because it's relatively safe without clinical consequences. If perforation is occurred, is there absolutely no no complication. And if successful, we can use for repeat PCI, not damage another forearm arteries and contralateral radial.
Have you experienced any relationship between oral pain and radiology?
Yes, of course. This is the painful procedure.
After opening, goes the pain away?
Yeah, in almost all cases.
Okay, thank you very much. Sorry, we don't have time for another question.
Thank you.
So it's my pleasure. Thank you very much. My pleasure to introduce Dr. Bernat, who, like Dr. Pancholi, is a pope of radial hemostasis, and who is obsessed about the patency of the radial artery. And we can achieve very, very low rate of radial artery occlusion in his cath lab. So the title is Post-Procedural Radial Artery Patency and Occlusion Detection. So please.
We have to wait, so. Sorry. No, please wait some minutes, some seconds.
So thank you very much for this opportunity, and I'll show you how we compare both methods in detection of radial artery patency and occlusion after the procedure.
We are waiting for loading the files. Sorry.
Sorry, can we have Dr. Bernat's slides up, please?
So post-procedural radial artery patency and occlusion detection. It was mentioned by previous speakers that radial artery occlusion is not rare, and non-occlusive radial artery injury is common. We can control radial artery patency at present by reverse Barbe test or by duplex ultrasound, and the new promising method is a laser Doppler, which will be discussed tomorrow in one presentation. Reverse Barbe test is relatively easy. It takes from 1 to 2 minutes. We need pulse oximeter on the thumb, strong ulnar artery compression, and display with plethysmographic curve. Duplex ultrasonography is not so often used, but it's a clear method for diagnosis of radial artery occlusion as a final step. We measure radial artery diameter, and we use color and pulse Doppler. The new promising method will be described tomorrow. Background of our comparison is that the diagnosis of radial artery patency and soon detection of radial artery occlusion after transradial catheterization and intervention is an important part of successful radial program, and the aim of our study was to compare these two diagnostic methods, reverse Barbe test and duplex ultrasound. But before our study results, let me show you a few slides about radial artery and sheaths. Because I made for a long time a mistake when I think about the guiding catheter which is available for radial artery diameter, and I didn't think about the outer diameter of the sheath. But in 1999, Professor Saito presented and published one article when demonstrated outer diameter of the sheath and inner radial artery diameter more than 1 is a strong predictor of radial artery occlusion. It is something which is clear, but I made for a long time this mistake. I thought about guiding catheters outer diameter, but the sheath which is inserted to radial artery of our patients is much more bigger. And from this study, it was demonstrated in this study that 20% of males and 40% of females in Japanese population has had a radial artery inner diameter smaller than the outer diameter of 6 French sheet. So I think this was one of the reasons why Slender Club Japan and then Slender Club Europe were established, because this is something which is very important in discussion of radial artery injury and radial artery occlusion. Look at this slide. 6 French sheet outer diameter is 2.5 and sometimes bigger. 7 French sheet 2.8. There are a lot of patients with radial arteries smaller than these diameters. So each insertion of the sheet to equivalent or smaller radial artery needs to initiate some injury or finally occlusion. That's why sheetless technique was established, and when you look to this slide, you can see that a lot of patients with inner diameter of radial artery with less than 2.5 millimeters must be injured by sheets with routine use of 6 French. It also, the size of the sheet also is associated with incidence of spasm, not only occlusion. And this is one example from this August from my cath lab. When I insert 5 French sheet, I didn't receive any retrograde blood flow, so I used sublingual nitroglycerin, and then after few minutes and gently application of verapamil, it was possible to insert catheter. This spasm was diffused. It's a rare situation, but the incidence is not zero. Finally, radial artery was not injured by this technique, but the diameter was really very small. And small radial arteries in our routine practice are not rare. This is an example on the right side that radial artery doesn't exist, but ulnar artery is diffusely calcified. And in this situation, insertion or 4 French sheet only to 2-3 centimeters was possible, and catheterization was performed by 4 French catheters. This is an example how to prevent and minimize complications. There are a lot of original studies from Japan and few from Europe about the downsizing. And there's a 6 French glide sheet which is available now, which is very similar in its outer diameter to 5 French sheet. And this is a first step in downsizing from 6 to 5 French. And what is the last and very good news, especially for me, is a 5 French glide sheet slender, because 5 French glide sheet slender outer diameter is very close to conventional 4 French sheet. And because we perform a lot of procedures, majority of procedures through 5 French guiding catheters, 5 French with guiding catheters of this size, it's something which is very helpful in our everyday practice. I like this slide because every time when I look at it, I see that radial artery is usually smaller than treated coronary artery of our patient. So we should think more about radial artery protection and soon radial artery detection, radial artery occlusion detection. So what about our study? We use comparison of reverse barbell test versus duplex ultrasonography in 260 consecutive patients from our same-day discharge program. We used glide sheet slender 6 French and glide sheet 5 French standard. We compressed radial artery with TR band, and radial artery compression by TR band was followed by a reverse barbell test by the nurse from our lounge under the control of a young colleague, and duplex ultrasonography of the radial artery was performed before discharge by another cardiologist. We evaluated radial artery patency and occlusion by both methods. We also measured compression time and evaluated local complications, including hematomas in centimeters by easy classification. This is a baseline characteristic of our 260 patients, and previous PCI from the same radial artery was performed in 20% of cases. And all patients had coronary angiography, and 25% PCI. The indication of this group of patients from our same-day discharge program was stable angina, chest pain, and dyspnea, and in less percent of cases the other indications. On this slide you can see the number of punctures. Majority radial artery was punctured for the first time, and this is the result. Reverse barbell test and duplex sonography in 99.2% verified radial artery patency, and in 2 cases radial artery occlusion, which was also verified by duplex sonography. Results of both methods were the same. This compression time, majority of patients had compression time from 60 to 100 minutes. And this is a result in terms of hematomas. We didn't have hematoma over the 2nd degree. It means no hematoma was over 10 centimeters. So in conclusion, both methods are comparable in detection of radial artery patency and occlusion. Reverse barbell test is easier in our routine daily practice, and this reverse barbell test should be performed in all patients after transradial catheterization and intervention for its simplicity, and optimally immediately after compression. Thank you for the attention.
Thank you, Eva. This is a really important study to define optimal methodology for determining radial occlusion. So I think it's going to be a really important study, this. Are there any questions from the panel?
Yeah, if you allow me, it's a very interesting trial because the Doppler ultrasound imaging is still viewed as the gold standard to detect radial artery occlusion. You show very nicely that by using the reverse barbell test, which is readily available, everybody can do that. You don't need to call the radiologist or to have a Doppler machine in your cath lab. So I think it's a very, very important information. And do you think that we should not recommend any more Doppler ultrasound imaging for the detection of radial artery occlusion? Or?
I think it's possible to say finally on behalf of this small number of patients. On the other side, when you have a lower rate of radial artery occlusion, it could be very complicated to have a big study to verify more. I think it's not about only detection, it's about prevention, because prevention is the best. And there was a discussion during previous talks about this, and adequate steps which lead to minimizing of injury and occlusions of radial artery are more important than this final detection, but I think final detection is also necessary.
So final question from Professor Hallis.
Congratulations. Although it's a simple thought and simple hypothesis, it's interesting and surprising. It's the first time that such a study has been done and shows what it shows. And we have found that the detection rate in all these studies for radial occlusion was exactly the same concerning ultrasound method and Barbeau method. So ultrasound Barbeau method appears also across studies that be equally effective in detecting occlusion.
It's very simple.
Okay, so thank you, Ivo. So if I can introduce the last speaker to what's been a really fascinating session, Dr. Paulson, looking at the association between ACT and time to hemostasis and patency.
Chairman, ladies and gentlemen, I would like to thank the organizing committee for having this opportunity to present our study. The title of the study is Association between Activated Clotting Time and Time to Hemostasis and Radial Artery Patency. My name is Marianne Paulsen and I'm a nurse in Aarhus University Hospital. Terumo has provided an unrestricted grant for the Access-1 study, so that is my disclosures. Heparin is routinely used during radial artery access. There's limited data on the association between ACT and time to hemostasis and radial artery patency. The purpose of our study was to evaluate the association between ACT and time to hemostasis and radial artery patency. This study design was a prospective study, a sub-study to the Access-1 study that my colleague Birte Sindberg introduced earlier today. We prospectively registered medication prior to or during the procedure, ACT level just before sheet removal, time of sheet removal, and time of hemostasis when the TR band was removed at the ward. After the TR band was removed, the nurses made the reverse Barbeau test. At the cath lab, we registered total volume air inflated in the TR band. At the ward, 25% of the volume was deflated every 15 minutes. If bleeding occurred, 25% of volume was inflated again. And we continued the 2 steps, 2 and 3, until the TR band could be removed. The reverse Barbeau test, we have talked about this earlier, so I will go quickly through that. The nurses registered which type of Barbeau test it was. If it was A, B, or C, the artery was open, and if it was type D, the radial artery was closed. We had 1,000 patients randomized to slender versus standard sheet in the Access-1 study. The study was in a 7-month period. We had 891 patients included at Aarhus University Hospital, and the rest was included in a regional hospital. We had 789 patients with a valid ACT, and 747 patients where we registered time to hemostasis, and 695 patients where we registered a reverse Barbeau test. We divided the 789 patients in the 3 groups with ACT levels below 250. There was 332 patients. The ACT level 251 to 300, we had 238 patients, and ACT above 300, we had 219 patients. All of our patients received heparin, because it's a standard procedure at our cath lab when we do a radial procedure. Almost all of our patients received aspirin, and there was a larger group with an ACT over 300 who received bivalirudin, abcipizumab, and NOAC treatment. Almost none of our patients received protamine sulfate. The result of the study was that there is an association between ACT and time to hemostasis. We also had the group with a 747 patient where we measured the time to hemostasis in minutes. And the ones with a low ACT below 250, there was an average time to hemostasis on 143 minutes. In the middle group, it was 152 minutes, and in the group with the ACT above 300, it was 153 minutes. The association between ACT and the radial artery patency. We had the 695 patient where we made the reverse Barbeau test, and in the A, B, and C group, the majority of the patient were. We only had 13 patients in the group D, and as Birte explained earlier, the 9 of them had an opened artery with an ultrasound when they came back 1 month later, and 2 of them had a closed artery, but they had no symptoms at all, and then there were 2 patients left who didn't come to have an ultrasound made, so we expect that they don't have any symptoms. So the conclusion of the study is that activated clotting time following radial angiography or angioplasty is associated with time to hemostasis, but the limited difference in time to hemostasis between patients with low versus high ACT is not clinically relevant. Our perspectives are no reason to consider protamine sulfate following radial angiography or angioplasty. Thank you very much.
Thank you. I mean, this is really important data. I mean, that was one of the discussion points from an earlier presentation around ACT and radial occlusion and outcomes. Can I open this to the audience? Any questions?
Did you look at heparin as well? So the question is essentially from the previous discussions, what is more important, the heparin dose or the ACT dose? Or maybe if we use heparin anyways, the 250 or 300 ACT is not that important.
We always give 500 international unit of heparin when we have a radial procedure. And then if we move on to an angioplasty, we give a higher dose of heparin.
Yeah, I think that the issue with ACT, especially if we are doing a diagnostic procedure only, is that we're probably not going to change anything unless we will have good or clear results that we need to give more heparin. If we measure ACT, we won't do anything with the results.
I don't quite understand. Can you explain?
I'm just saying that if we measure it, in this case, we didn't really see difference with ACT and radial artery occlusion, but even if we did, it is hard to say that according to ACT, we'll give more heparin once a procedure is done.
No. Is there any way some of the others can answer that question?
Band or hemostatic device without having to worry too much about the risk of radial occlusion, which we now know can actually safely and reliably be assessed by a reverse Barbeau. So in the immediate vicinity of the periprocedural period, there is no added risk of having a lowish ACT at the end of the procedure, be it diagnostic or PCI. Likewise, if your ACT at the end of the procedure is particularly long, that does not necessarily require a prolonged period of compression, because there was a time difference of approximately 7 or 8 minutes between the lowest ACT and the highest, more than 300. Whereas you couldn't have done that with a femoral puncture, for example.
Yes, any final questions?
No, it was more like a comment. I mean, certainly we still should consider ACT measurements, but only for the procedure to ensure that we have a high ACT level. I don't think there's any reason to measure it in the future when you've finished your procedure. And also, we were happy to see that we have very low levels of radial artery occlusion, but that's probably because of the rapid deflation technique. So less than 1%, I think that's ideal.
Okay. So thank you again for some really nice data and a nice presentation. I'd like to close the session. And the next will be starting at 3:50. So thank you, everybody, and to the speakers.
Hello. So good afternoon, guys. We'll get started with this session now. I have Ian Gilchrist helping me chair the session, and I'll have the rest of the people here introduce themselves, please.
Dr. Dangois from Belgium, Mogadin.
I'm Takashi from Tokyo.
So we are going to get started with the first talk. Mauricio Cohen from Miami, USA. He will talk about the tips and the tricks to guarantee the success of radial approach.
Muting my phone. Thank you so much for having me. It's a pleasure to be here. I just made it. I just got here from the airport, and I'm sorry that I missed my first lecture. So this is one of the first meetings. It's the most friendly. It's a bunch of friends. I missed it last year in Liverpool, and I'm sorry for Jim Nolan, or I'm sorry for me more than Jim, that I missed that. And I really enjoy this, and this is a nice lecture that gives me a little bit of freedom to talk about many things. So these are my disclosures. So to be successful, I mean, the tricks and the tricks and the tips that you need to be successful when you do a radial approach are not that complicated. So you gotta get access quickly, so you can do your STEMIs via Transradial and demonstrate in your hospital that that's the safest way to do it. Navigate the arm without rupturing any vessels, so don't break anything in the middle. And then if you are about to break something, just make sure you recognize it so you don't make things worse. Then third, understand complex subclavian anatomy. So because if you start breaking things there, things get more complicated as you get closer to the heart. You have to cannulate your coronaries, do what you have to do in an assertive and effective way, and using the tricks and the tools that you need to implement so you're successful. And then you got to get out safely. And it's usually the exit part of the radial procedure that is the safest, because hemostasis is really simple. So one of the things that I want to talk. So one of the problems is that sometimes we have a fellow stick in the corner, the stick in the radial, and then all of a sudden say, well, I lost the radial pulse, or there was a radial pulse, we don't have it anymore, or there was never a radial pulse, and we thought that there was a radial pulse. So it can occur to 5% of the cases after repeated attempt to puncture the radial artery. So Sam Pancholi, who's been very smart and very ingenious in the transradial approach, came up with a study in which he randomized patients to watch and wait for the return of the pulse, to do sublingual nitro, or to use subcutaneous nitroglycerin 200 mics just underneath the skin around the vessel. So he realized that the return of the radial pulse was much faster when you do sub-Q nitro. My advice is that if you have a good radial pulse and it goes away, just wait a little bit and go talk, give the nitro sub-Q, and then come back and the pulse will be there, and you can sedate the patient also, because that will decrease vasospasm. One trick that I don't have a slide here, but one trick that Sam Pancholi also told me is that you can have somebody hold pressure distal to the place where you want to stick, and then the pulse becomes a little bit more plump and more palpable. This is a slide for Arnold Zero, and he's a champion in the transradial ultrasound approach. And you can see in that slide there that the radial artery can be easily seen, easily visualized, and has two veins that go along with that. So the veins, when you apply compression with the probe of the ultrasound, the veins are easily collapsible, and then you see the artery that is pulsatile. So that's where you have to go. And the best way to do it is, as it shows here in this figure, is that you got to find the center of the ultrasound probe, and you just go underneath the probe in the center, and that's exactly where the radial artery is. There are some others. The one that I use ultrasound also for the groin. Sometimes I also use the groin. And when I use the groin, there's a little clip with a needle guide, and it tells you. I mean, you just measure the depth of the vessel, and then the clip comes with different angulations. So if it's 1 centimeter, 1.5, or 2 centimeters underneath the skin, then you have a very, very assertive an easy and secure tip that is very easy to do. So in terms of how does ultrasound does very good, and it really minimizes your crossovers either to the other radial or to femoral. It's very, very difficult to cross over if you really have the ultrasound and you know how to use it. And this study, I'm sure that this was presented before, the FAUST trial. Again, this goes to the credit of Arnold Zero from Irvine. Shows that with ultrasound you have less attempts, you use less fluoroscopy, you have greater success with in the first pass. That the risk of venipuncture is lower, and then the time to sheath insertion is also lower when you use the ultrasound. So it's a very safe way. It's a very nice tool to have in the lab. It helps with femoral access. And if you have a tool that allows you to see where you're going, why wouldn't you use it instead of just relying on your pulse and your senses? Another interesting tool to navigate the arm, and this is probably not new. It's the wire tips. So you have wire tips that are angled, like the glide wire. But the problem with that glide wire that is angled is that it will go into all the side branches. So if they go to the side branches, there's a risk of perforation. So you have to watch that, and you spend fluoroscopy when you're doing that. Then you have the regular J that has a 3 millimeter radius at the tip, but that's too big for the radial artery that has around 2.5 millimeters in diameter. And then you have the baby J, and they have the hydrophilic version by Truman, you have the non-hydrophilic version by Merritt, and it's ideal for TR because the J is formed very, very quickly. The wire shaft, you may consider stiff shafts, especially when you have to straighten the subclavian tortuosity, and the hydrophilic coating is also very nice because it's very smooth, and it's very automatic when you have to negotiate tortuous anatomy, and you have to unravel, you have to undo all those loops in the subclavian. So this is the way that the wire you should use, a 260, do all the exchanges of catheters over an exchange length catheter, and use the J-tip should be 1.5 millimeters. So this is the J wire, and you can see as the wire is going how easy it goes, and it doesn't go into any side branches. So what I do here is I stopped looking at the wire going up the arm, so I just advance it blindly, and then if I feel the slightest resistance, then I look. And usually the resistance will be either in the subclavian, or you will feel the resistance when you have reached the aortic valve. So that will save you, a few seconds to a minute of fluoroscopy time. And here is you are redirecting the catheter towards the aortic valve. So it's a very nice tool, and it's very easy to use, and it's a very simple matter. So this is a radial loop. This is an angiogram that was taken by one of my junior colleagues, and he decided to cross over to the groin, and he decided not to navigate. That was probably the smartest idea. So Tejas Patel has published in his atlas these very nice recipes on how to navigate and undo all these loops, and he's just a master in doing this, and he takes the time and the commitment to do it. Then I hear that Jim Nolan takes a little angiogram. If he sees a loop, he's a little lazy and he goes to the other side. He doesn't take the time to navigate, and that's probably the smarter thing to do. So, and this is what happened to me several times that I tried to do these very, very 360 degree loops. So I found the loop. There's a little bit of spasm there, and then there's a very small communicating branch that goes all the way to the brachial. So sometimes the wire will take that route, and then you'll think that you are in the brachial, and then you're not, and then the catheter gets trapped in that very small branch. So in this case, I thought, well, you know, if Tejas can do it, and Tejas has published all this, then I guess I can do it. I can do it too. So then we went with, if you're going to do it, you can use an angioplasty wire, no 14. This is a BMW wire. So we went, and you can see one thing: the loop is not getting undone as you are advancing the wire. So that's a bad sign. Then the regular catheter wouldn't go, but the glide catheters, those catheters that are 4 French hydrophilic coated, will go very easily, and that's very nice. So well, I said, well, I have already cannulated the loop. All I have to do is advance a stiff wire and then torque it a little bit, and then I will undo the loop. But here, it's not being undone. So, and here it's undone, but now the patient is in excruciating pain. So what we did in this case, because we don't want to go to the other arm, God has gave us the ulnar artery. So we went into the ulnar artery and we did the case through that same arm. I mean, this is controversial, and you should be very careful if you decide to do that. But if you look here in this angiogram, you will see that the interosseous, let's see here. I had already imaged the interosseous artery, and the interosseous artery is big, and it's giving collaterals it's giving good collaterals to the hand. So I felt that the hand was not going to be in trouble if I went via ulnar. I mean, we finished the case without any problems, and then accessing in the ulnar is also a very useful tool, but it's hard to feel because it's underneath the muscle, doesn't have a good compression plane, and therefore it's associated with more hematomas, and also it's a very important artery to the hand. So is it possible to do it when the radial is occluded? It is possible to do it. I always use it. I always use ultrasound. Very rarely I can actually palpate the ulnar. And here we have a patient that in whom we couldn't get, he had a transradial cath before, and I couldn't get access in the radial. Then we got the ultrasound, and we realized that the radial was very small or non-existent. So we went to ulnar, and here is to demonstrate how the interosseous artery has developed here, and then if you follow that, it gives a little collateral, and then you can see the radial filling distally. Brachial tortuosity, in some cases you can go blindly, and then as the wire goes, the thing will get undone, and then in the pullback angiography, you can see that the loop becomes, the loop recovers its integrity without any type of major trauma to the vessel. Here is another loop. We were negotiating this in a 91-year-old lady who was a candidate for TAVR. So we were doing the cath, the baseline cath in this case, and we found that the catheter was going this way. So we advanced the wire, and then the loop became undone, and then we were able to finish the case, the angiographic part of the case without any problems. But then we need to do PCI of the LAD when we advance the guide, and the guiding catheter has a larger lumen than the diagnostic catheter, so it will hang up and has like a sharper leading edge. So we'll get hung up in the the loop, and then it can cause perforation or dissection and you can see here extravasation of contrast. So the way to do it here is not to pull the wire, not to panic. You have to have a 125 centimeter multi-purpose 5 French that will go as mother in child. As a child catheter inside the mother that is a guiding catheter, and in this way. And here in the right hand side you have the slip cath made by Cook. I think there's been a recall for the hydrophilic tip, but they're coming back without the hydrophilic tip. That's also a very nice catheter that fits very snug in the 6 or the 7 French guiding catheter.
And here we're advancing the multi. The multi goes without any problems, and after you advance the multi, the taper is created, and then the guiding catheter goes very well. You finish your work you have to do in the coronaries, and then by the end of the case, you do the pullback angiography, and you will see that there's no extravasation of contrast in this case. So we did a stent in this lady, and then we brought her back to do the TAVI, and we forgot that we had all these problems in the radials, and I use radial access as my secondary access for TAVR. So we hit again the same obstacle, and you can see that the radial artery is still patent. We're navigating here with the JR4, so in this case we navigated in a different way. We used an O14 wire. The O14 wire looped very nicely, and you can see how it's navigating and finally straightens everything out, and we're able to advance our pigtail into the root of the aorta and do the TAVR using a radial access as secondary access. Balloon-assisted tracking also is a very useful technique to know and to think about when you're having these difficulties. This was initially published by Tejas Patel and Sam Pancholi. I call these the Indian techniques. And this is when you have an O14 wire across the vasculature. So what you need to do is you have to inflate a 2-wall by 15 balloon, the 2 distal thirds sticking out of the guiding catheter. And in this way you prevent that razor effect that can traumatize very severely and injure the vessel and cause perforation and extravasation of contrast. And then you make a smooth transition here between the wire and the guiding catheter. So this is a case in which we were exchanging to do a PCI, and then the guiding catheter got hung up there in the radial artery with some tortuosity. We had some extravasation. So what we did in this case, I'd like not to pull the O35 wire and use the multi-purpose that will go over the O35. In this case, they were scrambling, looking around for the multi-purpose, the 125 centimeter long, which is in some labs, at least it's not in every single room in my hospital. So I asked for an O14 wire, so that's what I did. I got the O14 wire, and then I inflated the tip of the distal part of the balloon inside the guiding catheter, and we had no trouble advancing the guiding catheter across the vessel. We actually used the same wire to wire the coronary that we needed to angioplasty, and that was in a way kind of an economic solution. And this is the pullback, and you can see that in the pullback there's no extravasation of contrast either. So what the catheter does, the guiding catheter does inside the radial artery, it causes a tamponade and it causes hemostasis and kind of repairs the vessel from the inside. This is a case that Olivier was nice enough to share with me. I don't know if it's going to play. Unfortunately, it's not playing. These are made by Mac, but this is a dissection on how to navigate the dissection. You use an O14 wire, and you have to be very, very careful so you don't go intraluminal. I'm sorry for these videos. Then you can still find tortuosity distally, and then if you find that your catheters are not going in the way you are expecting them to go, what you need to do is take an angiogram. Just take an angiogram, understand a little bit the anatomy. That angiogram didn't help that much, so we advanced the catheter and we found extreme tortuosity. This is probably the case with the most extreme tortuosity that I've had, and we cut this guy again, but we went from the other arm instead of navigating that. So in this case, the hydrophilic wire was very useful because it would slide through all the tortuosity, and then the transition to the stiff shaft. The stiff shaft of the wire would straighten everything out as it's shown here. And then after we did a PCI of the LAD, you can see how the vessel is straightened, but there was no complications and nothing happened to the patient. Here you have subclavian tortuosity. That sometimes can be tricky. You can injure the subclavian. You can cause dissections. The dissections can extend into the vertebral. So you have to be really, really careful in these situations, and you have to be very gentle in your maneuver. So this is a Jackie catheter. We have a calcium there, as you can see, in the subclavian. So that subclavian was not going to give out very easily. We advanced an O35 wire with the big J instead of the small j, because the small j will tend to go into the larger branches. And in this case, we navigated and finally the loop gave out, and we were able to do the diagnostic case. Now, if you're going to do PCI and you have lost your ability to torque the catheters or to get the support, to have the comfort you need to do a complicated PCI, I think you should change access to the other side. Otherwise you can be miserable doing the PCI through a very tortuous subclavian loop in which you completely lose the transmission and the ability to manipulate the guiding catheter. So, and I learned that the hard way with being stuck in the middle of the case without having the ability to support. You can still use guideliners to help yourself if you need. Another thing that can help is if you decide to go in a patient with cardiogenic shock, like we did in this case, so you won't feel the pulse, so you have to use a little bit of pressors and you have to use ultrasound. And then the nice thing about this is that you can actually get the catheter all the way down to the iliacs and help you yourself guide your access to the femoral artery. And that also adds to the safety of the procedure when you have to do a large femoral access like we did in this case for an impella. So a couple of slides here. Who said that left radial was easier? Because we say that if the patient is a little old lady, we should go left radial. So we did use left radial in all patients, and you can see that there's a chunk of calcium there in that radial. And then the wire was not going that easily. And then we found some more tortuosity there. And this is a graft case, and I was going crazy. So what am I getting into here? So we were able to get some we were able to get some pictures there. And then when we were looking for the lima was very distal. And I think that this is a lima we could have not engaged from femoral access. And then while trying to manipulate, the worst, a nightmare started to happen here. So the catheter got kinked. So you can be lucky here, like we were. We rotated in the opposite way as we did, and we were able to straighten that kink in the catheter. But if you're not able to do that, or the kink gets into a small branch, you may need to get access in the femorals and the snare, or you can hold it very firmly with you can press the arm very firmly with get the strongest cath lab tech there. Hold the arm just to subject to fix the catheter distally and undo the loop. Otherwise, you have to snare the tip of the loop, the tip of the catheter. I'm sorry. So then we went back in. Luckily, we didn't cause any damage. The vessel is still big and nice with good flow. So finally, we were able to get there and engage. Then we were trying to do PCI and advance the guide. Again, the guide gets hung up in the piece of calcium. And in this case, instead of using the multi or the balloon-assisted tracking, we used the second wire just to taper the transition a little bit, and we were able, as you can see here, we were able to advance the catheter there through the two wires. And then finally, we were able to cannulate the lima. Another case here, so this is actually the grandmother of a friend of my son, referred to me by one of my colleagues. Again, we started again from left radial because she's a little old lady, and then we started to see some difficulties. Went with the 014 wire. The wire was going everywhere. So then we found that the subclavian was extremely tortuous. And then we took a picture there. And then in this case, if you're working in a nice lab, you can use the road mapping feature, and that can help you navigate. A tortuous vascular anatomy. So that's what we did. We tried to go, and you can see that the subclavian is relatively narrow there. So you have the lima there. We went into the lima several times because you thought that the wire would go in that direction, and that was into the aorta. We were wrong, so we finally navigated into the aorta, and were able to do the angiogram. So, but then when we got there with the tiger, so the tiger was too big, and we had to use a JL 3.5 to image that coronary tree. Another case, so I don't know if you can tell, but this is a case that was done by a friend of mine, and he did the angiogram without much trouble, but he noticed that there was a significant bend in the subclavian going into the aorta, and then he took an angiogram. And here you can see that the subclavian actually arises from the posterior aspect of the distal aorta, the distal arch of the aorta, and that's a lusoria. So this is a picture that was given to me by Olivier, and you can see there the lusoria. That can be a significant problem to navigate. I think I've seen Dr. Tejas Patel do unprotected left mains using lusorias and without any problems. I think it can be done, but sometimes it's easier just to go to the other arm if you want to avoid the complications and you don't have really anything to show, because you just can't do it. I mean, there are so many things that we can just do. And here is a patient that we actually studied. The patient had dysphagia because the esophagus was getting compressed between the lusoria and the arch. That's called the dysphagia lusoria. And you can see here in the CT scan how the subclavian coming off the aorta, and then there's esophagus there that is being compressed in between the lusoria and the aortic arch. So 82-year-old female with a STEMI. So the question is, you go right or you go left? This is an anterior STEMI. This is evolved. So if you look at most of the papers that have been written, you go left, but we hate left access, so we went right. So we went right, and then, of course, we find the tortuosity that we were expecting to find. Finally, we navigate with patience. Again, you have to be patient. And then the navigation is done with very, very, very small torques into a catheter that will guide you. And in this case, we were going with a guide catheter. This is a 3.5 EBU, which is my standard workhorse to cannulate the left main. And you start torquing that catheter until I'm probing with the wire. If you have too much difficulty, it's better to do an angiogram, like I did before. And then finally, it goes down. Then it takes some work just to slide the wire. Sometimes a hydrophilic wire may help. Sometimes you may want to advance the guiding catheter so it will give you a little bit more support. So finally, we decided to go after with PCI. So you do the culprit or the non-culprit first. So I read that paper that Olivier published, and he says that if you do the culprit first, you're going to save 8 minutes and you're going to look better with the hospital and all the data submission that is going on in the U.S. and everybody is scrutinizing on how fast you can do a STEMI. So I just decided to go with the culprit. So we engaged there, we looked at the culprit, and the patient had, I guess, TME 2.5. We ballooned that, we dilated, it was a calcified lesion, we stented it, it looked okay, we gave ourselves a pat in the back and said, well, let's do the right. And then to do the right, I like to save the steps and save time. So I learned this technique again from Tejas. I call it the let's go Indian style, to my fellows, who most of them are Indian also, so they like that. So the way to do this Indian style manipulation is to advance the back part, the rigid part of the wire, and straighten the catheter. So you can do that with a JL 3.5. So you transform a JL 3.5 into a JR, or you just can straighten the EBU and you transform that into multi-purpose. And you can, with easy manipulations, you can start going into the right coronary sinus. And then when you're getting there, just pull very gently on the wire, and then the catheter will take its shape and go after the right coronary. So once we were there, we took a very nice shot. I thought that we had very good support in the contralateral wall of the aorta, and we found a lesion there. So what to do? So the PRAMI trial, so the British have told us that we should do it. So that's what we did. So we had a nice result, and I think the care of the patient was very streamlined. She was sitting up and having dinner that night. There's another case of a 3-vessel disease here, and as you can see here, so we were saying call the surgeon. We thought that the vessel, the LAD lesion was intermediate, and because you've been talking about FFR, we decided to do FFR of the LAD. Then there's a lesion in the obtuse marginal, and then there's a subtotal occlusion in the right coronary. So I skipped. And I'm guilty for that. I skipped an important part of the heart thing, which is CT surgery. And I called the primary doctor, and the primary doctor said, if it was me, I'd like to have stents. So, and again, don't replicate my process. Use the surgeons if you want to have the surgeons operate on your patients. So we went ahead and did FFR of the LAD. We thought that the LAD was relatively doable. So we found that the FFR was 0.74. So, and then my fellow He's Polish, and he was kind of smart. So he said, well, what if we do the right first and repeat the FFR in the LAD? So again, we use the Indian technique. We straighten the multipurpose here with, the EBU 3.5 with the back part of the wire. It takes some time, so you have to be patient. It's not like a JR4. But when you get the cannulation, you don't want to lose the cannulation, so I usually leave the wire inside the catheter when I'm doing this maneuver so I don't get any kinks either, because the kinks can be a headache. So finally, after a little bit of manipulation, we reach the right coronary sinus, and you can see there that we were able to engage the vessel. Once we engage the vessel, we continue to torque clockwise, and you can see that the catheter will dive in. And we were very happy because it gave us a very good, a nice support to do that lesion. So we easily crossed with a whisper wire. We pre-dilated with the small balloon, and then the vessel was a little calcified. We needed to use the guide liner because it was going to be a long segment that we stented. So we had a little dissection proximally after that stent. Put another stent more proximally, and here you have the final result of the RCA. So again, we went to the other side, we stented the circumflex, it looked okay, and then my fellow said, well, let's FFR now the LAD and see whether or not we have to do it. So we FFR the LAD, and the FFR came at 80.81. It has been shown that the FFR of a donor of collaterals usually is lower, and then you should fix the occlusion and then go back and do it. And you can see reversal of ischemia of donor artery myocardium after recanalization. That's been published in multiple papers. Engagement of the RIMA. So one thing that I stopped doing, even though we like to do it because we can, is engage the lima from the right side. A couple of patients have strokes, and I think there's heavy manipulation into that, and then if you lose access, you have to start all over again. So I engaged, in this case, the RIMA, and the RIMA has sometimes a very steep angulation, so a catheter that works very well, it's called the VV1, after Victor Bihar, that was an interventional cardiologist at Duke, that he came up with that shape for the femoral access. And this is the catheter, so it works very well for the RIMA and really gives you a very, very good cannulation, as you can see here. So you can see that usually with the IMA catheter will be the curve will not be sharp enough, and then you do it with the VV1. So again, as I said before, I stopped engaging the lima from the right, and then once I asked a patient, would you like me to go femoral and just do one stick femoral? You want me to do it like I did it radially before, but I have to get 2 accesses? I said, no, please don't touch my femorals, just go and get 2 accesses. So that's what we did. This is a patient with a RIMA and a lima bypass, and the patient had no problems, and he was sitting up with 2 TR bands and having dinner after we did the case. Finally, radial is very well suited for peripheral vascular interventions. There's a radiologist that wants to start doing that, mesenteric. I mean, they're just discovering, the radiologists are just discovering, at least in my place, the radial axis. So we're going to try to stimulate that incentive. And here you can see that this is a patient with, this is a patient that had no femoral access in this case. You can see how diffusely severely diseased are those 2 iliacs. So we went from the left arm just to shorten the distance. We used a JR4 guiding catheter. We stented it, and it looked good in the end. We gave ourselves a pat in the back. And I had to argue with the vascular surgeons because this is a turf, at least in my institution. So, what I like to say is that learning all these tips and tricks, and there are very few limitations for radial angiography, and these are just few of the tricks. I mean, we can go slender, we can go big, we can do so many things, and we can be so creative. And this group, and AIM-RADIAL, and the group that lead AIM-RADIAL, and I think have been instrumental to disseminate the use of transradial access and to push these techniques so we have safer outcomes for our patients. So the tricks and tips, as I said, an exchange of information such as AIM-RADIAL is extremely important, that we're advancing the field. New technologies will further facilitate. I think that in Japan, developing the 3 French virtual angioplasty, I think it's very interesting. We're starting to see more use of transradial access as secondary access for TAVR because because operators are getting burned. They are not as careful with the secondary access as they are with the primary access for TAVI. We have to allow expansion to all vascular territories, but we have to keep in mind that because we can do many things, it doesn't mean that we should do them. So we have to keep safety always in mind. Thank you so much.
Excellent job, Mauricio. I have a particular comment about one of the case you showed. There was a kink in the catheter, in the guide catheter, and that is likely to happen whenever you are dealing with severe brachial tortuosity more than radial tortuosity. And the best thing is to avoid it. So when you already know that you are coming across very severe tortuosity, you can keep a 035 wire in there through the catheter with a Y connector. Second thing you can do is keep a very close eye on the hemodynamics. As your catheter is about to kink, the pressure would start blunting. And the third thing is, in case if there is a kink happen, then one thing you can do is, as you said, somebody holding the catheter at the arm. Other thing you can do is just put a blood pressure cuff on the ipsilateral arm beyond the kink and inflate it at very high pressure, and then use that pressure to fix the distal tip of catheter while undoing your twist or kink. And you can at that point use 014 or 021 wire. As soon as you undo the kink, just advance that wire, and that will then facilitate further unkinking of the catheter, and you can remove the kinked catheter easily. Any of the other faculty have any? Yeah, please.
Dr. Cohen, could you tell us what is your indication for left transradial access at the
Patient with bypass surgery.
and that's it?
That's it. Or absence of radial pulse in the right arm. And sometimes we'll do it in very old ladies. But the setup in my lab, for some reason, and over the years we have not been able to get a good setup for left transradial in my lab. So that's an uncovered need. I don't think that there's a uniform way of prepping those patients, and that's something that we should come up with, at least a technology and a recommendation.
Let's ask the opinion here. How many of you use right radial as your primary radial approach, irrespective of patient's age? So majority. Are there anybody who uses left radial as primary approach, even if the patient did not have bypass surgery in the past?
Very often.
So that's your primary approach?
Very often, about 30% of my case. But one of the tips and tricks is just fixing the left arm to be sure that it will be not moving and it's more comfortable for the patient and for the doctor. So you have to fix the left arm. So, for some indication, all people, hypertensive people, you avoid a lot of manipulation with the tortuosity of the right subclavian artery.
I guess is anybody in the crowd, anybody has any question for Mauricio or any of the other panelists here? So we'll skip the second lecture as Dr. Alfaro is stuck because of the volcanic eruptions. We'll go to Dr. Lux, the right forearm pain and the culprit transradial angiogram.
Dear Chairman, dear colleagues, thank you for this opportunity. And I'd like to show you this case of mine where a patient came back a few weeks after his diagnostic angiography with a right forearm pain. And, well, of course, our culprit was the previously performed transradial angiography. I have nothing to disclose regarding this presentation. So, short story of my patient. He is a 56-year-old gentleman with a medical history of hypertension, dyslipidemia, epilepsy and panic disorder, also atrial fibrillation, and the previously mentioned diagnostic angiogram was performed on the 16th of January. He came back exactly 2 weeks after the diagnostic procedure and presented a swollen, sore, weak right forearm. On the image, I put some markings to show you the areas of pain. The red marks the most severe symptoms, and the yellowish part shows that there was some irradiation to the thumb and the index finger. We had to go to a quick differential diagnosis. It was a bit complicated by our patient, who told us that there was a pustule at the site of the puncture and that it was treated by his GP with antibiotics, so we had to exclude any infections. I was a bit afraid that we find something, because this would have been the first at our site, but we found normal parameters, normal CRP, normal PCT, so we could exclude this diagnosis. Ultrasound excluded any venous insufficiency, and we checked for the arteries as well. We saw one of the radiologists told us that there might be a fistule on the radial artery. The others said that there is nothing, but there is an occluded radial artery. So regarding this insufficient diagnostics and the very strong pain from the patient, we went for diagnostic angiography, which clearly excluded any fistule, but strengthened the diagnosis of an occluded radial artery. We talked to Dr. Ruja. He was our expert at that day, and since we were already inside, we tried to do a recanalization. Anterograde, we were not successful to go with any wires into the radial artery. So we tried a retrograde approach, first by puncturing the deep palmar arch, but that was not successful, unfortunately. So we punctured the brachial artery and went to the ulnar artery to the palmar arch, here that you can see, and tried to cross the occlusion to the radial artery. We did several attempts with different wires, with a Pilot 50 and Fielder FC, so dedicated CT wires as well from the coronary practice, but those remained unsuccessful. So in the end, Dr. Ruja consulted us to improve a bit the collateral flow. So before ending the procedure, we did a balloon dilatation in the palmar arch, and we think that we made some minor improvements, which resulted in relieving the radiating pain into the thumb and the index finger. But unfortunately, we were unsuccessful to open the radial artery. We did a decent follow-up for this patient. We can say that after 6 months, his complaints and pain relieved significantly, although there were some mild complaints left. And with more ultrasound examinations, we could tell that the blood flow remained very good in his brachial and ulnar artery and in the palmar arch. Conclusions for this case, in my opinion, are that radial artery occlusions in some cases can cause really major discomfort and serious complications for our patients, limiting their everyday life. This gentleman was working on construction sites, so this pain and the weakness in his arm really limited his everyday life. And also that seemingly perfect collateral flow, next to a seemingly perfect collateral flow, we can still have symptoms like this. In our case, the angiograms helped to get a better diagnosis, although we were unsuccessful to completely solve the problem at hand. There are some minor comments that we can tell you after 6 months of follow-up. The patient in the end told us a few months later that he had severe fracture on his right wrist. So we assume that one of the reasons why we ended up like this and why we were unsuccessful to cross the occlusion at the distal part of the radial artery was actually this injury to his hand. And he also admitted that he had some minor pain in his forearm, even prior to the diagnostic angiogram. So the differential diagnosis and the treatment of the patient was heavily influenced by his willingness to give the proper information needed to diagnosis and treatment. Thank you for your attention.
So let me start by asking you the question, do you think it was the radial artery occlusion that was causing everything, or was radial artery occlusion was a part of the process that was causing the pain as well as radial artery occlusion?
Well, everything put together, I think that it played a role. There was definitely some kind of an inflammation at the site, maybe due to the occlusion of the artery, but the whole setting, the patient itself with his panic disorder, with his already painful history in his forearm, so everything was put together to this seemingly very severe situation. So in my opinion, the issue was not as bad as the patient presented, and definitely the occlusion of the radial artery added some extra pain.
And what are the other treatment measures that you tried before trying to recanalize the occluded radial artery?
Well, we finished the antibiotic regime that was started by the GP, because that's not a good idea to stop too early. We gave non-steroid agents to relieve the pain. He was already on anticoagulants due to his atrial fibrillation, so that was already done. 2 weeks after the situation, we did not try to compress the ulnar artery and get a flow back. We did not see any merit in that one. And well, he seemed to be really symptomatic, so the transition to the invasive approach was rather quick in this case. It's not the regular protocol at our institute, but in this particular patient, due to his pain and the elevated CK levels, we thought that it might be a good idea to be a bit more assertive and go for it.
Would anybody else would have done anything different here, or would have attempted this radial recanalization?
Yeah, I'm not totally, sure that the picture all fits together as it being occlusive ischemia related to the procedure. So, the swelling, the venous dilatation, discoloration, whatever it was, it doesn't totally fit into the picture of an acute ischemic occlusion there. So, I wonder whether that had elements of a chronic regional pain syndrome presentation rather than being an occlusive ischemia, and it wasn't actually based on the occluded radial. And if it was a chronic regional pain syndrome, it's very difficult to treat, and it's actually fortunate that the symptoms have resolved to the degree that they have done already.
I agree that this is not a clear diagnosis, and I chose this story because, in my opinion as well, this was a bit too complex, and it's a difficult question as well what it was actually.
So a patient who complains of who develops a chronic regional pain syndrome would typically have a discoloured arm, perhaps with venous stasis, and many of the things that you described in that patient would be consistent with that diagnosis.
Yes, that's why we tried to exclude all the other things. We did many consultations with the local teams, so vascular surgery, radiologists, to get an explanation. We waited, called back the patient for follow-ups, waited for the results, even for the hemocultures without any fever, but there was no clean explanation. One of the vascular surgeons also said that it may be a relative insufficiency in the blood support of the forearms, and the patient was a physical worker. So they also said that this might be that just the amount of muscles on the forearm was too much for the collaterals to supply it. I don't know.
Yeah, I don't know whether anyone else has seen a chronic regional pain syndrome in the arm.
Yeah.
No. Our cath lab sister's got it. It comes and goes. It is very like what you described there.
I think a couple of the other things is the pustule that was seen at the wrist artery puncture site could be just the sterile granuloma, sterile inflammation to the hydrophilic coating. And I have just recently, I had one patient, I did a 2-axis radial artery and the basilic vein, and both the axes had a sterile pustule. That was like about 3 weeks ago. So that's very much a possibility. And another thing that I've tried is a patient comes in with acute pain in first week to 2 weeks time, and say it's warm compression. Warm compression helps a lot. And then I also tried trial of a Madrol pack to reduce the inflammation, and have seen some really good response with that. I had one patient very early on in 2008 we had who ended up developing reflex sympathetic dystrophy after the radial access. So one of the other things from that patient onwards I've learned is I always tell the patients to exercise that forearm and the hand with the hand above the shoulder level and open close fist as many times as they can do it. And I think that really helps preventing it to progress to the reflex sympathetic dystrophy from the regional pain syndrome.
For the pustule, I did not see it myself, so it could have been anything on that side. We, at our clinic, for financial reasons, we use bandages and heparin vials, so we see a lot that small lesions occur, so maybe that was something like that. We don't really know, it was just a possibility we had to exclude. For the Metro, thank you for the suggestion. So if we encounter a patient like this in the future, we will definitely think about this one.
You might have expected, you know, if that was purely based on the occlusion of the vessel, that there would be pallor in the thumb and the index finger, but I mean, it's not really what you describe, is it?
No,
more of a swollen limb with, okay, it could be some compartment syndrome, I don't know really, but...
No, we also think that as for the index finger and the thumb, that was more like an accidental finding with the whole the situation, and especially that after getting the whole intervention there, the symptoms did not relieve too fast, so it's not really explaining anything. And this, as well for us, how long we waited after patient presented at our institute. We waited, I think, 4 days approximately till the invasive procedure. We tried to stay on the conservative therapy. That was actually the advice from all the consultants. The only issue was that during those 4 days, despite the therapy, there was no relievement in the symptoms and in the pain. So especially I, as his treating physician, got very excited about this whole issue and wanted to get to a solution. So was asking
I also would like to warn that trying to recanalize the subacutely closed radial artery may end up causing acute gangrene of a digit in case if you had distal embolization while trying to recanalize with an antegrade approach. So that's something to definitely keep in mind. Personally, my experience and from talking to all the experts over years, if patient has radial artery occlusion along with pain syndrome, try to address the pain without trying to recanalize the radial artery, because trying to recanalize ends up causing more harm and problem. So our last presentation for this session is from Dr. Katona. Is Dr. Katona here in the room?
Dear colleagues, it's a big pleasure to me to have this presentation here at the meeting. It's not an extraordinary case, this one. Probably the solution of the problem is a little bit unusual. It's just an ordinary case with a late coronary myocardial infarction at the age of 53. She has an infarction ongoing 3 days ago. She has the usual risk factors, hypertony, COPD, some kind of gastritis or reflux disease, and she has a supraglottic larynx resection due to cancer. She's an active smoker despite of that, and she's so-called some kind of Hispanic Hungarian. So here you should have seen videos. Okay, I can go back. So this is the first angio. As you have seen, it's just what we have weighted. And then we recognized, sorry. Cannot really understand.
It's not present in your presentation, this video. It's absent. It's not here. Try this.
Előző szlájdot keresik, nem?
In your computer, this video is impossible to start right now.
De hogyha van nagyon jó megért munkalákat, mint az, akkor fel kéne jött, hogy előző oldalát vissza felépni egyet, nem? Kérdeznek, mit akar?
I'm very sorry. It's the usual one. I mean, it's a right coronary occlusion, and we recognized it, and that's all. No.
Tudnám, hogy hol van az.
No, it's not mine. That's my presentation on this one.
There were two screens, guys. Just this last second, you put back.
There you go.
Okay, thank you. So hopefully it will be better later. So this is on the right screen. We have the recognized right coronary with a wire and a thrombus aspiration and nothing else. And I think most of us would do a direct stenting in this situation. Plan to do this, but it was not possible. So it was unsuccessful to deploy a stent in the right position. Then we decided to pre-dilatate it with a balloon and then retrieve the stent. It is impossible again, as you can see. The stent is just at the tip of the catheter, and the balloon inside was the original length of the stent. The stent is just compressed here at the tip of it. So the only possibility to just to pull down, but I think it's happened to everybody here, so it's not a big issue. If you have a really bad stent, I mean a very cheap one and bad one, and then you pull it down to the radial access. It's not too elegant, but I think it works. So we tried to pull it down, but it was not possible to pull it into the sheath. Then we lose the position of the sheath as well. So we try, but have the wire inside the compressed and absolutely crushed stent. So we tried to advance a balloon, a small one and a bigger one, and that one just behind the stent, and somehow pull out. To tell you the truth, the patient has no pain. So lidocaine is a very good drug in this site. So we do everything, I think, but it was not possible to pull out the stent from the radial access, and then decided while we are waiting for the surgeon, it was just at the site of the puncture, so I tried to pull it out with tweezers, and finally it was successful, if you can see. So something like this. We were very curious what we have in the tweezers, and this one was the result. It was originally it was a 32 millimeters long stent. Now it's almost 6, with some kind of fat from the arm. And this was the final angio after we have done the procedure with predilatation from the left radial. So the take-home message could be that the radial approach is suitable for most of the interventions. Even we have complications, and they can be treated from the radial side as well. And it's very forgiving because the patient has no ischemia, pain, or anything else. Actually, I was on the call duty that day. In the night, I went back to this patient and just asked about the pain in the arm, and then she told me that yes, she has a small pain in the left arm. It's good. I don't do anything with it. So thank you for your attention. Always keep your hands in the air.
Was the balloon not deflating, or was it inflated while the stent was inside the guide catheter?
Yes, during the pulling down the stent, it was inflated partially in the guiding catheter and partially in the stent.
Balloon has been inflated in the stent.
No, the balloon was inflated in the guiding catheter where the one portion of the stent was, so we strapped in to the guiding catheter, and that's why we can't pull it down.
So you did really well to get that out, didn't you? So congratulations on that. I suppose one thing that would concern me is, not just for your case, but for some of the others shown today and frequent things in cases shown at meetings, is if you put your hands in the primary beam like that, you get a lot of radiation. And if you look back, you'll see that early radiation pioneers often didn't have all their fingers, and you really shouldn't put your hand in the primary. I'd have left it there rather than put my hand in the primary beam. Yeah. It's a very intense radiation zone. Yes. So, okay, transiently for a second or two, but if you put your hands in the beam for long periods of time, it's not good for you.
Yes, I agree with you. Thank you very much. Yes.
I've left the stent in the radial artery in exactly that position because I couldn't get it out. It wasn't a big problem.
Yeah. That was definitely an option, to just leave the stent in the radial artery. At the worst case, radial artery would have a asymptomatic radial artery occlusion.
Yeah. Okay. And I was very happy with that. I didn't have any broken bone in my hand. Yes.
Lots of people do direct stenting. I mean, I will sometimes do it, but there's always a hazard when you direct stent a lesion that you'll encounter exactly that problem. You won't be able to get the stent in, or it won't go up. You'll run into it. It's probably advisable to always pre-dilate.
Yeah. Since this situation, I think it twice, yes.
Well, you always learn from things that happen, don't you, in your own cases? So I never used to screen the angioplasty wire out of the coronary artery at the end of the procedure until I caught the wire in the end of a stent and concertinaed the stent into itself. It took me a while to sort that one out. So now I always screen when I'm taking the wire out.
Yeah, sure. Thank you.
Anything that can go wrong in the cath lab will go wrong one day, and it's always the operator's fault. So you have to bear that in mind.
Yes, I agree with it, yes.
Does anyone have any final comments or question? Thank you all. We'll end this session. The next one will start in about 10 minutes.
shoot for the stars. If it feels right, then aim for my heart. If you feel like, take me away and make it okay. I swear I'll behave. You wanted control, so we waited. I put on a show. Now I make it say I'm a kid. My ego is big. I don't give a shit. And it goes like this. Take me by the tongue and I'll know you. Kiss me till you're drunk and I'll show you all the moves I jag. I've got the moves I jag. I've got the moves like Jagger. I don't need to try to control you. Look into my eyes and I'll own you with the moves I jag. I've got the moves I jag. I've got the moves like Jagger. Baby, it's hard when you feel like you're broken and scarred. Nothing feels right, but when you're with me, I'll make you believe that I've got the key. So get in the car, we can ride it wherever you want. Get inside it and you wanna steer, but I'm shifting gears, I'll take it from here. And it goes like this. Take me by the tongue and I'll know you. Kiss me till you're drunk and I'll show you all the moves I jag. I've got the moves I jag. I've got the moves like Jagger. I don't need to try to control you. Look into my eyes and I'll own you with the moves I jag. I've got the moves I jag. I've got the moves like Jagger. You wanna know how to make me smile? Take control on me just for the night. And if I share my secret, you're gonna have to keep it. Nobody else can see this. So watch and learn, I won't show you twice. Head to toe, oh baby, rub me right. And if I share my secret, you're gonna have to keep it. Nobody else can see this. And it goes like this. Take me by the tongue and I'll know you. Kiss me till you're drunk and I'll show you all the moves I jag. I've got the moves I jag. where I'm coming from, regardless of the things in my past that I've done. Most of it really was for the hell of the fun. On the carousel, so around I spun, with no directions, just trying to get some. Trying to chase skirts, living in the summer sun. This is how I lost more than I had ever won. And honestly, I ended up with none. There's not much nonsense, it's only conscious. I'm thinking, baby, you should get it on. I don't want to sound redundant, but I was wondering if there was something that you want to know. Well, never mind there, we should let it go. Cause we don't want to be a TV episode. And all the bad thoughts, just let them go. Beautiful girls all over the world, I could be chasing, but my time will be wasted. They got nothing on you, baby. Nothing on you, baby. They might say hi and I might say hey, but you shouldn't worry about what they say, cause they got nothing on you, baby. Nothing on you, baby. Hands down, there will never be another one. I've been around and I've never seen another one. Look at your style and really got nothing on. Ain't you wild when you ain't got nothing on? Baby, you're the whole package. Plus you pay your taxes and you keep it real while the others stay plastic. You're my Wonder Woman, call me Mr. Fantastic. Stop, don't think about it.
Good evening, ladies and gentlemen, dear colleagues. I think we are a little bit late and we should start this late-breaking clinical trials session. My name is George Hahalis from Patras, Greece, and I will co-chair with Dr. Panholi from US. And we have a distinguished panelist, Dr. Chodor from Poland. I don't see him, and I don't know him. Dr. Pacchioni from Italy. I don't see him. Dr. Ratour from UK. And last but not least, nurse, Mrs. Spicer, coming from a long distance away from California.
Yes,
Nice
from
to
Palo
see you.
Alto, Stanford, California.
Nice to having you here.
And I'm here it took a long time to get here.
Okay, let's start with the first speaker. It's my good friend Antonis Yakas. He will present his memory trial, manual versus mechanical compression of the radial artery. We would ask the speakers to keep their time. And let's start, Anthony.
Okay, I would like to organize first to thank the organizing committee for their invitation. I won't be very long. So, first of all, there is no conflict of interest. Let's start with the background. I think we all know that there are controversial results regarding vascular complications of manual compression versus use of closure devices post-transfemoral catheterization. More recent data show that closure devices are not inferior to manual compression. However, many femoralists still consider manual hemostasis superior regarding safety. Coming now to radial hemostasis, mechanical compression with earlier artery compression devices is almost always used post-transradial catheterization due to its convenience. However, some people use manual compression routinely because, first, it allows earlier hemostasis and so earlier patient discharge, because the cost is lower, and because of the belief that manual is superior in the leg, so why not the same in the arm? Manual compression of the radial artery is preferred in many private hospitals in Greece for the same reasons, and at the moment there are no data comparing the two approaches in radial artery hemostasis. For this reason, we designed this study, which is a randomized multi-center study. The goal is to enroll 600 patients, and at the moment, here we report the results of the first 400 patients. So these are our initial results. 5 cath labs across Greece are enrolling patients. First, my hospital in the University of Thessaloniki, and the other 4 hospitals, University of Patras. I would like to thank for this Dr. Hachalis, who works there with Dr. Tsingas, Heraklion University Hospital, Hellenic Red Cross Hospital with Dr. Koutouzis, and Veria Hospital with Dr. Datsios. The study is prospective cohort study aiming to compare, as we said, mechanical versus manual compression of the radial artery post-coronary angiography. Inclusion criteria very easy. Any patient over 25 years of age undergoing transradial coronary angiography. All patients are undergoing angiography with the use of 5 French sheath and are receiving 50 units per kilogram of unfractured heparin. And in all patients, patent hemostasis is pursued. Let's come to the exclusion criteria. These are easy: pre-randomization, no written consent, pathologic Barbeau test, anticoagulant therapy, cardiogenic shock, renal insufficiency or dialysis or EGFR less than 30, bleeding predisposition, hepatic insufficiency, low number of platelets, ad hoc angioplasty, and seat diameter more than 5 French. Post-randomization, inability to have a triplex 24 hours after coronary angiography or constant withdrawal. The study endpoints: primary endpoint, early, within 24 hours, radial artery occlusion as assessed with radial artery triplex, and secondary endpoints: bleeding, hematomas, and hemostasis duration. Here are some details about the hemostasis protocol. In the mechanical group, it's what we do with patent hemostasis, so immediate sheath removal after angiography, attempt for all patients for patent hemostasis, of course, and the hemostatic device used should be one with where titratable pressure can be applied. In the manual group, immediate sheath removal, the same here, pressure with 3 fingers over the puncture site and centrally, attempt for patent hemostasis, and patency for patent hemostasis checked for every 1 or 2 minutes, compression for at least 10 minutes, and for as long needed to stop bleeding. And when hemostasis is achieved, of course, the wound is covered with gauze and elastic bandage. Here are the 2 groups. As you can see, there are no significant differences in any of the baseline characteristics. Demographics, the same, gender, age, and weight. Coronary artery angiography indication, the same in the 2 groups. Comorbidities, hypertension, diabetes, dyslipidemia, smoking, all the same in the 2 groups, and the same with the procedural aspects: fluoroscopy time, dose of heparin, and contrast volume. Let's come now to the results. Let's see here. If the first thing we saw, in how many patients we had success of patent hemostasis. This is something we don't discuss too much in the studies. In this study, we had a successful patent hemostasis in 88.7% of the patients in the manual group versus 82.9% in the mechanical group. So more patent hemostasis here. However, the P is not significant. Let's come now to our primary endpoint, which is radial artery occlusion, as we said. Here is, in the left, all patients. We can see that radial artery occlusion was more in the manual group than the mechanical group, 11.3 versus 6.3%. Of course, these numbers are not, the difference is not statistically significant, but as we enroll more patients, we are seeing that the P is getting lower, and we believe at 600 patients we will get statistical significance. We saw also the primary endpoint in the subgroup of patients where the successful patent hemostasis was achieved, and we can see again that radial artery occlusions are more in the manual group than the mechanical group. Coming now to the secondary endpoints regarding hematomas, these were similar between the 2 groups, no statistical significant, and all hematomas were insignificant, easy class 1 or 2 hematomas. The same with bleeding, no statistical significance, and a very small percentage of bleeding in the 2 groups. Here is something interesting in this here, the hemostasis duration. As we can see, the hemostasis time was a lot shorter in the manual group. Average time 13 minutes versus average time 108 minutes in the mechanical compression group. As you can see, as I write down here, in all 5 centers, 1 or 2, the most doctors performed manual compression. We didn't want many people to be involved in this manual compression so that there will be, people will get confident with this manual compression thing. There was also no relation between time of hemostasis and radial artery occlusion in the manual group, because we wanted to see if people have to press for a lot of time in the manual group, you know, doctors might get tired, so they press harder, and maybe that's why we have radial artery occlusion there. But there was no relation here. And the last time we checked for this presentation, because these are not all the study hasn't finished, we didn't notice any learning curve in radial artery patency in the manual group. What does this mean? We wanted to see maybe that because the doctors in the beginning, they are not very well familiar with manual compression, maybe we thought, let's see if the radial occlusion, here is manual compression, is the radial occlusion rate is higher in the beginning of the study. So here we see the first one-third of the patients, second one-third of the patients, last one-third of the patients, and radial occlusion rate is not higher in the beginning. So there is no, this is not a matter of a learning curve. So in conclusion, there seems to be a trend, although not statistically significant yet, towards more early RAOs in the manual compression group. There is no difference in hematomas and bleeding between the 2 groups, and hemostasis duration is significantly shorter in the manual group. Thank you.
Thank you very much.
Go ahead. I have a question.
Please.
Is that okay? My question is, did you give the same amount of heparin in both of the arms? And if so, you immediately withdrew the compression on the manual as soon as you started the removal, correct?
It was a randomized study. Everybody received, as per guidelines, 50 units of per kilogram of heparin. And as I showed in the figures, there was no statistical significance in the amount of heparin. But what was your second question?
So my question, yes. So as far as when you started to release the pressure on the radial band versus a manual compression, the timeline was exactly 10 minutes on both?
We have the protocol as from Duke and Durham. So we put the bracelet, we try to achieve patent hemostasis, you wait 30 minutes, and then you release 3 mL of air every 15 minutes. Okay. If you have bleeding, you have to do it again. You know, it's the...
Okay, I just didn't know if it was the same timeline, that was all. Thank you.
Any speculation about the mechanism of why manual was more associated with occlusion?
To be honest, when we designed the study, we believe that manual is better because we thought you press the artery, you check every 2 minutes for patent hemostasis, so I was sure manual will be better. And I can't find any reason why manual is worse. I thought of maybe the doctors get tired, but it's not a matter of time. I don't know.
I think a very similar finding is reported in the Journal of Cardiovascular Nursing a few weeks ago from China with 1,650 patients. Very similar. They used a bandage as opposed to manual, but it was non-device-based compression. And it has to do with the variability of the force that one is applying as opposed to the band which applies steady-state pressure.
Just a brief comment. I think this patent hemostasis is quite a dynamic process because it needs to be. So you checked it every 2 minutes in your group, whether the radial artery is patent or not. How frequently did you check patent hemostasis?
Every 2 minutes we were checking that the hemostasis was patent. So the doctor was pressing the radial artery, but every 2 minutes he was also pressing the ulnar artery with plethysmography to check that the hemostasis is patent. So you check patent hemostasis more frequently than with the device. That's why we thought it would be better, but it wasn't.
Yeah, I think that's one of the questions I would have, and I think excellent idea and excellent study. I'm surprised that your physicians are doing it because it's a very high cost endeavor, because I know how much nursing time costs, and I'm fairly sure you're better paid than I am. So because of that reason, it's one of the things that we have looked into as far as cost-benefit analysis. one of the things that I do have, like you said, a question, and Dr. Pancholi said about it, is we find that there is inter-rater irreliability because of how people compress. And we also note that sometimes there is a more pinpoint compression with manual than there is with the balloon, because the balloon is usually longer than the fingers of the person that's holding over the site, because your fingers are not the same length at the tips. So you can't hold in the exact same way that you can with the compression band.
I think that's a very good point. And, there are two processes from a physics standpoint that we have observed in ultrasound now. With proximal compression, non-occlusive proximal compression, you lower the pulsatile stress at the arterial rent, which is trying to break it open. By compressing the artery upstream, you stop that pressure wave transmission, which has a very big effect when your pulsatile stress is high, like femoral, but it might have some effect even in the radial space. And the second is what Bernadette was mentioning, which in the physics term is called applanation enlargement. So when you press on the arteriotomy hard, you actually enlarge it, as opposed to pressing lightly when you let it stay small. And the geometry of the thrombus is very important. So if your thrombus has thin structure but wide, it'll pop off easier than if your thrombus is like a nail in a hole, where it'll be very difficult to pop it off. These are simple stuff my father teaches me. He's an engineer. But I think, these matter when it actually comes to real life differences like this. Excellent study.
Any question from the audience? I must say, Anthony, I was also impressed by the results, although we participated in the study, and I think the explanations which have been heard are very reasonable to explain why you had a sacrifice of patency with manual compression, although you had a time advantage of 90 minutes difference. So it takes short, but you lose arteries. Thank you very much.
Thank you.
Again,
we do have comments because we get more ideas. Thank you very much for the
Thank
comments.
you very much. Also the comments from the panelists. And now we will move on to the next speaker. Is Dr. Lavi. And his talk is post-cath radial artery clamp time in the cath lab, the practical trial. Dr. Lavi.
Thank you very much for the opportunity to present here. I have nothing to disclose relating to this presentation. So we talked a lot about radial artery occlusion today, but just to kind of summarize, we know that it's an uncommon condition, but on the other hand, not very rare. It's usually clinically silent, but potentially significant. We don't see often ischemic symptoms of the hand, but it could happen. And maybe more important for us, that it precludes use of the artery for future procedures. And with regard to different ways to decrease radial artery occlusion, we know that if you use larger catheters or don't use anticoagulation or use prolonged compression, this increases the risk, and in our study, we avoided all that. And if we use patent hemostasis or different vasodilators, we reduce the risk, and we use those as well in our study. And overall, there is lots of variability in terms of how long we need to keep the clamp on. It seems that most start to release the clamp after more than 2 hours. In our institution, before we did this study, usually the standard time was 1 hour, but rarely even 15 minutes was used, or up to 3 hours. And we think that overall, if we start to release the clamp early, we will have more bleeding, but if we keep it longer, we will have more radial artery occlusion. And therefore, there should be some sweet spot in which we'll get a better outcome. So the aim of this study was to assess the safety and efficacy of what we called an ultra-short duration of clamp application after radial approach. This was a randomized trial performed at 2 sites in London, Ontario, and in St. Mike's in Toronto, both in Canada. And essentially we included almost all patients that either underwent elective procedure or were admitted with ACS, we require that the patients will have some sort of patency of the unipalmar circulation. So we excluded those with Barbeau type D. And also because we wanted the patient's time to, for the informed consent, we excluded patients that required urgent procedure, like for a STEMI, if they had prior radial artery occlusion or prior surgery close to the access site. The protocol included overall standard techniques, both for the diagnostic procedure or PCI. We could use either 5 or 6 French sheath. There was a recommendation to use vasodilators, usually nitroglycerin 200 microgram and verapamil 2.5 milligram. There was a standard dose of heparin that was recommended, 50 units per kilogram for diagnostic procedures, and higher dose if we performed PCI and then adjusted according to ACT. The procedure was completed before the patients were randomized, so all those interventions or different medications were unknown and completed before the patients were randomized, and we placed a clamp with using patent hemostasis. So the clamp that was used was the radial clamp, and I want to emphasize that the company did not have any role in this study. We are not studying the clamp. We are studying different times of using it. And it has a clear compression pad and adjustment knob. And we randomize the patients to either 20 minutes or 60 minutes of what we call full pressure with patent hemostasis. And patients essentially left the lab with a timer, either a timer of 20 minutes or 60 minutes. And after there was a buzz, we started using the 5-minute timer. So what you can see here is that there was a 20-minute, for instance, 20 or 60 minutes, and then I don't know if you can see on the knob there is a marker, and we turn the knob quarter turn every 5 minutes, and after 20 minutes the clamp was removed. Patients were discharged for diagnostic procedures 1 hour post removal of the clamp. We documented bleeding during having the clamp and after release. If there was bleeding and there was a need, the clamp was retightened for 10 minutes, and then we restarted to release the clamp again 5 minutes 4 times. The endpoints included the radial artery occlusion on the same day. We used pulse oximeter and reverse Barbeau, and if there was any question, we could use ultrasound Doppler. In terms of hemostasis, we used Olivier Easy Scale, and in addition, documented any types of bleeding. And we invited patients, those that live in a reasonable distance, to come back after 1 week to assess radial artery occlusion. And about 50% of our patients live more than 1 hour or 2, and so they were not invited. So these are the results. Overall, 887 patients were assessed for eligibility, and as planned, 570 patients were randomized. Almost all had assessment for the endpoints, and slightly more than 200 came back for assessment after 1 week. These are the baseline characteristics, which were very much similar, age about 64, about 30% women, BMI about 30, about 73% hypertension, close to 30% having diabetes, 15 to 20% at prior PCI before, about 10% prior radial approach, and most had Barbeau type A or B. In terms of procedural characteristics, sheath size 5 French was used in 1/3, and the rest received 6 French sheaths. No other size of sheaths were used. PCI was performed in 27%. Essentially, all the patients were treated with unfractionated heparin. We didn't use bivalirudin at all. 2 B3 inhibitors were used in less than 5%. And you can see also the numbers of clopidogrel, ticagrelor, prasugrel, aspirin, in the two groups, which were very similar. So these are the results. On the same day, when we look at radial artery occlusion, in the 20-minute group, 4.9%, versus the 60-minute group, 2.8%. This difference was not significant, but the numbers were higher actually in the 20-minute group. About 1/3 of the patients were brought back for assessment, and we see that the numbers are lower. So we know that radial artery occlusion is less after a week, but the numbers were still higher in the 20-minute group, 2.9% versus 0.9% in the 60-minute group. In terms of hemostasis, this is while the clamp was still on. We see here the hematoma grade 1. The numbers are higher in the 60-minute group, but this group had the clamp for a longer time, so they had more time to develop hematoma while the clamp was still on, and there was no significant difference. Hematoma more than 5 centimeter. Also, the numbers are higher in the 60-minute group and not significant. This is overall hematomas, including after removal of the clamp. And here we see that actually in the 20-minute group, 6.7% had a small hematoma less than 5 centimeters, and in the 60-minute group, 2.5%. So this difference was significant. There was no significant difference, and the numbers were low with regard to hematomas that is larger than 5 centimeters, and there were no more than grade 2 hematomas. Here we look at any bleeding. This can include hematomas or any bleeding that was recorded. The numbers were higher in the 20-minute group, but not significant compared to the 60-minute. And what we see is that there was more need to retighten the clamp in the 20-minute group, and this difference was significant. We try to explain why we see more radial artery occlusion in the 20-minute group, even though it was not significant. And when we performed logistic regression analysis, we found that if there was a need to retighten the clamp, this was associated with more radial artery occlusion. So in summary, what we found is that the ultra-short clamp release after 20 minutes was not associated with reduction in the incidence of radial artery occlusion. This type of rapid release required more retightening of the clamp. It was associated with more bleeding and hematomas, and the retightening was an independent predictor of radial artery occlusion. And therefore, the conclusion from this study is the still short 60-minute clamp duration is preferable compared to the ultra-short 20-minute. Thank you.
Thank you, Dr. Levy, for the excellent presentation. Comments from the panelists?
Just a brief comment. What's the total hemostasis time in both groups? So was it similar, or like what was the mean time required to achieve complete hemostasis when the clamp came off completely in both groups?
So we had the 20-minute group. We had the 20-minute release time. This is 40 minutes, as opposed to 80 minutes in the other group. Now, some patients required another 10 or 20 minutes if there was some bleeding, but those were only the patients that required retightening.
So must be less, the mean time must be less in the 20-minute group as compared to 60-minute group.
Sorry, what's the question?
So the mean time to achieve complete hemostasis when the band is taken off was less in 20-minute
well, here we didn't
group?
really look at time to achieve hemostasis because we just took the clamp off unless there was bleeding. We were not attempting to release the clamp earlier in any group compared to the time that they were randomized to.
I think, this is great proof in a way of rebound bleeding being the worst enemy of radial artery. Because once you rebound bleed, you have already put the cloth on your head and you're going to blow it up. So I think, we basically, the one thing I learned from this, which gives me corroboration, is that, you should go slower and more secure rather than faster and more sexy. So
the other thing, too, I think that's excellent point that you brought out is there is no standardization. And in running a cath lab where you are managing the sheath removal process, that is absolutely essential to reduce your complication time and reduce your radial artery occlusion and identify problematic issues. Because if you don't have everybody doing the same thing with consistency, just like with physicians, if we are not releasing the bands with consistency, we do not become as good at our profession. So I think that's one of the things that I think that I would like to see as well as standardization of a process regarding, release of bands or when should we release them or how we should release them. And exactly what Dr. Pancholi said, we had found that we started to do a very rapid release. And if they rebled, it was a problematic issue, and we know that to be a fact. So the first initial release, as long as you have patent hemostasis, then wait 30 minutes is what we did. And then after that, a more rapid process can occur, where we would then go down a cc or two every 10 minutes after that. And that seemed to be ideal because when we looked at radial artery reocclusion rates, they were less than 1%. So I think that standardization of a process is where all your staff are doing it the same way.
It's interesting that both studies which were reported this evening came to the same results: shorter hemostasis time, higher occlusion rates.
Well, I guess it depends on how short you go. Here we try to be very short.
When
we
you
still
see
use 60 minutes.
When you see the trials, the reported trials, most trials report an occlusion time, hemostasis time of about 4 hours on average, whether patent hemostasis or non-patent hemostasis. And I would like to hear from the panel, what is your usual hemostasis time in your lab, cath lab? What do you say to the nurses, to the doctors who are on duty, for example? How often should they go and how should they open the hemostasis device?
So, we have a standard order of 2 hours of compression with attention to patent hemostasis on every 15-minute basis. So we never take the band off before 2 hours, even if it looks perfect at 1.5 hours. Mostly because we obviously tried that and learned that the rebound bleeding completely destroys the whole purpose of hemostasis and patency. So we have 2 hours.
Yeah, more or less same. The problem is to keep the patent hemostasis because it's quite a dynamic process. You achieve patent hemostasis in the cath lab. And I think immediately when the patient returns to the ward area, the blood pressure and heart rate, all blood pressure drops, heart rate drops. And the thing which is patent hemostasis may be in the lab. On return to the ward immediately, when the patient is in the relaxed atmosphere, it becomes compressive. So it should be checked immediately, and we have found about 90% of patent hemostasis which was achieved in the cath lab and patient returned to the ward area is not patent anymore. So I think it's about how frequently you should check the patent hemostasis and how it's not easy to maintain it. So we check it immediately after as well, and then half an hour or 40 minutes depending on whether they have an angiography or angioplasty to start releasing the clamp after initial check.
I think that's a very good point. There is some stabilization after 15 to 30 minutes, but first 15 minutes are extremely dynamic.
Right, and we have a protocol very similar to that where our protocol is standardized. So basically, let's just talk about diagnostic because it gets a little bit more complex when you start talking about angioplasties and what kind of agents you're using. So diagnostic cath, we give everybody 5,000 units of heparin, whatever, or 50 units per kilo. The standard protocol would be to make sure you have patent hemostasis, like they said, in the lab. Then you bring the patient back. We do recheck patent hemostasis immediately afterwards in the recovery area because many patients fall back to sleep and their blood pressure goes down. Again, their hemodynamics all change, but we want the staff that are in the recovery room to take ownership of the radial artery occlusion and the radial artery patency. And so that gets checked again, and then we lead the band completely alone for 30 minutes, and then begin our 10-minute 1 cc down, 2 cc's down, and it usually takes about an hour to get the TR band off. Or the radio, our band happens to be that type of band, but the compression band off. Thank you. Very excellent.
I think it's important to also note that, even though we saw no significance, we all are believing in the directionality, which tells us that the sample size is at issue. So, these are all great preliminary signals, but obviously statistically quite falling short of what we are trying to answer.
Yeah, I think that statistically it will be very difficult to do any studies these days that will have power to reduce radial artery occlusion if we already use all the methods that we know, like patent hemostasis.
It's true. Yeah, it's becoming impossible.
Thank you very much.
Thank you. So our next speaker is a very well-known trialist and has contributed several important pieces of information. Alessandro Shivasi from Roma is going to talk about the RADIANT trial.
Good evening, dear colleagues. First of all, I would like to thank Dr. Ruse and Dr. Bertrand for their kind invitation to be part of this very interesting meeting. And in my speech, I'm going to present the results of the RADIANT study, that is an observational study aimed to evaluate the radiation dose of the operator during percutaneous coronary procedure. Interventional cardiologists are chronically exposed to a variable amount of radiation during their work, increasing the probability of a stochastic and deterministic effect. Indeed, previous studies showed an increased rate of posterior lens cataract in the interventionalists compared to controls. And moreover, previous studies show an increased rate of brain neck tumors among physicians performing interventional procedure, and these tumors are generally located in the left side of the neck and the head, that is the region most exposed to the radiation. Another important aspect is the vascular access. In many countries like Italy, the radial access is preferred over the femoral for percutaneous coronary procedure. And despite the advantages in terms of bleeding and vascular complication, some reports documented an increased radiation exposure in the radial compared to the femoral approach. And recently, a large meta-analysis showed that the transradial access is associated with a small but significant higher radiation exposure for the operator and patients. But in this large meta-analysis, despite the inclusion of 24 trials, only 4 trials included the operator radiation dose directly evaluated. And after this meta-analysis, the very trial showed that performed during diagnostic coronary angiography, the comparison from femoral and right radial access did not show any significant difference in terms of radiation dose for the operator. So we decided to perform the RADIANT study, that is an observational prospective study aimed to evaluate the radiation dose to the operator using different vascular access, femoral, right radial, or left radial, in a center that performed most of the procedure through transradial access with a high experience in transradial access. All the procedures were included, and the only exclusion criterion was the hemodynamic stability. All the procedures were performed by 4 different expert operators and 2 fellows. The operators were equipped with 2 dedicated dosimeters located at the thorax and left wrist. These electronic dosimeters were very comfortable to wear and consent to measure the radiation dose at the end of each procedure. During the study, a 3rd dosimeter was available, and in the last part of the study, this was placed at the head level. But today, I'm going to present the results of the thorax and left wrist dose. The radioprotection of the operator was ensured using the lid apron, a lid collar, lidded glasses, and structural devices as an upper mobile ceiling lidded glass and a lower table lidded curtain. Globally, 2,028 procedures were performed in 1,508 patients. And most of these procedures were performed using the radial access, only 6% of the procedure through transfemoral access. In the radial group, most of the procedures were right radial, but more than 40% of the procedures were left radial access. In the radial group, more than 20% of procedures were performed using adjunctive protective drapes, whereas in the femoral group, no adjunctive protective drapes were used. The first analysis that we performed was the comparison between the femoral and the radial axis. In the baseline clinical characteristics, there were some difference. For example, the height of the patients were significantly higher in the radial compared to the femoral group. But also the rate of patients with previous coronary bypass was significantly higher in the femoral compared to the radial group, with almost 20% in the femoral group, only 4% in the radial group, and the rate of acute myocardial infarction. Also, there were significant difference in the procedural characteristics in terms of DAP that was significantly higher in the femoral group and in number of scene acquisition, probably due to the higher number of patients with previous coronary bypass. But when we analyzed the operator radiation dose, and we have to remember that more than 20% of procedures were performed using adjunctive drapes. But when we analyzed the operator radiation dose, we observed that there were no significant difference either at left wrist or at thorax level between the two approaches. But considering the baseline difference in clinical characteristics, we performed a multivariate propensity analysis, propensity match analysis, obtaining two group equivalent. So we had 124 procedures performed in 85 patients with no significant baseline clinical no difference in baseline clinical characteristics and no significant procedural characteristics. However, when we analyzed the operator radiation dose, we observed that in the radial group there was a significantly higher radiation exposure either at left wrist or thorax compared to the femoral axis. The second analysis that we performed was in the radial group, comparing the left and the right radial axis. And in this case, the baseline clinical characteristics were significantly different between the two groups. Generally, the left radial axis was used in older patients, in lean patients, and shorter patients, but with a higher number of risk factors for ischemic heart disease, generally in patients with previous coronary bypass, and also the procedural characteristics were significantly different between the two groups. An important point is the rate of subclavian tortuosity that was significantly higher in the right radial compared to the left radial. When we analyzed the operator radiation dose, we observed that the left radial axis was associated with a significantly lower radiation dose compared to the right. But even in this case, considering the baseline difference, we perform a matched propensity analysis, creating two groups equivalent without clinical significant difference in baseline characteristics and procedural characteristics of almost 500 patients. But when we analyzed the radiation dose, we did not observe variation. So the left radial axis was associated with significantly lower radiation exposure compared to the right. At this point, we decided to evaluate the dose in the single operator. And when we analyzed the dose of the single operator, we observed a gradient from operator 1 to operator 4. And we excluded the fellows because the fellows perform almost exclusively diagnostic procedure. And so the radiation dose so low was due to the diagnostic procedure. And all the operators were similar for experience, similar for preparation of the patient, similar for experience. So the only difference that we found in the four operators was the height. And we have a gradient in the height of the operator and a gradient in the radiation dose. The taller it was the operator, the lower the radiation dose. At this point, we compare in the single operator the difference in left and right radial axis. And in the first two taller operator, we observe a significantly higher radiation dose in the right compared to the left axis. That was almost double. Also in the third operator, the medium height operator, there was a significant difference between the two approaches, but this difference was smaller than the previous two operators. Finally, in the shorter operators, we did not found any significant difference between the two vascular access in terms of radiation dose. Another analysis was to compare the use of adjunctive drapes. We compared the group with adjunctive drapes with no drapes, and we observed a significant reduction in radiation dose. Considering this very low radiation dose in the radial group with adjunctive drapes, we compared this group with the femoral group. In this case, the radial access was associated with significantly lower radiation dose compared to the femoral, but the radial group had the adjunctive drapes and no adjunctive drapes in femoral group. Another point was the effect of tube angulation. In patients who underwent PCI, we divided in two groups: patients with procedure performed using almost exclusively right projection and a procedure performed using the left projection. We observed that procedure performed using the left projection were associated with a significantly higher radiation dose for the operators. Another aspect, very important, was the effect of the angiographic system. All the procedures were performed using 4 different angiographic systems, 3 dedicated for coronary and 1 for interventional radiology. The fluoroscopy time in using the 4 different angiographic systems was almost similar, no significant difference. Also, the radiation dose for the patient in terms of DAP was similar for 3 of these angiographic systems, and only 1 showed a significantly lower dose of DAP comparing to the other angiographic system. But when we analyzed the operator radiation dose, we observed a significant important point, that the angiographic system not dedicated for coronary was associated with significantly higher doses for the operator. That was more than double compared to all the other angiographic systems dedicated for coronary. And finally, we analyzed the effect of the different diagnoses. And we observed that patients with valvulopathy or patients with acute myocardial infarction, either STEMI or non-STEMI, were associated with a significantly higher radiation exposure for the operator compared to all other groups. So in conclusion, dear colleagues, despite the high experience in our center, the use of femoral access was associated with a lower radiation dose compared to the radial access. But the use of adjunctive drapes and the use of left radial access seems associated with a significant reduction in operator radiation dose. Thank you for your attention.
Alessandro, did you guys bring the left arm over to the right side, crossing the patient's trunk?
We put the left arm close to the left leg or a little bit up of the left leg as the left femoral access.
Okay. And did you have any information available on the length of the cine angiograms in frames?
In frames, the cine angiograms, that was the number of frames.
Number of frames.
The table that was the number of frames.
So you already adjusted for that in your propensity match model.
What's the explanation, do you think, that you observed the reduction for the left radial approach over the right? To me, it seems difficult because you have to lean further over the patient, and most of the radiation they operate against is backscattering the patient. So, you're in you should be in a more dangerous position, but it's not just your trial, there are other trials that observe that.
Yes, there are different authors, so at least all other 3 authors that show the similar results. And my hypothesis is that one thing is the position of the upper mobile ceiling glass. We take a picture for our position during the left and right radial axis. In the right radial access, the upper ceiling mobile, we cannot put close to the operator the ceiling lidded glasses because we need a space for the access. Differently, in the left radial access, we can cover our body with the glass completely because we can put, we have no problem with the access. Second, another explanation is generally in the left radial access, the fluoroscopy time and the DAP is generally lower, even not significant different for expert operator, but are generally a little bit lower. And finally, another possibility is that the tube angulation. During the left projection, for example, used for cannulation of the right coronary artery, the radiation source is close to the operator. And when the operator lean above the patient, the arm of the operator and the thorax are protected by the patient, are far compared to the right radial access where the operator are closer to the radiation source. And so combining this hypothesis, I think we can explain the effect of the left radial axis.
Alessandro, one other quick thing, in the labs where this was done, what is the distribution of the preference of left versus right? Were these operators who predominantly do left radial over right radial?
No, we perform left or right radial axis almost indifferently. In general, in our center, most of the procedure performed in older patients are left, and in younger patients are right radial axis. Only the shorter operator prefer the right radial axis, but if there is no pulse or in previous bypass or for something reason is not available the right radial axis, we perform the left radial axis. And another possibility is that in the left radial axis we observe a lower radiation dose at thorax and left wrist, but we don't know in other side. For example, we don't know if for example at hip level probably the radiation dose may be higher. We performed a phantom study and we confirmed in a phantom study a lower radiation dose for the operator left wrist at thorax, but the radiation dose at hip level was higher in the left compared to the right because the hip was closer to the tube.
I think as we grow older, the left radial access is associated with back pain problems. I think for me, at least, it's not so easy to perform routinely from the left radial. This is one point. Now, a comment is and a question. In general, isn't it correct that the additional radiation dose is in the order of 15 to 20% compared to femoral?
No, I think it's more than 15.
Than 20%?
Yeah. Yes, I think it's more than 20. In our experience, it's more than 20%, but there are other studies that confirmed, and I'm waiting for the results of the RAD matrix that I'm the principal investigator of this study that are in few months are available to confirm or exclude this difference in comparing the radial and the femoral axis in a multi-center randomized trial. So this is a trial that can give some important information.
And then your opinion about the volume of each operator and the radiation dose. I'm almost certain that people, as doctors who are not very well experienced and don't have high volume examinations, they tend to be exposed to more radiation. What's your opinion?
Absolutely. Yes, absolutely. Because generally, not expert operators are also not expert in radioprojection. So they do not use adequately the radioprojection tools as the upper ceiling mobile. Sometimes I see with the fellows that they put the upper mobile ceiling closer to the wall. They do not use because it's not...
Go ahead.
You saw quite a difference between your operators there, I think. I wonder the magnitude of difference between the operators.
Yeah, there's a big difference in radiation. The problem was for the shorter operator. But the problem is also because the location of the dosimeters. For me, tall operator, the shorter operator, the dosimeters were placed lower, so closer to the patient, closer to the resonance source. So probably if I put my dosimeters in a lower position, the difference was the eye of the dosimeter. Yeah, exactly.
It's really difficult, there's so many variables to be able to.
Yeah.
When you look in the literature, there can be a huge difference between operators doing the same procedure. That can be far bigger than the difference that you observe from things like access site practice and blah, blah, blah. So the people who are good at radiation protection don't get much radiation.
Yeah.
However, whichever vessel they put.
Yeah,
that's very true. Thank you. Thanks, Alessandro. And,
right.
Our final presentation is by Dr. Alonso, and it's on radial access. Until when shall we compress? A pilot study. Thank you.
Good afternoon. I'm very pleased to be here. Thanks to the organizational committee for inviting me here. We are going to talk about a little more conservative study. This is a small study where our main concern was how much bleeding could occur after compressing different times. I have no disclosures. And since several trials have supported the use of radial approach as being safer than the femoral approach in terms of bleeding and mortality, also allowing the patient for an early discharge, the longer compressions have been associated with more frequent radial artery occlusions, and it is not totally agreed how much time the radial compression should be kept. So we decided to design this study to demonstrate that radial compression for 3 hours may be as effective as 3 hours compression. Why 3 or why 6 hours? 6 hours was a standard protocol in our center. That in most recent trials, 2 to 4 hours were seemingly appropriate. So we decided to compare our standard protocol to a new time compression. So it was defined as effective, the 3-hour compression, when it was able to stop access site bleedings with the same proportion as 6-hour compression. Another thing that was of our concern was how did the administered heparin affected the results. So our primary endpoint was the access site bleedings, meaning those bleedings that occur after releasing the compression, minor bleedings that occur after releasing the compression, that needed to keep the compression for a longer time than expected for each group. Secondary endpoints were major bleedings, hematoma, modified Barbour test response. So this is a single-blind, single-center prospective study with 112 consecutive patients, which were admitted with a clinical diagnosis of, in 11% of patients, acute myocardial infarction, non-STEMI in 39%, stable angina in 22%, and in other cases, such as heart valvular diseases, were 28%. So we randomized before the procedure to 3 versus 6-hour compression. In all cases, a 6-French sheath was used. The TR band device was used for compression, and every patient had a Barbour test performed before the procedure, and a reverse Barbour test was randomly performed after the procedure, the day after the procedure. So the number of procedures were in 68 patients, and diagnostic coronary angiogram, and in 44 patients, PCI. Our standardized protocol for heparin units are 5,000 when there is only a diagnostic angiogram, and in 10,000 whenever we use a PCI. We make a PCI. So the events such as access site bleedings that require prolonged compression, major bleedings, hematoma, extension, and the Barbour test responses were recorded. Exclusion criteria were previous lytics used in the patients or previous radial access on the homolateral side. So the results for the secondary endpoints were that there were no major bleeding, as anyone would expect, no blood transfusion were required, there was no hematoma bigger than type 1 in any group, and only one patient had a reverse Barbeau test type D in the 6-hour group. But what about our main concern, the excess site bleedings? Well, we say that 112 patients were included, 63 went to the 3-hour group, and 49 to the 6-hour group. There were 11 bleedings in the 3-hour group and 6 bleedings in the 6-hour group. What does this mean? So when we see at the 3-hour compression group, we see that there is 17% of bleedings versus 12% in 6-hour compression. This is a little bit more than we expected, but in any case, there were no statistical differences. What happened to the axis type bleeding when we compare, according to the heparin doses administered? In the 5,000 group, there was 15% of bleedings, and in the 10,000 group, there was 22% of bleedings. Well, this, again, is not, has no statistical differences, but what called most our attention was that in the 3-hour group, 78% of the bleedings were caused when they received 5,000 units. In the 3-hour group, there was an exceedingly high bleedings. Again, there was not statistical difference, but we guess that this may be because of the small sample that we included. So, preliminary data of this pilot study did not show significant statistical differences between bleedings in 3 versus 6-hour radial compression. There was neither statistical difference between administration of 5,000 versus 10,000 heparin units in terms of bleeding, and there was a trend towards more bleeding in 3-hour compression group when we used 5,000 heparin units. That was not persistent when using 10,000 units. But another study design with a larger sample size is needed for obtaining significant statistical power. So the limitations for this study may be that it's a single center study, a small sample was included, a sample of at least, after this we made a research of a calculation of how much patients we will need to maintain that proportion of high bleeding that we found at 3-hour group, especially using 5,000 heparin. And we found that at least 165 patients in each group would be needed so as to have enough statistical power to confirm that 5,000 heparin units would cause that proportion of bleedings that we reported. Heparin dose was not strictly adjusted to patient weight. It was, as we said, a standardized protocol to use 5,000 or 10,000. And we did not use the ACT either. So the main idea of the study is we think that a 3-hour compression may be as safe as 6 hours. 6 hours now, it seems too long compression, and somewhat by the recent data or trials, we think that somewhere between 2 or 4-hour compression will be as effective as a 6-hour compression and with less complication and discomfort for the patient. Thank you.
Any comments? What was the device used to achieve compression in your study?
Terumo TR1.
And when did you started releasing pressure? Like first, like how long did you give it before you start releasing pressure?
The band was completely released, the depression, after 3 hours in one group and 6 hours in each group. But it was supposed that a progressive decompression was performed. In any case, we didn't check that out precisely, and we think that is one of our main problems with this study.
Interesting. For me, the interesting point is that we don't have to fear that we will prolong hemostasis time when we give 10,000 units heparin, example for PCI. although there are sporadic patients who may require prolonged hemostasis because they bleed and bleed and bleed, sometimes we keep these patients a long time in the hospital. I think it's a matter of statistical power, because what I understood is that even not statistically significant, there are about 50% more chances to retighten the hemostasis if you choose the 3 hours limit instead of 6 hour limit. So if you choose to go earlier with hemostasis removal, you have 50% more chances, as far as I understood from your slides, to have bleeding. It means to retighten to go back to the hemostasis.
It's quite obviously variable how people achieve hemostasis after and when they start releasing pressures. It varies quite a lot. Some people will start releasing pressure in half an hour time. Some labs start releasing pressure a little bit longer, and some will leave it for a couple of hours, 3 hours, and then release the pressure quite quickly over a period of like half an hour to 1 hour, completely comes off. So Samir, question to you is, can this not be standardized? Like, what is the initial time, do you think, in each, depending on angioplasty? When should we start releasing pressure, the initial pressure? Then obviously the rest of the pressure goes like you check every 15 minutes or half an hour, 15, 20 minutes till it comes off. That can be controlled, but when should we start releasing pressure? How long should we leave it without releasing pressure on patent hemostasis?
So, the only constant we can find in this is somewhat of a constant is the pharmacodynamics of heparin. When you give a bolus, it starts wearing off within roughly 2 hours, and then it actually hits its half-life, so to say. So, and that's purely measured by ACT, not by anything more accurate. And as you well know, ACT is not very, very reproducible in a general sense. So I think there are way too many dynamic variables here to give a one protocol. I can tell you in our lab with patent hemostasis, a minimum of 2 hours is what our standard order is, for the simple reason that we have had more rebound bleeds with shorter durations, and we saw no benefit with any further long duration compression. Thank you. I'm sorry. Yeah. Thank you again, and thank you very much for attending. We'll see you tomorrow. Thank you. Thank you.